why nobody from India is going forward and becoming a member of HL7. And not only Dr. Chandral is a member of HL7, he's the person who brought HL7 to India, the messaging standards which are so important. But below the messaging standards, we have a whole lot of data sets which are incorporated into HL7. He brings along with the entire HL7 and its data set to India. And I think hopefully some of this will be adapted to India. Thank you. So we look forward to a great session here. And before I give the dais to the speakers, let me just tell that I myself spent considerable time. It's been a decade I've been out of the field, but now I'm a politician, as you can see from my dress. And so let me speak both as a health informatics professional and as a politician. India has been a very free country. In fact, we are so free we rarely follow any rules. We are very tolerant. We are so tolerant, we tolerate even the intolerant fundamentalists. We are the most diverse country in the world. We speak multiple languages. We have different religions. Our cuisines, our dress, everything is very, very different. We conduct the same puja. Today there's an auspicious day in 10 different ways in the same house and in different ways in different cities. The way we pronounce is very different, the same words, and the way we spell the same words also are very, very different. Now, standards go against our very basic culture, and we are trying to implement standards in health informatics for quite some time. But then, the good thing is we are not alone. A lot of countries have been trying to implement health informatics standards and have not succeeded too well, because it's not just to do with our culture, it's to do with something else. It is the very nature of the information in the healthcare environment, and which is very, very different from other industries like airline, banking and all. So today before coming, although I was outside the field of health informatics, I just reviewed my old slides when I was a health informatics profession, and my first slide shows 15 years ago, we could transfer money electronically from one bank to another bank. 15 years ago, we could book an airline ticket. And 15 years ago, I could even send red carnations to my friend in New York. We could electronically order flowers in New York and they'll be delivered. They will be red and they will be carnations. But even today, this is what we were talking about 10, 15 years ago. But even today meaning 15 years ago, a decade ago, we can't transfer electronic medical record from one hospital to another hospital. And unfortunately, the status has not changed. The status has really not changed because of the very nature which is very complex to implement. The nature of data, like an airline ticket or a bank account number or a amount to be transferred, the very nature of information fits neatly into databases, but the nature of data in information, in healthcare information systems are very difficult to capture and codify. So primarily, what are the standards we are talking about? There are multiple. Broadly, there are 5 sets of standards, and I think we are going to cover different aspects. One is the messaging standards, messaging between one information system and the others. HL7, EDIFACT, X12, these are the messaging system. Fortunately, the more popular and the more worldwide accepted today is HL7. And one is the messaging standards, other is the codes and vocabulary and terminology standards, mostly to do with the clinical area. It's to do with doctors. So ICDs, CPTs and things like that. So they have to match. Then the content and format standards, they also have to match if you're trying to transfer electronic medical record from here to there. Then the identification standards, UHID, patient identifier, institution identifier, pharmacy identifier, the ID standards also, they have to follow the same thing. And lastly, access, authentication, and security standards. Only if all these 5 meet, all these 5 match, then we can transfer an electronic record from here to there. And one area we have come a long way is the very first one, the messaging standards. But all others, we are way, way behind, including the simplest and the simplest of the standards, which is the ID standards. We do not have UHID for patients today. So, but I think efforts are being made. Islands of efforts and islands of excellence is there. We need to go on a nationwide basis and adopt some of these standards. The other thing about standards is there are different types of standards based on the ownership. Who owns the standard? Does WHO own it? Is it a proprietary owner? Or is it a NGO that owns the standard? And there are some risks of following proprietary standards, proprietary and copyrighted standards. You better make sure that the vision of that proprietor of the standards matches your vision and your mission. And you make sure that you don't infringe on any copyrights while following standards. The next aspect of standards is the cost of a standard. Some standards are free, like I think ICDs. Some standard you pay a price. Some standard a one-time cost. Some standards you have to pay a subscription to follow. The next thing to look about standards is some standards are international standards, some standards are national standards, some standards are institution-specific standards. So typically, I would say a lot of the clinical and the drug and the clinical terminology standards need to be international. But when it comes to drug codes, it better be a national standards. The standard should be nation-specific, because you don't have the same manufacturer in the same dose form and same dosage as some other country. So drug codes have to be specifically national standards. And we talked about it about 15 years back about drug codes. We still don't have national drug codes. Most other developed countries have national drug codes. We don't have national drug codes. Some standards have to be very institution-specific, like department name. What is the department code? These are institution-specific standards. Then you have mandatory standards. The government mandates them. You have adopted standards, and then you have guidelines. So you view standards from different perspectives. And after having viewed all these perspectives, which I think some of the team headed by Dr. Bedi have come to the conclusions you can't impose standards overnight. So the very first standard, in fact, the vision then was to introduce as a guideline, and subsequently when it starts getting followed, the government will make it a standard. And I think the first part we in India have achieved, that it was a guideline that was proposed by the Ministry of IT and Ministry of Health. And I think it's time to move on and to declare certain standards. But among all these standards, the most exciting area of standards is clinical terminology. But before that, I would just like to, this thing on a lighter note, I had a friend from Germany who visited us. And, we used to have these air conditioners, window air conditioners. And they don't fit into our windows. So they block a portion of it with plywood and fit in, because none of the air conditioner manufacturers and the civil contractors have standardized size of windows. Whereas in Germany, UK, United States, you buy a window unit and then plug it into a window, it fits perfectly. But here was the most hilarious. This German gentleman who was a partner of mine or a friend of mine, he was also in innovation and design and biomedical engineering. He was visiting India for the first time, and we stayed in various cities in various hotels. In one hotel, he opened the tap and he got hot water. In another he opened the same tap this way, he got cold water. In one hotel, the taps are opened like this. In the other hotel, it is like that. So he had to open both the taps anti-clockwise and close them clockwise. Then he had to do the other way for the other. But the last one, he was just awestruck by the innovation of the Indians. You open this tap this way and this tap the other way. The last one was you open both taps this way or both taps like this, and he just held up his hands like this. This is the country, and I make ventilators, and in ventilators, anesthetists use it And to open the flow meter, you have to open it clockwise. Now imagine if somebody opens it anti-clockwise, you'll probably kill the patient. And that is the importance of standards. Standards can save lives. The most exciting area is really the clinical information, standardizing clinical information. Reminded me of, because the clinical information is very nebulous. It's, as I told, it doesn't fit into databases, little difficult to codify. And reminds me of that movie song, How Do You Catch a Cloud and Pin It Down? Sound of Music. You can't catch a cloud and put it into a database. The nature of the data in the clinical information system is such that it's very difficult to codify. But the benefits is phenomenal. Abstraction of clinical information system into codes that fit into databases can actually trigger decision support systems, reduce errors, enhance your decision making at the clinical level. And we have not. So the benefits are just much more phenomenal. The benefits of codification starts from merely accurate information, accurate MIS, goes on to information triggering decision support systems, helps reduce medical errors. It helps institutionalize knowledge. If these group of doctors are doing something good, I can take that and put it into a best practice and put it into the system so it institutionalizes knowledge, but it can extract best practices, and actually what it does is it extracts intelligence and puts into the system. It extracts wisdom. And wisdom comes with age and experience. So the longer you have a hospital information system with the codified data, the longer you use it, the better and better it becomes. But I had exactly the opposite information. I was actually, at one point in my life, I was actually a briefcase vendor going hospital to hospital, selling hospital information system in Asia, in Eastern Europe, and Saudi Arabia, and in India. Now, when we implemented the hospital information system, when we sold, they thought, ours was the best, of course. That's why they chose us. And then we do the implementation. There are a lot of hassles during implementation, but you fight with everyone, you make friends with everyone. And ultimately, the end of 18, 19 months, you implement that hospital information system. You sometimes even get some few pats on the back. Then you walk out, and then they call you back again. And you stand in the center, and the cardiothoracic surgeon there, along with the chief information officer and the finance, the person who paid us the money, and the CEO of the hospital sits in the conference room, makes you stand up and say, this is the MIS I got. Last week, the cardiothoracic department had 15, this is the MIS, they show the printout, 15 admissions and 10 bypass surgeries. I know for sure, last week there were 38 admissions and 52 whatever. And this is the garbage your HR has generated. Vishweshwar Reddy, this is the garbage you sold us. I actually felt like Jonathan Livingston Seagull. So you take a nice hospital information system, as it progresses, garbage starts filling in. And I think the most important thing is privileges. We don't have privilege management. Anybody can put any garbage into that. If they can't find a drug, they add another drug. If they can't find a patient, they add another patient. And so a hospital, well-implemented hospital information system can actually, or well-implemented EMRs also, can over the period of time become garbage instead of becoming wise and wise. So let's hear this wise gentleman. I think they have the same mission that we all have. And I hope at the end of the session, we'll know where we are going as a country. And we'll all form our individual strategies of how to implement it in our individual institutions. So without much ado, can I call the first speaker, Dr. B.S. Bedi, to give his address and explain this. And we'll have the question and answers, if you all agree, at the end or after every speaker. In the end? Yeah, thank you.
Thank you, Chairman Vishesha Saab. A long association. It's very interesting. You see, today I am going to give you a glimpse of the initiatives which happened in India. The whole journey actually started when, you know, in around start of his 2000, from sitting in, you know, Ministry of Communication Information Technology. This dream of, you know, bringing ICT for use in healthcare started, and that was the time when, you know, I was promoting telemedicine in late 90s to beginning. And in the process, what happened, you know, I spotted platform development at 2-3 centers, 2 at CDAC and 1 in IIT Kharagpur, and we took pilots, those 2-3 states, 3-4 states. And one day my secretary called me, said, Mr. Bedi, you have set up something in Tripura, West Bengal with one platform, and Pune, CDAC, Pune system in Tamil Nadu, Kerala, and then, you know, there another one at Mohali. Supposing I want to connect one with the other, the same platform, can I talk to him? I was highly embarrassed. There was no compatibility. See, there was, because they had gone their own way, and I very sheepishly I told him, sir, no. In 2002, then, you know, he set up a high-level committee under his own chairmanship, and then set up a technical working group to suggest, you know, telemedicine standards and guidelines for practice of this e-health in India. And gentlemen, that was the journey. We started with telemedicine guideline, and so that was also a time when, you know, suddenly from Apollo Health Street, Ms. Sangeeta Reddy, he came to our office and said that the question is this: why not look at total? Gentlemen, we had begun the process, but from a wrong ministry. Ministry of IT was not meant to, you know, you know, basically, you know, involved in the use of ICT for healthcare, making healthcare delivery efficient. But it was not the proper ministry to really enforce the standards. The baton got shifted in around 2005, and task force was set up, and then again there was a standardization committee to set telemedicine standard plus EMR standards, and then Dr. Vishesha Konda was also part of it. So many of my colleagues we took, and of course that report was submitted. But today, gentlemen, I will concentrate on the initiatives which have gone in from ministry, the initiatives, you know, on EHR standards. So I will just go through this document. You know, obviously we know that why ICT it becomes important, because healthcare itself is very highly data dependent. And what is the power of ICT? Accessing data, storing data, analyzing data, and transmitting data. So this is one thing which really makes ICT for very, very relevant, you know, if we want to make those process of healthcare delivery to benefit the patient, and also to make things easier for the health providers, the doctors and all that. That is always the motivation. And what are the needs for standardization? Optimally leverage the resources, continuity of care. This is a very, very important area. And then, you know, interoperability and scalability, another this thing. And one of the most important standards in the whole this thing is, you know, electronic health record for a lifetime this thing, and then, you know, use that. This is very important. Yesterday, if you recall, in a beautiful address, Sangeeta Reddy said something about health being health sector generating a lot of data. Only thing is, if you want to draw benefits, you have to change the data to information, information to knowledge, and knowledge to discovery. This is where, gentlemen, EHR, we think will play a major role. So once we start having electronic health record of population, and which by bringing standards we are able to share over the years, then these new techniques which are coming, big data analytics and all that, they will play the role into creating those discoveries which will be very, very important for ultimate public good, to improve the health of the subjects, the patients, and come out with very best practices, evidence-based medicine and all that. Those are the key things which will happen. So what is EHR? I think this is a knowledgeable crowd. I will not go, but it is something. Health of a subject of care in computer processor form. It starts building up right from your birth and till your end, and is a lifetime record, can be, and more important is retrospective, concurrent, and prospective. So I will just go to the initiatives. As I said, you see, it was in 2005 the baton of looking at health standards shifted from Ministry of IT to Health Ministry, when they set up a national task force for practice of telemedicine in India, and also including the EMR standards. But those reports, after the task force subgroups, I was chairing the interoperability group, standards and interoperability, but somehow the standards, the work didn't see the light of the day. It was in 2010 when Secretary Sujata Rao looked at this area and set up the first standardization committee for EMR standards in India. So for 2-3 years, this committee deliberated. There were 3 working groups set up, one on codes, one on interoperability, which again I had the privilege of chairing, and also privacy and legal issues, the third task team. So after intense deliberation, the recommendations were finalized, and then it was put up on the ministry's website for 2-3 months to elicit comments and views from the public, Indian Medical Association and all that. The response was very overwhelming, especially from associations which we thought we were very apprehensive. The best comments came from Indian Medical Association, which really appreciated this effort and gave their wholehearted support. Very constructive comments came, and then Ministry of Health set up a committee in FICCI to consolidate those comments, involve more stakeholders, vendors and industry, plus key clinicians from various hospitals. And after that consolidation, intense work by that committee, again I had the privilege to chair that. In August we finalized the comments, after with the proper clearances from the minister and all that. In September, these standards were put up on the ministry's hive. They were notified by Ministry of Health. So obviously, there are category of standards required for e-health. There are so many identifiers, as chairman said. You need UHID, and also sometimes now we are talking about provider. Yesterday, provider's ID. So that also becomes big, important. Then codes and terminology, then content and formats, messaging, security and access control. See, this is another very important area which I think comes up every time and again. What is the privacy issues and all that. So I will just go through the efforts which the committee had gone. The committee studied all the standards, existing standards across the globe, and how they were being used by different countries, and all standardization organizations. So many, I am listing them here. And their applicability to India. To India, no standard was generated from our own side. We took advantage of the experiences of all developed and other countries, developing countries also, who had really gone into this exercise. So our task was what was the optimal thing for India. So that's what we had adapted. So I give a brief list of the codes which or standards which have been notified and accepted. This is very important. That the list of standards. I think you can, if you go to Ministry of Health's website, you can have detailed report available at in Ministry's website and look at those standards. As Chairman said, messaging standards and imaging standards and clinical data format. So basically 13 major standards have been notified. And also we thought that some of standards we didn't take, we thought that we will take up in the second phase of this particular development, because the standards were considered as a living document. Also, in that those standards, a minimum data set to profile a disease was also suggested, that which also gave basic minimum information which should be captured for creating an EMR. So, and then further resulting in a EHR. See, this is a topic I think which has been brought out again and again in previous yesterday's discussion. Ownership, security and privacy guidelines. See, this particular standard, EHR standards, deliberate on this issue in detail. And of course, they are not called standards, but we have taken them as the guidelines which should be followed either by the health, the health providers and other things. And also, ownership of the record. Who owns the record? So that also has been very clearly mentioned in these EHR standards notified by the government. Threat sources, EHR security mechanism, ethical and legal considerations. And then in this regard, I will mention another thing. This is a very, very contagious and very important issue. So Ministry of Health has now set up a fourth subgroup under EHR, National EHR Standard. It is called legal subgroup. So they are now framing a particular way in how to take up these things and make them mandatory. So those that legal group is really acting, and only on Wednesday I had that meeting from Ministry of Health, where we have done the background work. We have studied all countries' legal issues, which people have really taken up in their EHR standards. After consolidation, a legal house is being appointed to make the whole guideline into a form which can be taken up as a mandatory condition. So this deliberation is going on. I will again give one particular very important thing. It was again briefly mentioned in yesterday's deliberation. See, a Clinical Establishment Act has been notified, and it is a law. For registration of any clinic, practicing clinic, it has now been mandated. The registration is subject to clinics adapting EMR, that they should have a EMR. So this is a part of a Clinical Establishment Act, and registration also will depend on it. Only thing is, it has to be accepted by the state governments, because health is a state subject. So basically, when clinics are adapting this, so we hope they will follow the standards also. Okay. And you see, again, national e-health authority is also being set up, which will oversee not only implementation of and adoption of these EHR standards, but a lot of other things. And then, to promote whatever recommended standards, India has become member of IHTSDO, so that nobody who wants to use a very important standard, SNOMED CT for clinical terms, they have to pay anything. And see, already Ministry had recommended to FICCI that they should have a India Health Information Network which has set up guidelines so that they can keep advising Health Ministry on what should be further done in these standards. And also, again a national committee has been set up under Ministry of Health to do the first updation of the suggested notified standards. So we again, that committee is also very active. This is depending on that FICCI's IN committee also. And I can tell you, gentlemen, a small subgroup, myself and Mr. Sundar Gaud and another gentleman, we have been given the onerous task of suggesting the first draft of the upgraded standards. We have more or less finished that work, and very soon the committee will examine, and again that will be put up next year or December on the ministry's website for further comment.
Dr. Bedi.
Thanks. Thank you.
Thank you, Dr. Bedi. Thank you. And is there a website? And I guess. So thank you, Dr. Bedi. And we look forward to seeing all this happen in the next 6 months. Yeah. So now we have Dr. Sabadikari and Dr. Please.
Thank you, Honorable Chairman. I think you did a great start to it. So what I feel is somehow or other when we are talking about standards, there is a lot of confusion. I mean, the good thing about standards is there are so many of them. That itself could be a big problem. So I'll skip the obvious slide because I think here everyone is aware of this. But this is one figure which I feel could be of some help. I mean, if you look at the types of standards, there are different types of standards and there are different groups of standards in each of the fields. So whether it's for a clinical interface or for reference, or reporting, when you're giving the rules, the way you want to categorize the information, health information or medical information, you actually need a different set of standards. So all standards are not the same. And even within the same group, if you see, there are more than one standards because the objectives with which the standard developing organization had set forth may have been slightly different. So where does that lead us to? If you look at the broad categories, and this has already been stressed upon by Honorable Chairman and Mr. Bedi as well, I am not talking about the identifier standards because they could at most be nation specific, they can't be global. But what we are very concerned about are the global standards. If we want to really have an health information exchange in this global village, we need to be very careful about these things. So the first one is the vocabulary standard. Vocabulary is something very funny. I mean, what is C. larynx to a doctor, maybe laryngeal malignancy to another, or laryngeal carcinoma to another. I mean, the same thing can be said in so many different terms. And all the clinicians may be understanding it, but anywhere in between where the message is being transferred, it may be ambiguous. So vocabulary is definitely the major area. The next part is the content exchange. I mean, what content we are exchanging. It's very important to know what we are exchanging. Often, as you say, we may have institutional codes. Say we categorize male as 0 and female as 1. Sent to another institute, another hospital where it's just the opposite. So where male is 1 and female is 0. There could be another group where there's a third gender. We simply cannot exchange this content as it is. Next is the transport, and the fourth is the privacy, security, confidentiality. I won't deal much about those, but as you have already been told, there are issues related to that. So if you look at the common vocabulary standards, these are the controlled medical vocabulary, and there are, again, quite a lot of them. The WHO has the stable of ICD standards, and in fact, we are progressing so fast, ICD-11 is also just around the corner. It's expected by the end of the year. So I think from 1st October, the US is moving to ICD-10, but by December, ICD-11 will be available. So ICD-9 is way behind. It's historic. And why has there been a new addition? Because there were some shortcomings which couldn't be addressed by those. Incidentally, ICD-11 will be one-to-one mappable with SNOMED City on LOINC. In fact, SNOMED City and LOINC would be one-to-one mappable. SNOMED City and ICD-11 would be one-to-one mappable. So in a way, maybe in a couple of years, we'll have more harmonization. SNOMED City, we have two eminent speakers here, Dr. Karanbir Singh and Mr. Gaur Sundar, who would be dealing with different aspects of SNOMED City, so I don't have to say anything on that. Next part is the content exchange standard. And here again, the two most well-known standards are HL7 and DICOM. Now, HL7 started with, there was no version 1, but the version 2 was there. That started way back in 87. Then the version 3 came. In European countries, version 3 is more popular, whereas US, Australia prefer the version 2. 2.8 is around the corner. But HL7 also realized that these are not serving the purposes that it was meant for. So they have come up with a new concept. It's a new look strategy. They call it FIRE. What is FIRE? I'll come into that. They're not calling it HL7 v4.0. But in a way it is. I'll talk more about it later. The other one is DICOM. I think all in imaging are very familiar with it. In the transport standards, I think SOAP and XML, these are the well-known ones. Security also, as I said, I won't go into it. But I'll talk about this content exchange standard a bit more. I hope Dr. Chandil won't mind. In fact, he has been, in fact, HL7 India didn't start very long ago. Initially, it started somewhere in 2000, but it was almost dormant for 10 years. Then I became the second chairman of HL7 India. Then Dr. Lavanian came, and Dr. Chandil is there now. So we have tried to move HL7 India forward. HL7 headquarters, international, is doing a great. If you look at HL7 version 2, v2.x, so that was mostly in the communication layer. So you had the interaction and message models. So HL7 v2 was dealing with message models. When version 3 came, that was in the objects layer or the information model. So you have the RIM, the reference information model, and the document, that is the clinical document architecture, CDA. What is FIRE doing? FIRE is an acronym for Fast Health Interoperable Resources. So it is actually going in the SOA domains. It's a service-oriented architecture. You have got small building blocks. You pick and choose. So whether you want to use a particular thing, use only that. You need not go into the very extensive version 3 CDA if you go into it. It's a very extensive module. But FIRE, they're trying to break that. So you pick and choose your modules, and then you use only that much which is essential for your purpose of health information exchange. DICOM, again, I don't have to say anything about it. Now, one thing which is there, which I talked just now, so before I end, I need to stress on this. Now, suppose there are different standards. Let's take the commonly used ones, the well-known ones, HL7 and DICOM. Now, HL7 is communicating between the HIS and RIS. Because HL7 deals with the clinical and administrative data, which you get in the hospital information system. If you give an order for some imaging, it will go to the RIS or radiology information system. DICOM, on the other hand, will be communicating between RIS and PACS for images. So you have a picture archiving and communication system. There, DICOM will work. If you look at this, these two standards operate at different levels. And obviously, they don't talk to each other. So if you need to have a communication, if you need to have seamless exchange of information, you need a broker. So one of the players in this field is IHE, Integrated Health Enterprise. So they have scheduled workflow, for radiology, the example I'm giving. So that will integrate this ordering, scheduling, imaging, acquisition, storage, and viewing activities associated with radiology exams. So once you are using this scheduled workflow for this radiology, then you can use HL7 DICOM without having to think over it. How do I make them talk to each other? So this is just one of the examples, and there are various such efforts going on globally. India is a new player in the field, but definitely we are trying to learn from the others' mistakes rather than repeating those ourselves. So this is the IHE website, and that brings to the end of my slides. Questions, as the chairman said, we'll take at the end. Thank you.
Thank you, Doctor. Thank you for illuminating us. We'll have Mr. Chandal Kumar, Dr. Chandal Kumar, on HL7. Please, Doctor.
A very good morning to each one of you here. Every year, the Government of India conducts, the Union Public Service Commission conducts an examination to select about 400 to 500 odd best talents in the country to help run the nation. And I'm given to understand that they have a compulsory history paper. And one of the very repetitive questions they get to hear is, what would have happened if the Britishers had not invaded India? If somebody were to ask me this question over breakfast today morning, my answer would be very simple. I think there would be a startup of English translators and would give Flipkart and Snapdeal a good run for the money. And if somebody would ask in the same context, what would have happened if HL7 was not there, I think we'll have 100 odd questions. My answer again is a little funny here. Maybe we would have police stations and courts in each of the hospitals to choose who's right and who's wrong and what went wrong in between. So ladies and gentlemen, today I'm going to spend the next 10-15 minutes to give you a very basic overview of what is HL7, what is HL7 International, and what are we doing as an affiliate, HL7 India as an affiliate is doing in the country, and possibly touch upon what looks like to be the future for healthcare IT with HL7 in the context. With this, I think I'll move to the next slide, which says HL7 International is a consensus-driven standards development organization. I think everybody on the podium has spoken how difficult it is about standardization. I think it is doubly difficult to have a consensus around standards. Hundreds and thousands of meetings are held across the world to get consensus for the standards. Likewise, there are tens of meetings that are held across the globe for consensus for HL7 standards as well. So this gives a sanctity of uniformity and acceptance. So what works in one context might not definitely work in the other context, but yes, it is given to understand that a lot of factors are considered before driving out the standards. Unfortunately, HL7 India is still not come up with India-specific standards, but we are moving towards the direction and we are trying to come up with India-specific standards to be adopted by the relevant stakeholders. So all of us know what HL7 is, but I think not many of us know what actually it means in terms of a technicality involved. So this slide explains there are 7 layers of transport that happens. If I were to take a LAN cable and connect 2 systems across, that's the physical layer. And if I were to transport a pocket of data, that becomes a data layer across a network. Likewise, it goes all the way across even to a session, a presentation, and an application layer. So HL7 standards cover the last mile involvement, and it is a application to application connectivity. I'm sure this slide is the most abused or the used one. I think everybody has spoken about scope of standards. What is pertinent and relevant from HL7 is, yes, one of the slides from Supten also had an HL7 DICOM overviewing and harmonization between standards. This is where the HL7 also plays a role to bring in relevant parts to be interconnected between disparate systems, even among standards itself. Let's say between DICOM and Snowband, if there is a scope to be integrated, I think HL7 has a definitive role to play there. Yeah, I think this is the slide which is been inspired by a very famous poem, if doctors differ, patients suffer, from a 1843 slide. I think we are no different. If technologies differ, I think the patients still suffer. I'm just keeping the doctors out. So I think even with technology, it has to come to a talking terms to convey the right thing again. So who and where is HL7 International? This is definitely, since its origin in the 1980s, this is headquartered in US, and this is a not-for-profit volunteer-driven organization. And it has its various stakeholders who are not only the guys who make the standards, but are also the people who use the standards. So 38 affiliates across the globe. You can see India out there. So we have been one of the very active affiliates. We have 100 odd members today with about 20 institutional members. And we are the highest certifying agency in the world. We do about 60 certifications per annum, which means we not only enroll members, but also certify them being on their conformance to passing the test, be it version 2.3 or version 2.6. And we are also now getting into understand to see if we can roll out certification for FHIR. So as an affiliate, we are an independent legal entity. We are a Section 25 company, which is having a permanent office based out of Bangalore to run the day-to-day activities. So we have been influenced and driven. HL7 standards have been influenced and driven by the governments. I think it's very heartening to see the government of India, through its Ministry of IT and Health and Family Welfare, has permanent bodies to enforce standards. And we are also being influenced by vendors. We are being influenced by clinical users, the end users for whom it is meant, and definitely the terminology experts, the ontology experts. And we are all keen to see what we can do along with NEHA and EMA standards committee with the government. And the users, of course, as I mentioned, again, globally it includes a lot of healthcare professionals, including the NHS, for example, or the other governmental agencies and the health agencies across the countries. And I think this is a very pertinent slide for us to prove directions on what is happening at international level. The standards provide for interoperability that improve the care delivery. I think today is the world where the transport has got its importance as much as the content. The pizza boy who delivers the pizza to you, or the Bansals who deliver the packages themselves. For those of you who read the newspaper today, the promoters of Flipkart have been delivering the packages. I think the transport has today come to an important aspect itself. So, and optimized workflow, I think this is where we have a role as an adoption body to see how much ever can we cut down on the redundancy and improvise on the efficiency of the system. And knowledge transfer, enhanced knowledge transfer among all the stakeholders, including the end user, the patient in question, and practically put our willingness to needs of the stakeholders as the primary objective of the organization. This is more important because, there's so many components which don't work in tandem. They work in opposite direction. This slides explain how there's so many disparate systems. Though we talk about information system being the panacea for half the problems in healthcare, I think a lot needs to be done to put them in tandem, to move them in one simple direction to optimize the efforts. So the market definitely needs a faster and meaningful implementations, tangible syntactic and semantic interoperability. I think this is a big topic of interoperability which all of us have been talking about, and a lot needs to be done in this area. And continuity of care across facilities. Mr. Vishweshwar Konda definitely spoke about it. You move to one hospital to another hospital, you need to still carry your records and briefcases and perhaps files. And to ensure in the process confidentiality and security and harmonization with other standards and support the latest communication technology. FHIR has come as a result of a demand for a mobile and cloud-based technology. So I think HL7 is also equally responsive to understand the needs of the communities and come up with appropriate adoption of the technologies. And these are the various working groups. There are more than 65 working groups. We worked in each aspect of healthcare. It could mean as clinical genomics, or could be as non-clinical as policy advisory. So I think this is the extent on the expanse of HL7 working groups, which makes it to work in cohesion with each of the other working group. So this, I think, is in my view going to be the future of healthcare informatics along with the way it's going to cloud. There are a lot of devices which track us. I think a lot of us here would be also using Fitbit, which would definitely monitor what you're doing, how many calories have you burned, what is your workout, and to how much of sleep you have lost over the night, which would move to an application which would talk with the services, which would connect. All this to be seamlessly connected needs a messaging platform, and I think there could be no better platform than HL7 to get this to a logical end. This is the website where you can find a lot of interesting articles which are more technical in nature. For those of you who are interested, can definitely go and check on the website. And I would like to end with a 2-minute video wherein I was a part of the project in the US where we used...
Can we see the video in the end?
Yeah, and this is the last slide, sir, any which ways.
Yeah.
Okay, thank you.
Yeah.
Okay, in that case, this becomes my last slide where I think all of our efforts are towards embracing patient relationship and to deliver better patient care. Thank you.
Thank you, Doctor. I think the most challenging is codification of clinical data. It needs to capture the severity. It needs to have the clinical specificity and the appropriate level of granularity. It can't be too fine, which is user unfriendly. It can't be too granular, which does not capture the detail. I think SNOMED comes close to it. Dr. Karanveer Singh, can you explain us the SNOMED CT system?
Thank you, Honorable Minister. This is normally a topic that I cover in 2 days, but I've been told I have 10 minutes for it. So I'm going to just show you the skeleton. In fact, just a few bones. Now, as you can see, it's a short form. That's the full form shown over there. People say it's new. Is it really going to come in a big way? But if you, where's the pointer? This one? Oh, yeah, okay. Yeah, so, well, this pointer doesn't work. So as you can see, it started in 1965. A lot of us were not born at that time. But it started off with the College of American Pathologists, and then they brought it down, and in 2000, they introduced logic into it, which is currently the thing that makes SNOMED very powerful. Simultaneously in UK, Dr. James Reed, who was a GP, was developing clinical terminology, clinical codes, but they were a bit haphazardly organized. And then in 2002, the College of American Pathologists and the NHS UK got together, and they made SNOMED CT. The IHSTO, which currently manages it, was formed in 2007. And in 2014, as you can see, India became a member of the IHSTO. And the reason why I have put both in the same color is that when we became a national member, we became part owners of the IHSTO. So it's like being a shareholder. So because of that, SNOMED CT, although pretty expensive, is free for use by all of us, whether it's an individual or an organization, whether it's public or private, as long as the final source, the final destination of the product is within India or another member of the IHSTO. So most of us own smartphones, and this is one study that showed what we use smartphones for. It doesn't matter if you can't read, but basically it's all requiring data connectivity. But now if you imagine you remove the internet connectivity, what can you use it? It becomes a dumb phone. You know those old Nokias? So you can use it for voice calls, SMS, camera, a few games like Snake. That's about it, really. So the EMR alone is like a dumb phone. I'm not saying EMR is dumb. EMR is very good. But compared to what SNOMED can deliver, SNOMED is what gives you the bells and whistles, what converts a dumb phone into a smartphone. So what does SNOMED do? It connects across. So we've been talking of interconnectivity. That's really the call of the word nowadays. That's what connects EHRs across different hospitals, across different countries. Plus, it does a lot of things more. It is clinical terminology, not coding system in a sense of not a statistical coding system. So we will see this in more detail. It has very granular details. That means every disease, every variation, every minor variation of a procedure is covered over here. It provides very clinical, powerful analytics, far more than you can do otherwise. It supports clinical decisions, so intelligence. It's got a fair amount of medical intelligence inbuilt into it. And it is used in over 15 countries. As of now, this is the best clinical terminology and likely to remain so for the next decade or so. So we are going to see how it's better than some standard healthcare coding systems. So we're going to compare it with ICD-10. It has more clinical terms. So take one example, ectopic pregnancy. There are 5 codes and 5 terms in ICD-10, but in SNOMED, there are so many. Every variation of ectopic. So when a doctor is trying to code something using ICD-10, and if he does not find a variation, he doesn't like it. And that's one of the reasons why doctors are not using EMRs, they're not coding. One of the many reasons, of course. Here with this, it is very unlikely that they will search for something and not find it. It has multiple ancestors. SNOMED has multiple ancestors, unlike others. So what does it mean? So let's look at one problematic example in ICD-10, pneumonia. So pneumonia is infection of the lung, so consolidation of the lung. So if you look at it, the first 3 codes say that it's an infectious disease. The first 3 have been classified as infectious disease. The subsequent 6 have been classified as respiratory disease. But actually, they are both. But with SNOMED, you can have multiple parents. So like in this, there was only one parent. You could either be an infectious disease or a respiratory. You couldn't be both. But here you can. So on the right side, you can see it's classified as an infection. On the left side, it's a lung disorder. And it goes up. Another problem with ICD, it's running out of codes. So if you look at the right lower corner, so if you see the last one, ureterocele. So if doctor wants to diagnose a ureterocele and he wants to enter it, what prints in the final summary is other specified diseases of the kidney and ureter. So you imagine putting this in the final discharge summary of the patient. It really doesn't make sense. And those 5 or 6 codes below, all of them belong to the same category. SNOMED CT has no such limits. Why? Because the codes are independent of the classification system. So there is hence no sharing of code. Every single condition has its own code. So if you look at the current existing systems, you can just look at the green parts and you see each coding system. So the first column is ICD-10, then ICD-10 PCS. Each one covers one area or at the most 2 areas. But if you look at SNOMED, it covers all. But don't think that just because it covers all, it's powerful. There's a fair amount of medical intelligence within it that actually is the main power of SNOMED. So the question obviously comes is, will it replace ICD-10? Well, it will certainly replace a lot of clinical codes like NANDA codes. It may even replace LOINC and all that. But with ICD-10, it's a yes and no. So clinical modules, it should replace your ICD codes. So doctors should never see ICD codes. They should see SNOMED codes. But the government of India requires, and the WHO requires, that all information is sent to it in ICD-10. ICD, well, it's 9 or 10 or 11 next year. So those also will have to be used. So the medical records will have to use it. So somewhere in between, we'll have to do a conversion. And yes, there is an automated conversion, or rather a semi-automated conversion mechanism provided within SNOMED CT. So just let's look at a little bit of nuts and bolts of SNOMED CT. So here, as you can see, 1, 2, and 3 are 3 different conditions, and number 4 are different terms for the same condition, right? So each condition, like I've written at the bottom, each clinical idea, each of them is a clinical idea, is called a concept and has a concept number. And you can see these concept numbers are long and random. They're not like the ICD codes I10.4. No, they're not like that. They're just random numbers, really. And not only that, they have different terms attached to it. On the left side, you can see English. On the right side, has Spanish. So if I'm going to transmit a patient's information from here to Spain, I'm transmitting the number. But what the doctor sees at the other end is automatic Spanish terms popping up on the screen. So it's truly international in that sense. And when I'm going to do my connections and relationships, like viral pneumonia, is it an infectious disease or a respiratory disease or both? I can just draw with a pen, a red pen, and I can have my connections and then convert these to numbers and have it in what's called a relationship table that is provided with SNOMED. And because of this, I can have multiple parents because of this, because I can draw any number of lines. So if, in summary, till now, is that each clinical idea is a concept and has a unique concept number. Each concept has multiple terms for it. Like we saw that for myocardial infarction, there are so many. There's a heart attack, there's a cardiac infarction. There is no limit to the number of concepts. You just keep on giving numbers, and numbers are huge. So 2 codes don't have to share. And concepts can have multiple connections. It's almost like a cobweb. Everything connects to each other. So it's multiple connections. Plus, there are other relationships which bring the power of SNOMED CT. So let's look at an example. So in the middle of the screen, I have cellulitis of the foot, which is a disorder of the foot and also is a cellulitis. So two parents. There are some other properties. So for every single concept, this is the single thing. So there are 2 properties over here. There can be 10 properties also. So one is, what is the condition on the right side? It's a cellulitis. Where is it? It's a foot structure. Right? Now, let's look at 2 children of cellulitis of the foot, cellulitis of the heel and of the toe. There are many. There's some 15, 20. I'm just showing 2. They also have properties. What is it? It's a cellulitis. Where is it? It's a toe structure. And toe structure is linked to foot being a part of the foot structure. See, these linkages, we are building a cobweb. Same thing with cellulitis of the heel, it's a cellulitis. And where is it? Heel structure, which is part of the foot structure. Now, why do we have all these connections? Because if I want to say, show me all conditions involving the foot or any part of the foot structure, I just have to look at foot and say, show me anything where the finding site was foot and also where the finding site was any of the children or the grandchildren of foot. Simple, straight, clinical analytics. Right side, we have cellulitis. Show me all the cellulitis. Now, you may say it's very easy. All I have to do is, even with ICD-10, I just fire a query saying where contains cellulitis. On the left side, you have all the things with cellulitis. But with SNOMED, because of the additional connections, you also have the thing on the right side. None of them contain cellulitis, but they are cellulitis. You would never pick them up. In fact, if the clinician sitting over here, half of them will not even know that half the conditions on the right side are a type of cellulitis. What is beat knee? What is seal finger? They are all cellulitis. So SNOMED knows that. So if you ask SNOMED, show me cellulitis, it actually goes into and says where associated pathology was cellulitis. Show me all of those. May not contain cellulitis. So your clinical retrieval is much better. And because the clinical retrieval is much better, you can have decision support. The decision support itself, algorithms will be part of the HIS, but SNOMED is going to provide the data. So I say I've got patients with CVA, a stroke coming up. I need to consider them for thrombolytic therapy. So what do? I just say, show me where the diagnosis entered by the doctor is CVA or any of the descendants of CVA, which may not even contain the word CVA in it. As soon as it pops, as soon as the answer says, yes, it is one of those categories, up pops a warning saying, or a message box to the doctor saying, please consider thrombolytic therapy. I want to look at patients with breast cancer because I'm doing a trial on a new breast cancer drug. So infiltrating duct carcinoma is entered. The system knows, SNOMED knows it's a type of breast cancer. Up pops a pop-up box.
Doctor.
Just 2 more slides? Yeah, okay. And then it warns if I can look at for diabetes or kidney disease and all that. So how do we use it in a hospital EMR? So if you see the box on the right side, that's where vendors have a problem in populating data. SNOMED contains all the data. So if I want to say, a foot surgeon says, show me all the foot surgeries only in my drop-down box, I say, okay, operations on the foot and all the descendants of the foot. So that clinical information is there in SNOMED, which is not there. And I can populate any other box like that. So will clinicians benefit from it? Yes, look at all these terms on the left, on the upper part. They're all the synonyms, but the doctor in ICD searches for it, he doesn't find it. He only finds calculus of kidney, but with SNOMED, you'll find everything. Synonyms are not the only thing, they even have short forms. And this, if you look at this, I will stop over here. If you see on the left side, this is what the doctor wants to type, and in ICD, this is what comes out on the right side. So the doctor wants to say, this patient has achlorhydria, but what comes out is, this patient has other specified diseases of the stomach and duodenum. No, ICD is not good for doctors. So in summary, it supports the EMR, it's very clinician-friendly, multilingual, powerful analytics, and augments the decision support. Right? That's 10 minutes, I hope.
Thank you, doctor. Thank you. Thank you for explaining the accuracy, the clinical specificity, and the fine granularity that SNOMED presents as opposed to ICD. But doctor, one thing I think for sure, without any doubt, is if we cannot implement ICDs, we definitely cannot implement SNOMED. So I hope the next speaker will will explain certain challenges or the practicalities of implementing SNOMED in a clinical environment. Thank you.
Thank you for the opportunity. It's an honor just to be in the room and to speak here. It's like having your most favorite icing on the most favorite cake that you can think of. So this is what I will present for about more than 1.5 years. I have been working with the National Release Center, and I'll tell you what all we do. But one of the important aspects of bringing standards to India is to help people adopt, and that's what my division does in CDAC. So Dr. Karanveer Singh has already covered it, and therefore there is not much for me to say here. Basically, yeah. IHTSDO, just to give you a small brief, it's an organization created for public good. It is owned by its member. Only countries can be member. That is what the charter of IHTSDO say. Individuals cannot be a member. They can be advisor, they can be associates, etc. But it is owned by countries. And therefore, the member, the entire organization is governed by the management board, which is directly kind of overseen by the General Assembly. And the members of General Assembly are direct representative of the government of the country which is a member. It has various other governance bodies. So basically, India joined in 2014 April. The whole purpose was that when the standards committee that what Mr. Bedi was referring to, they came to understand that standard needs to be adopted. The one challenge that was, how do you get the best? And if SNOMED City is best, how to ensure that nobody has to do an extra effort to get it, and therefore somehow bring speed in the implementation. And that was one consideration that drove Ministry of Health to get India to become a member. And my division was created in September 2014 officially to help in the process of adoption. So this is the benefit of SNOMED City, which Dr. Karanveer Singh ji have already covered, so I'll just skip it. Now, in order to implement SNOMED City, the first thing which everybody is immediately focuses on and gets a feeling that it's pretty daunting is that it is huge, yes. Because if it covers everything what Dr. Karanveer Singh ji is saying, what he said a term saying, it is very rare to not find what you're looking for in SNOMED City, then it has to be pretty large. Obviously, it is many-fold larger than any other coding systems that you have seen. So on the left side, what you see are the 19 top-level hierarchies under which the codes are assembled. And to give you a little bit of detail, it has everything from clinical findings, diseases, procedures, etc. There are about 365,000 unique codes available in SNOMED City. And if you add the descriptions and their combination, it's more than 1 million entries in a system. Just to have a coding system like that into your database is going to be a challenging issue. Then there's a whole point about how do you use it and how do you transmit it. Now the good thing is that SNOMED City not only comes, the entire thing comes in a set of text files. And these files not only have columnar entry, but they have concept ID, their descriptions, but they also have linkages. And as Dr. Karanveer Singh ji was pointing out, the linkages are one of the most powerful thing in the entire SNOMED City. Thankfully, the packaging that you get is basically in terms of these three kind of important things. What you get are concepts, which are basically numbers. Then you get for each of the concept one or more descriptions. And for each of the concept with other concept, you have one or more relationships. There are even different types of descriptions, out of which one to choose that you can decide. The good thing is that since the descriptions are delinked from the concept themselves, you can have a translation file anytime. So you can translate the whole thing into a different language. Then SNOMED City can be expressed in two ways. One of them is what is called the pre-coordinated way, which is basically what you're looking for. There is a explicit code available already in SNOMED City. Then the other one is where you go for post-coordinated expression. Everything in pre-coordinated expression is available already. Post-coordinated expression is a combination of multiple SNOMED City codes to form a larger expression. In fact, you can say a whole paragraph in just a post-coordinated grammar. Everything that you have in pre-coordinated world can be expressed also as a post-coordinated grammar. Then SNOMED CT is, obviously if you have something so large, you'll want to know exactly which ones to use, and therefore they have something called subsets and ref sets. We are trying to come out with 5 subsets initially, which Government of India is interested in, but there are many ref sets and subsets you can create. In fact, you can create your own ref set within your own implementation. That is also possible. You can have ref sets specific to a disease, specific to an anatomy, specific to an organism. You can also have specific to a whole hierarchy. Then you have extensions. Obviously, SNOMED CT is not complete, and many countries want to have specific entries into SNOMED CT, which is more of a prevalence in their own country. Sometimes doctors want to use a particular way to say something which is not available in SNOMED CT, and SNOMED CT editorial team thinks that it is not necessary to have it because you can express it in a different way. So then countries can come up with their own extensions. Even an implementation, so a vendor can also have its own extension. However, please understand that there is a complete way of doing a ref set and subsetting and as well as extension. Nobody can just start adding something into their own database. It follows a particular logic and a particular mechanism. You can also submit requests to ISGSGO from time to time saying that I've realized that these extensions are necessary, and the editorial team, when properly addressed and voted, they will basically include it into SNOMED CT next release. A new version of SNOMED CT comes out every 6 months. Yeah, and then there are cross maps because you have other coding systems. You have SNOMED CT to ICD, you have SNOMED CT to LOINC, and that kind of maps are already available and they are being enhanced as we go along. So what are the technical views? If I am a technologist and I want to look at SNOMED CT and I don't want to get inside what and it is how it is, then I am mostly interested about how it is organized and then how can I use it. So SNOMED CT, the entire international content comes as a bunch of release files. And these release files, like I said, are a bunch of text files. They are about more than little more than over a gigabyte in size. But they are columnar data, and you can simplify one single command called read from file and embed it into an RDBMS of your choice. In fact, at SNOMED CT, we create at CDAC, we have created a component called CSNOTK, which is a SDK built in order for you to use SNOMED CT, which has a tool called DB Maker, and there you can simply point which database, and you can point where are the files kept. It will automatically populate everything into your database. There are 3 types of files that are there. One of them is a snapshot, which is basically only the active ones which are going to be used at any given point. The full contains even the historical entries, the inactive entries and everything. You basically do not use full in a live environment. It's mostly for research. And then there is delta, which basically say what has changed from the last release to this release, so you can just use it as an important entry. So how can it be integrated? It can be integrated as a code system, so you can use it for storing clinical information. You can use it as an interface terminology, so you can give a drop down, or you can give a search text. So basically people can simply start typing and you can search into your database to see which is the one which is matching what doctor is trying to say. You can use it as an indexing system because once you already have data, then you can pick the keywords in your databases and check relevant entries into SNOMED CT and index it properly so that you can do analysis later. You can use it as a common terminology because you can use it inside HL7, you can use it inside DICOM, you can use it inside CCD, so it can be a common language of semantics between record exchange. You can also use it as a dictionary. You can query it, you can analyze it, you can build it into your report, and you can also link health records together saying that all the clinical records for this disease, and you can index it separately and keep it using just SNOMED CT. These are some of the examples of how integrating SNOMED CT would look like inside your application. One of them is a search, in which you type search and you have some kind of criteria as to how the search should happen. On the other side, you can have filtering, which is by hierarchies and etc. You can use it for data entry directly, and in fact, it's a good idea to do it because there are 2 ways. One of them is that you give your own drop downs, which is language set which is acceptable by the hospital, or you let people enter everything from the SNOMED city itself. You can use it for everything from observation to all the way to specific conditions. Yeah.
So, Doctor,
Yeah.
so you actually have a series of questions.
Yeah.
And quite a few seems to be directed at you.
Okay.
So if you wrap up, you can also
we're
answer
just
some of
done.
those questions.
So I think I'll just skip this because Dr. Karanveen Singh is much better, experienced than me to tell you how to use it in practice and how it will benefit EHR systems. But yeah, these slides are there, and I hope that when this presentation is available from the organizers, you can look at it yourself. Just to tell you an India update, most probably this will be answer some of the questions that you already have. You already have 74 affiliate licenses issued within India, out of which half of them are commercial vendors. Remaining are a combination of students, researchers, and organizations like government bodies, etc. We have already conducted about 6 workshops across the country, and this year we are planning to take it to state governments and also direct institutions, so maybe we'll do it specifically for particular hospitals. Also, training, we are trying to focus for clinical use as well as implementation. We maintain a website, the URL is here, you can go, and most of the things that my team wants to talk about and let you know about SNOMED City is there. Thank you very much.
Thank you. Thank you, Karan. So, we have a lot of questions here, and a lot of them, interestingly, are focused on clinical coding. In fact, that was the most exciting and most complex area. Here we have some of them, and I think a lot of them are directed to SNOMED. And I think SNOMED is about exactly that, how to catch that nebulous cloud of clinical data and put it into databases. Or as someone said yesterday, converting data into information, information to knowledge, knowledge to intelligence and wisdom. Or what Dr. Karanveen Singh simply put it as how to convert a dumb phone into a smartphone. I think SNOMED is all about. A lot of questions on SNOMED here. I think we'll take the first one here. The difficulty is answering them in a short, sentence. It's a short question. Advantages of SNOMED over ICD-10. I think you can easily.
Hello, am I audible? Yeah. Okay.
Anonymous.
Advantages of ICD-10 over SNOMED. So there is only two advantages of ICD-10. SNOMED is used only in a few places. 50 countries are using it, and within each country only 2% or 1% of the hospital, even in developed countries, are using it. So it's not still a uniform standard. ICD-10 is used everywhere. So collation of international data is better through ICD-10. And that's why ICD-10 and 11 are going to remain in the long run, certainly for many decades. The other advantage is that with ICD-10 being a single hierarchy, you are counting it only once. Say example is that if you look at viral pneumonia, and if you look at the total number of patients under lung diseases, you will count the same person, say Ram Kumar, and if you look under infections, you'll count him again. So you will think that there are actually two conditions. So you can have a duplication if you are not careful of excluding duplicate patients. But at the same time, the same advantage on a disadvantage is also there in ICD-10. If you are looking at lung diseases, you may miss out viral pneumonias because they are classified under infections. So here is an extra positive on the SNOMED side, and there is a false negative on the ICD side. So that almost neutralizes it out.
Thank you,
But yes, the acceptance at this stage.
I'll give you another question on SNOMED. Yeah, tons of questions on SNOMED. I think the answer is simple and straightforward. SNOMED is much more detailed and granular, and I think
in US.
Yeah, we'll come to that. Okay, we have more questions for you on SNOMED and on SNOMED usage in US. This one was simply on ICD versus SNOMED. I think Dr. Sabadikari, can you take this question? Someone is doing a PhD in health informatics and healthcare. What are the top areas of research they need to focus on?
I think that's beyond the scope of this session, in the sense because health informatics is a huge spectrum. Health informatics, if you look at it, biomedical or health informatics, I mean, it could be at the cellular or subcellular level, that is bioinformatics. It could be at the tissue level, organs, that is imaging informatics. It could be at the individual level, that is clinical informatics. It could be at the population level, that is public health informatics. You can get into the field you're interested in. So first try to focus which area you would be liking to go work for, and then within the subdivisions.
Thank you, Doctor. Anything you'd like to add, Dr. Besi? Dr. Bedi? What can a PhD or a health informatics professional look forward to?
Basically, I think, when SNOMED CT comes, the research, etc., on the clinical aspects becomes much more effective. It depends, in what kind of way you are trying to do PhD. Is it the clinical PhD or informatic PhD? So that will make the difference.
Thank you, Doctor. Sundar, can you take this question? Why can't we have a system that looks into ICD and SNOMED CT database? This actually directs the application of big data, which could be used for predictive analytics. If we know the prerequisites and consequences, surely we can connect the chains that have been broken in the middle. Mr. Karanveer, but you can start. But
yeah, actually, I've been reading the questions, and almost all of them can be answered in just 2 or 3 things.
Yeah.
Number one, someone said US started ICD-10, they just said started and it started, why can't India do it? We have been using ICD-10 for 12 years. We are ahead of the US in that sense. The most common question, different wordings is, the answer is that SNOMED CT is meant for use by doctors. Doctors should not be asked to use ICD-10. ICD-10 is not a clinical terminology, and if you are searching for terms, you will not find it. You will find terms which are vague, not elsewhere classified, etc. So SNOMED CT should be used in all clinical modules. ICD is to be used in government reporting, and a conversion has to be done. A lot of people, a lot of medical departments are doing it manually even now, but there are automated processes that can be brought in.
Sundar, can you add?
I think that there should not be any doubt that ICD-10 is going. It's not going. It's going to be there. And it is going to be used mostly for statistical and aggregation. That is one of the... Yeah, epidemiology. That's what most of the government reports and the MIS request from the government side will keep coming for ICD-10. But the good thing, ICD basically. The good thing is that if you have entered record in SNOMED CT to begin with, it's always possible to get ICD-10 on the fly. It's not something that you have to do. The maps, the automations are already in place. So it's not to work. In US, the ICD-10 is mostly used for insurance. And if you see the latest guideline from ONC, which has come most probably a few months back, for field by field, they've given mostly SNOMED CT entry. They've given this should be SNOMED CT, this should be SNOMED CT. As soon as it comes about aggregation, classification, ICD. About ICD-11 and ICD-10, ICD-11 is coming, yes, and it does have linkages. But the map with SNOMED CT and ICD-10 is already available. And India we have been using ICD-10 for like 11, 12 years. So yes, we can continue to use it, but the idea is now to use it for the right purpose.
Thank you, Sundar. There are 2 questions on drug database. Why are we not able to formulate a national level electronic drug database which can be used by all softwares and solutions in India? The second thing is, second question is, Dr. Oman John, is it possible to have standard codes for drugs in India where there are 3 or 4 different irrationally combined drugs? Let me answer Dr. Oman John's question. Yes, it's possible, but whether it's irrationally or not, that's a clinical decision. But yes, we have combination drug codes. Many countries do not allow combination drugs. India is one of the countries that allows combination drugs. The second thing about drug codes, why don't we have? Yeah, even I have the question. All of us sitting here have the question, why don't we have national drug codes in India? I think one of the reasons is nobody's baby. It's typically should be the baby of the drug control of India, and his focus is not health informatics. It's regulating pharmacies, regulating manufacturers of drugs, bulk drugs and things like that. I think that's something I think both the gentlemen from the government can probably help us, and I think we need these national drug codes. Anyone wants to add on the drug codes?
See, this issue came up when we were going for the updation of this thing. I think in the new updated version, you may find a reference on drug. As you know, the chairman said, it is more country-related thing. So we have to take into consideration that. But something is, the Ministry of Health is going to suggest something, some kind of standards for this. Basically, it will be country, what, as the chairman says, the organizations related to this, they are going to suggest.
Jadil, a quick question on HL7. Where are we today? And how can we make it country specific? I know I was seeing some of the data sets within HL7, like marital status or gender. I think gender shows male, female, other unknown. Is it still same? Because now we have another gender. And how do we change the data sets within HL7? Marital status is married, that's what I was 10 years ago, married, single, separated, unknown, not disclosed. Not disclosed, separated, not divorced, separated. But now you have multiple other marital statuses in India, concurrent wives, and maybe in other countries, concurrent husbands and things like that. So how do you make it?
Yeah. The greatest challenge is an adoption, and it will only be adopted if it's localized.
Can you?
I think, I'm sorry. I think the greatest challenge in adoption is the localization part. A lot of the standards have been done in countries which have different ecosystems. And we are lucky to have a kind of bodies to regulate it and adopt it. And I think the key for this adoption will be coming from localization. We have started that initiative from HL7 India. We are looking at various profiles which can be customized to our requirements. And as rightly put, sex could have 7 values, but do we need the 7 values in India? Or do we need other values to be added up is a question. And we are also equally looking upon the government agencies to come onto a common platform for the standards to be implemented even on a pilot basis. And if you were to understand, today the Indian healthcare system is very disparate. One, we have policies and bodies which are trying to standardize standards for Indian ecosystem. And we have private players, big corporate houses running hospitals, and the government primary healthcare to the public health system, which are at 3 different levels of maturity. I think what needs is an adoptable standards to be vetted by the various bodies here.
Okay. Just 2 more quick questions and quick answers. One is relating to spine. I think, where's this question? What prevents us from adopting a backbone equivalent of spine of UK and forces all software vendors to get certified by spine compatibility? Anyone?
Yeah, actually, this is something that is being thought of at the Ministry of Health level. There's a proposal for forming an integrated digital health platform, but I think you're all aware things move rather too slowly, but it is moving, it is in the process, it is being thought over. So once this integrated digital health platform is in place, that will be very much there, and obviously they have to comply with whatever guidelines the ministry sets in.
Okay, the last question, I think, too many standards, NANDA, SNOMED, CPT, ICD, National Provider Information, Gabriel nomenclature of medicine, and I think I have hundreds of standards, too many standards, I think that's the thing. And when do we harmonize, when do you normalize, and when are we going to start focusing? One quick thing is, already lot of these standards are becoming dinosaurs. I don't hear the same standards names today that was there 10 years ago. And I know there were standards for clinical observations and findings which hardly are there. So I think we are getting there. Anyone want to make comments?
Yeah,
we have less standards today than 10 years ago. That's the good sign.
I think meetings of this kind should propel thought process to harmonize the standards. I think that's the beginning. With that, I think Dr. Karan can add.
Actually, SNOMED CT will gobble up a lot of standards, and anything that has to do with clinical clinical side, and even LOINC will hopefully move into SNOMED. LOINC is a big standard, but SNOMED has almost got a one-to-one mapping now. And if a new hospital starts, one good suggestion is don't go in for LOINC, go in for SNOMED. Certainly NANDA and a lot of other things, including ICD-10 PCS, will move into SNOMED. So SNOMED is the single harmonization point.
I think last closing point.
In terms of standard, we have to understand that more and more standards are becoming very specialized. They are looking at the narrow strip of problem that they want to solve. It's most probably one thing that covers everything. Other than SNOMED City, I can't think of any. Maybe FHIR will have. And therefore, it is important that we select the right one. And that exercise is what Mr. Bedi was referring to, is what the panels at the government side is doing. The whole idea is that out of the entire spectrum of standard, you pick the right one for the right purpose. And that is what these guidelines and the notification from the health ministry is.
Yeah, last comment. Quick one.
Actually, although SNOMED is broad, SNOMED is also deep. So when you're looking at a very narrow strip of highly specialized standards, SNOMED is in depth. So if you're looking at even, say, variations of, bariatric surgery, and bariatric surgery, people have some standards which have some 45 variations of it. SNOMED has all of them.
It covers the morphology in dermatology, it covers in morphology of the tumor and the cancer, not just the location and the type. Yeah, that's absolutely great depth.
And
I think that's what we are talking about
you can
converting.
Choose the narrow ref sets if
Absolutely.
you don't need the whole thing. So that's another one.
That's what I think we are talking about, converting data into wisdom. And I thank all the panel speakers for sharing their wisdom here. And thanks the audience for your wonderful questions. Thank you. Have a great day.
I just wanted to make an observation. I think more questions have been asked in this session than the whole of yesterday put together. You can draw your own conclusions and extrapolate these observations and make appropriate inferences. So far as I'm concerned as a clinician, I think what I mentioned yesterday, I think I'm out of a job. I mean, this session has elicited so much of discussion. Thank you once again.
Thank you, Honorable Chair and eminent speakers. May I now request Dr. G. Ganapathy, sir, to present the memento to the chairperson. May I also call upon Dr. Selva Kumar and Dr. Anant Padmanabhan to present the mementos to the speakers on the dais. Thank you, sir.
They will come. They will come.
A big round of applause to our...
Ladies and gentlemen, there will be a coffee break now. Please be back in sharp 200 seconds from now. It's 20 minutes, and we would like to reassemble all of you here by 11:45. We'll have the next session taken up by Vice President of TCS, Mr. Girish Krishnamurthy, on challenges in introducing EMR.
the Best Employee Award.
Hi, I'd like to
It's our priority to ensure our life-critical devices never lose connectivity to the network because the results could be life-threatening. Infusion pumps and bedside monitors help reduce the errors and medication, but an unstable Wi-Fi...
Using these devices in terms of healthcare delivery or, more importantly, on the treatment and the clinical settings. So, to sum it up, from the technology industry perspective, there is a digital tsunami is gearing up to hit healthcare. As healthcare as an industry, are we ready to deal with it? There are, by the day, there are about 720 companies have been funded in Silicon Valley in last 1 year doing healthcare innovations. Leave alone Sweden and the rest of the world. And there's a tremendous amount of investment Australian government is making in terms of making digital innovation for healthcare. And our Prime Minister is talking about Digital India, and there's a major focus on how do we bring in digital technology effectively to the common man in India. Now, all these things are a major paradigm shift which is gearing up happening. Nevertheless, 80% of our citizens the most important part has to happen. Implementing an electronic medical record, which is interoperable. Probably last 20 years, it could be a myth, or all of us would have been talking that EMR, and some of it happened, somewhere it is becoming a nice story here and there. But I personally feel that it is most critical one thing which has to happen in healthcare today, not better than ever before. And to summarize it, as a group, let's buckle up. I would request Arvind and Ms. Sin to guide us through how do we go further. And I call upon Ms. Sin to take over us and share our experience and also guide us through that what in the given situation, how we can make an EMR as a reality.
Okay, well, thank you, Girish. I think I'll speak from here so that I can see the screens easier. Could we load my slides? Thank you. Well, good morning, and close to noon now, so right, I'm very privileged to speak here, and I'd like to thank Sangeeta and the Apollo group, all right, for inviting me here. So my objective today is to share with you the Singapore story about where we are today and how we got to where we are. Today, mostly all of our hospitals are at the HIM stage 6, which is totally paperless, right? And they, of course, have to adopt the standards that was talked about by the panel early in the morning, earlier on before this segment. So I'd like to introduce a little about Singapore and IHIS, because I think it's quite important to introduce something about IHIS, which is the organization I run, which has actually facilitated and the state of health IT in Singapore. So we are a very small country. I think that actually speaks to why many of the implementations can actually happen in Singapore, because we're much smaller than you are here in India. We're less complex. We are a one government party rule, all right, and which has been in place for the last 50 years. And this year we celebrated 50 years of our own independence, right, as a nation. And that has been very largely, all right, ruled by just one party. So I think that has also facilitated a lot of the things that we do. Right, well, I'm not a politician, but I'm just saying that, you know, one decision at the top is worth 2,000 at the bottom, right? So we're 5.5 million people on a very small piece of land, all right, just about 700 square meters. And that's the composition of our ethnic groups, all right, largely. But if you ask Singapore people, okay, or if you meet any one of us on the streets, right, if you find a Chinese, Malay, Indian, and a Caucasian, okay, people will tend to think, they must be from Singapore, okay? And we speak a certain language, you know, which is like pygmy English, right? Which is what we call Singlish, which is a combination of all sorts of our own local dialects, right? So 40,000 healthcare providers, right, is whom we serve, and these providers are all in public healthcare. So we run public and private, right? But IHIS serves public healthcare today, all right. So in total, we have a total of 11,000 beds. 450,000 hospital admissions in the public healthcare, and the public sector outpatient visits are such, 3.6 million specialist outpatient clinics, and these see, the specialists that was talked about there just now. A&E, which is emergency department, sees about 800,000 visits a year, and polyclinics, which is our primary care for service run by the government, all right, that sees about 4 million visits a year. Okay, so that in a nutshell, Integrated Health Information Systems was conceived in 2008 as a result of the merger of the then IT departments of the public healthcare hospitals. So there were two major IT departments comprising 600 people. So we merged all the IT people together. I think that has got great benefits, because once you merge the people together, the people who facilitate IT, right, and we did not allow, right, other IT or shadow IT on the ground, right? What happened was that we managed to facilitate, all the consolidation of the systems, and that very much helped the acceleration of the adoption of standards. Because, before, I was hearing the panel before, right, we had a lot of debate about standards, about, which one is better, in the old days, people talk about CPT-4 as well, and SNOMED CT. But ever since then, right, we had got our hands around and said that we were already adopters of ICD-9 CM. We will continue to adopt ICD-9 for regulatory and for submissions to WHO, as well as for our billing and subvention standards for subvention purposes. That means for the claims, all right, that the hospitals make from government. So that remains on ICD-9 CM, and we had since migrated to ICD-10 in just one fell sweep, because it was one organization that did it, okay? So today we are already all on ICD-10 AM, which is the Australian version, because I think that had actually got the localization for countries like Australia and Singapore, which actually shared very much similar practices. And we adopted SNOMED CT for all our labs, our, for all the diagnosis, treatments, and so on. So for clinical standards, they are predicated on SNOMED CT. Okay, so we have been on that ever since. Right, so just 3 standards, all right, DRG for the huge medical claims, I mean for, at the aggregate level, then at the granular level, ICD-10 AM for claims, and then we have SNOMED CT for all the rest of our clinical vocabulary and so on. Right, so we are about 1,200 people. We started as 600 people in 2008, and we've doubled the size. But on top of that, right, the users have more than doubled. In 2008, we were serving only 18,000 users. Right now, we have 40,000. Okay, and we've got from 2 clusters, we have got 6 now. Each of the cluster is a regional health system that comprises of the acute hospital, primary care, family medical centers, and in a continued provision of healthcare for the population in the region. Okay, so we've got 6 of these different regions. All right, so that's basically about IHIS. So that's, and we're comprised of IT people as well as some of the healthcare professionals who decided to take on an IT career. So we've got nurses and doctors among us who have made IT their career. So we have a humble beginning. Okay, this is the evolution of our healthcare IT in Singapore. 1980, we started with a master patient index. That was quite key. All right, so we have a key for everybody. All right, every one of us has a NRIC number, which is the National Registration IC number that we are given, all right, at the age of 12, all right, but when we're born, all right, every one of us has a birth certificate number, all right, and that gets converted to a NRIC number with your photo, all right, at the age of 12, okay, when you're kind of going to adulthood. So that NRIC stays with all of us, all right, to life. And for every one of our record, whether it is a government record, your tax record, education record, can be, your working record, right? For we have something called CPF, Central Provident Fund, that has compulsory savings. So for anything that you do, your driver's license, your passport, etc., everything is predicated around your NRIC number. So we use the same number for our medical records as well. So 1980, we actually started the entire registry, all right, for all our patients, but practically just having billing as our mission. Okay, that's 1980. We did not have much of a clinical system. 1990, we started on clinical systems with our health informatics group. And then, we had many standalone systems because every department could make decisions about acquiring systems. So as a result of the very varied systems, we had a interoperability problem, all right, that is 1990. And of course, then the subject about standards came about. Everybody had their own drug codes. Everybody had their own little interoperability standard within the silo, within the hospital. All right, but things could not go across. So that's the 1990s. All right, but from there, right, we started to consolidate, our administration, our ADT, admissions, discharge, transfer. That's actually predicated on the NRIC number. So we started to do a little bit of that, but still we had many instances. And in the year 2000, right, we had a plan to actually implement electronic medical records. So these are the operational clinical records on the ground. So we had 2 sets. One was a B system. At all. Right, then comes the year 2010, after IHIS was formed. That's when we formulated and said we needed to have a SNOMED CT. NEHR was rolled out, and NEHR is the repository. Remember, we have 6 clusters, and each one, the EMR system. So we actually aggregate all the EMRs in our NEHR. So the NEHR is our interoperability as well as the consolidated registry, okay, of all our records. So that's our NEHR strategy. And that has got full interoperability. And actually, interoperability was made possible because of the fact that we made it seamless, for the clinicians. They don't bother. But back end, we have actually, I'll show you later. Okay, maybe. Okay, I'll just tell you a little bit here. Okay, back end we have actually got a whole network of interface engines, all right, largely predicated on Cloverleaf, all right, as well as our ESB, our Enterprise Services Bus, which actually, maintain the flow of information across all our systems. That means between the labs, the EMR, to the NEHR, and so on. But this is transparent, all right, to the clinicians, and they only see their screens, all right, that they operate with. But at the background, we facilitate the flow. And by and large, we didn't have to argue so much about the interoperability standards, but because we were one organization facilitating that, right? Now in 2015, right, the emphasis is on smart healthcare. That means the ability for information to be known, to be sensed, rather than to be inputted into the systems, right? For meaningful output of decisions that the clinicians can have and work with. So this is the value, all right, that clinicians always want. They do not want to spend all their time, right, keying into the systems, but what they want is for the systems to tell them or to give them the options as to what to do, right? So this is the whole idea of the CPOE, all right, and the decision support. So our, I think everybody knows, you go to Singapore, we are a much older generation, right, compared to India, right? In India, we have, your average age is probably about 20-something. Okay, our average age is actually 40 plus. So we are an aging population, second to only Japan. Right, so because of that, right, we have got a master plan which actually talks about access to healthcare, quality, and affordability. All right, especially for aging populations, affordability is a very big factor. Right, so the strategies for that is this. Okay, so for every one of the different clusters that I mentioned, we have an EMR, and the EMR may be shared. We have cases of 2 or 3 clusters sharing the same EMR system, but the common repository is our national EHR. We used to have an EMR Rex, which is an EMR exchange, that exchange information across all the EMR systems, so that if a patient presents himself at one cluster and later goes to another, all right, his record is discoverable, all right, and is known and presented to him, all right? So we used to do that with EMR Rex, which is an exchange. And then we have subsumed the EMR X into the national EHR system. So these are the objectives for every hospital, right? There must be information sensing, or paperless, all right, and the clinical and business must integrate around the NRIC as the patient master index, and we must have advanced clinical decision support for things like allergies, all right, things like any conditions that the clinicians need to know, either doctors or nurses, as well as the care plans. Right, so that's at the hospital level. At the intra-cluster level, which is within the cluster, involving transfer of patients from acute settings to primary care settings, we need to have integrated workflows and one EMR system across and one patient relationship management, or a PRM. The PRM is similar to the CRM, right, of the customer relationship management. So that actually contains the care plan for the patient. Across the clusters, we have one EHR. That means if I go from a SingHealth to a NHG cluster, which are different, I can discover the records via the NEHR, which presents to them, to the clinicians. Right? And if I want details, because at the NEHR, we decided that we didn't want to clog it for performance reasons. For any details, you can then zoom into the EMR, all right, for details, for things like, all the dosages of the medications along the way and so on. So our enterprise architecture guided us towards our solution harmonization, because then we could take a whole system-wide view or national view. We could create an ecosystem, right, and culture for solution reuse, meaning if some cluster wanted to have a system, they would necessarily have to come to IHIS, and IHIS will recommend a previously done system, a previously implemented system for the cluster. Or if not, if we know that many clusters are asking for the same solution, we will actually convene a work group, all right, that comprises all of them. All right, of course, everybody will say that, because we go into a work group, we get slowed down, right? But we always say, do you want to go fast or do you want to go far? If you want to go far, go together. So that's how, we've been nudging everybody along the way, right? So the first thing we did when we formed the IHIS was to architect the roadmap ahead, get the buy-in from everybody, and we integrated the system. It was quite key here because, you know, when we actually put everything together as a result of forming IHIS, right, we could have access to all the systems. Imagine when they actually started a new cluster, they didn't have to poach from another cluster, all right, for people, because the very same people were facilitating that for them, all right. So that helped to evolve even clinical practice because it became more standardized. But one thing that we did, all right, to actually be a more inclusive society, all right, is that we asked everybody, just let us know what your systems are, and we will interface them for you, all right, so that they get into the entire network. And for that, you could continue to use your system, and you could also continue to use others. But we make sure that at the back end, you know, the data is actually collected and consolidated. And that was a very hard exercise, but that was a technical exercise that we made transparent, you know, to the clinicians. So in doing that, slowly by slowly, for the clinical departments that found that their system wasn't as good compared to the others, right, over time, they had discontinued their own system and then, you know, went in favor of the more, you know, functional system that they came to adopt. So that we found was a very important lesson for us. I mean, that strategy of inclusiveness, all right, rather than say that, okay, you know, let's kill this at the outset. We didn't do that. All right, we just included everybody in and let the system speak for themselves. All right, of course, at the back end is a heavy job, all right, to interface and pull all the data together, get the logs and get the right, you know, systems. But it was quite a technical, you know, challenge. Right. So in the end, right, this is what we want: patient-centric records. Right, that wherever you go, right, you should see the same view of the patient. And we're quite happy to note that, you know, for the third goal, tomorrow we're launching the National Patient Portal, where, you know, every patient, every person will have their own record at last and can see their own record as a citizen. And you can see your children's record as well. So as to standards, you know, we did the common data standards, integrate them, and then we intervene at the right channels. Okay. So the EMR journey, I think in the interest of time, I'll just lead you into, you know, the essential elements of the EMR. Okay, this is our architecture. All right, we had, you know, the service channels, right, defined for every EMR. This is what every EMR must have. And then we had the transactional apps and the modules, which are things like the labs and all that, you know. And then, of course, we have the enterprise service bus. Or it was easier for us to do this because we were one group already. All right, and we didn't have to fight with other colleagues, you know, to do this. So this was like centrally done, you know, as a consolidated group. So we had an enterprise service bus, and that actually speaks to the EHR and the ESBs of the EHR. We've got different repositories that we agreed upon, and the enterprise reporting for the warehouse. So one of the key elements of our EMR is actually the closed-loop medication management, which I thought, you know, there were a few lessons to learn. Okay, at the outset, we decided that we must have the 5 rights because medication management and safety is actually primary, okay, to treatments. So there's a lot of value, and we decided that we would actually focus on this. And to focus on this, right, it means that we had to invest, okay, in the electronic prescription system, which is part of the EMR. Clinical decision support is also part of the EMR. But the external systems like the robots, okay, for single dose packaging, these we had to sort of integrate together, and we bought them from, we had 2 brands. One was Omnicell, the other one was Swisslog. Omnicell is a US brand, Swisslog is an Italian brand. So they're just different ways of doing the same, to achieve the same thing. All right, and what we had was a nursing admin system using barcodes. And using barcode is very key because it means that you don't have to argue, okay, about all the standards and all that, right? Everything is translated in the barcode in which you just scan, all right, and leave all that data translation to the IT people at the back end. So we barcoded, all right, at every point, all right, so that to ensure that the same or the right dosage, right, the right method, the right route, the right pill or the right medication is given at the right time to the right patient. So every patient wears a a barcode. We've actually now, that there is a program to actually have RFID, replace the barcodes, right? So this is how it works, right? I think many of you will know this. We have both the inpatient and the outpatient CLMM, all right, or the closed-loop management medications, all right, where, it sort of automate everything from prescription. That means from the time the doctor prescribes the drug, right, there is no intervention. Okay, so the pharmacy reviews the screen, all right, and gives its signature, after which it just proceeds, all right, into packaging, all right, of the drug, and then it gets sent into the medication storage, all right, that is for vials, okay, because the, the pharmacist, the robots doesn't handle vials today. So the vials and all that will go to the ward stock, and then the vials together with the pills and the capsules, right, whatever is the individual dose for the patient, will go into the medication trucks or the medication carts, and then they get administered by the nurse, everything through just scanning and the barcode. Right, so this ensures the 5 rights, right? And for this, right, we were quite fast for us to attain the HIM stage 6, because stage 5 is actually CLMM. Okay, so the lessons learned was that the robot technology, okay, for filling medication and orders and all that, all right, enhances patient safety because there's no intervention. 2D barcode is something that we have now used instead of the 1D barcode, right, and for all the labelings. And then I think other things like unit dose packaging is, if it's not consumed, because the problem is that if you change, all right, the dosage or you change the medications, then you have to return it. So there must be this proper process to return it, and so on. Okay, so I will leave, the slides will be available, so you can take a look at that. All right, next on to the EMR. Part of the major portion of EMR, aside from the medication management, is the clinical documentation. All right, this is where the doctors come in, and they've got to document, all right, every encounter with the patient. So to do that, there are 3 main aspects. Organization support. So we had, adoption along the way, but we had to have a deadline that said that must have 100% adoption by a certain date. Okay. So that is very much, I think, the leadership at the top that actually can drive that. So the organization support is very important, the leadership. We had, in every case, right, the chairman or medical board drive the initiative, and definitely the resources. Okay, so the strategy was that we engaged all the clinical chiefs and the administrators such that this became a goal, a KPI. And then we conducted road shows. We set up sandbox, okay, for people, all right, and so that they could test it, and so on. All right, I guess my time is up, but all right. So for clinical adoption, you can read it. They're all on the slides. All right, and basically, I think the key thing that I wanted to mention here is that there must be integrated on a workflow. All right, and these must be consulted upon. All right, before you implement them. All right, and because of that, you also must do, a minimal keying. That means you do not allow your clinicians to actually be encumbered with all that keying in. So all our screens are actually pulled down. Okay, we've gone from cows to tablets so that they can walk around more easily and make their orders more easily as well. All right, so standards and governance is absolute key, as I mentioned, and you must have the right work groups and all that, to actually implement this successfully. Of course, all these points are important as well. Okay, so I think on the slide too, you can see the governance process. We have one that actually allows us to have a common governance process and common, order sets and common practices, okay, across, at least within each of the clusters, so that we have consistency. And because of the commonality, which is IHIS, we enabled every one of these clusters to adopt as much as possible same processes. Of course, there are differences, but I think along the way, I would say that about 80% are common and probably 20% are different. Okay, so that rounds up my presentation. So if you want to have more details, all right, I hope that the slides can provide you, with the notes. Thank you.
Thank you, Dr. Chongsin. Girish had to leave on a personal emergency, so he did offer his apologies for leaving in between the session. If I can have my slides up. While my slides are going up, challenges in adopting electronic medical records in a corporate hospital. And I'm not sure if my team is here or they've conveniently vanished, because sometimes it does sound very familiar to what they hear on a daily basis. So we started this journey on CPOE, computerized physician order entry. Then adoption-based challenges started taking over, and computerized physician became computerized practitioner. More challenges, and computerized practitioner became computerized provider. More challenges, and then the fear that whether the practitioner, the physician, and the provider will finally end up in becoming computerized person order entry. And that means data entry. So we've lost the clinical sense and we start getting into data entry because we just want electronic records. And that, if we ever get to, is a battle lost. A battle lost that can never be regained. So never get into the need and the urgency and the style and all of it looking that everything just needs to go electronic without purpose. Electronic without purpose is just going to be data entry, and we had a lot of discussion on that yesterday. So what are the challenges in implementing electronic medical records, and why are there challenges implementing electronic medical records? That's because you can't even read it in 3 minutes. We have that many priorities, and all of them are the right priorities. All of them are something we ought to be doing. All of them are something that we are already late, that we have not delivered on. That means that the need to ensure a fabulous implementation of electronic medical records is beyond the need of the hour. We have to follow some structure. And we did, when we started off this model, we said, let's take a structure that is international, that is applicable, plus it has all the nuances of India and the Indian healthcare workflow. So we did look at the HIMSS Asia Pacific model, and if you look at it, there are 7 stages of maturity on this. Most of the organizations will claim to be anywhere between stage 3 and stage 5. Most of the organizations will be somewhere there. And most of the organizations will have stuff in every stage, including stage 7, but no stage complete. We've started off on every stage, no stage complete. That means that we are jumping without realizing the full value, because there is a speed to maturity versus a speed to deliver, and both of them seem to have a constant war on delivery and maturity, and ultimately we lose out and going back to that provider practitioner becoming person. And I'm happy to say that Apollo Hospitals, 22% of Apollo Hospitals is at stage 6. I did see Dr. Chong's slides on the health system, and I don't have a comparable health system, but if I just take off the word Singapore and put Apollo Hospitals, I think our numbers are the same. And this to me is a matter of pride. Put it into my shoes. And this is what we probably want to have as the new definition of digital optimism or pessimism. 100 clinics, 2,500 pharmacies, 350 telehealth centers, 63 hospitals, close to 9,000 beds, an average of 10,000 footfalls per day, close to about 150 cardiac surgeries per day is a typical day in life of any Apollo hospitals. 350,000 lab transactions flow through any single day including a Sunday. And that is the complexity of implementing an integrated system in a corporate hospital. So what is this path to the complexity? The implementation of the EMR starts with meticulous planning. There is no substitute to planning. Every hospital has its uniqueness. Dr. Chong nicely mentioned that hospitals don't fight. Very polite word. What we go through is much more than that. And each hospital having their own IT systems because each hospital is unique. So there can be a great argument in terms of how can we have so many hospitals with disparate workflows. They are not. The techniques that we use in planning should drive us towards operational, clinical, and financial excellence. That means that we have a functional, empowered governing council. Functional, empowered. We can have a council. It can be decorated with all the designations in the organization. Most of the meetings will be delegated to the next level, the next level, the next level. Ends up being a departmental meeting. So that is not a governing council. A functional, empowered governing council that maximizes the efficiency and minimizes the cost. I'm not sure if there are any CFOs or people who are close to CFOs in this audience. This is music to ears. Minimize the cost of implementation, maximize the efficiency. And that is what will take us into a very effective, productive, and sustainable electronic medical record. Size of the team, manpower, cost of manpower. Again, I'll compare it with Dr. Chong. She mentioned that her team is about 1,200. I'm not going to venture a number because my numbers are pretty embarrassing there. That is a challenge. That is necessarily a challenge. The investment that needs to be put into the right manpower, this is not a number game. This is not about having, okay, I go back to my management tomorrow morning. I heard Dr. Chong say that she's got 1,200. I stake my claim for 1,200. I'll tell you what will happen. I'll get thrown off the 9th floor, straight down. And there'll be enough people to watch that. That is in terms of the right people, the right size, that is going to maximize the efficiency and minimize the cost and lead to an organization of sustainability, create a culture of ownership. Electronic medical record is not an IT project. Electronic medical record is about the health system implementing a powerful solution for the next generation. It is not IT's project where geeks come and do something on a .NET screen that is normally not compatible to the next version of the Microsoft Explorer. Process is key to an electronic medical record. There is change management. There will have to be clinical champions. There have to be process specialists. And yes, HR has to be involved in the process because every job description is bound to change. Every job description is bound to have a transformation. And every person is going to have some cheese moved out. It is change. Get over it. Process is key to EMR. Check for the downstream impact. Why was something done? There is a method to every madness. It was done for a purpose. It was done for a reason. We have to know why and then do the transformation. Change without meaning, change for the sake of change, change to prove a point because the neighbor is doing something, change because we heard something in a conference and they said we have to move forward, is going to be counterproductive, will lead to disaster, and that is one of the reasons why most of electronic medical records fail. Check for downstream impact, understand the clinical process, and do not just justify, educate, understand, participate, mingle, co-work, become friends with the clinical team, get the operational team involved, get the finance team, get into HR, and make it a single driving initiative of the organization, definitely not the IT department. In summary, what drives electronic medical records? Focus on standardization, focus on efficiency, focus towards the new world digital, focus towards paperless. What is it? What is it that should drive organizations towards a meaning? What is it that should drive organizations towards getting results? It is implementation with an eye on adoption. Without adoption, there is no purpose of implementation. It is money gone down the drain. It is adoption with the eye on maturity. We need to move to the next 2 levels, not the next level. Next level is no more acceptable. We need to move up. Stage 7, stage 3, stage 4 are just pleasers. Maturity with an eye on continuous improvement. It is continuous improvement that is the sole steroid that is going to drive electronic medical record into a course of maturity, into a course of adoption, into a course of usefulness, into something that can become the DNA of every organization, and continuous improvement towards the eye on excellence. That, my friends, ladies and gentlemen, is how we see challenges and solutions towards implementing electronic medical records in corporate hospitals. Thank you for being a patient audience.
I hate to tell you that there'll be no time for questions. We're already behind time, and I don't think it's fair to disrupt subsequent scientific sessions. With the permission of Mr. Arvind, and thank you for your impassionate, fantastic talk. And madam, thank you very much. I think in your enthusiasm, we went a little ahead of time, so I'm sorry, but there's just no time for questions. We'll just present the mementos, and may I request every one of you to assemble back in exactly 25 minutes, a quick business lunch, and please come back on time. I don't want to disrupt the rest of the scientific program. Please do come back in time. Thank you.
Just one comment, sir. Good news from the standard session, which we thought we'll have a comment as. In India, the SNOMED licenses are completely free of cost. All that is required is for somebody to register. Government of India through CDAC, Sundar's team will provide these free of cost to every person who wishes to adopt. Yes, they will track your adoption, but it's free of cost and they will help you with it. So please do contact the team there.
To the organizer, Mr. Arvind. Let's run for lunch, please.
For all the delegates, the pen drives with the conference material will be available at the registration counters. So after lunch, as logically the sessions progress, please do make sure that you have them collected. Of course, the slides and the material of the conference will also be available at the conference website.
So got some meaningful
exactly mentions a very similar vision of access management. That's what you want to implement here in India and across wherever we go, across geographies. So a lot of synergies. Thanks a lot. It's difficult in India.
I've got a reason to for the rest of the day. Get out of bed. And reason to suspect. Okay. So maybe if you're keen, if you're okay, we can take you to a display of our solution. It's in the nearby, it's in the next hall actually. Sure.
Why do I keep a picture of myself by my bedside? So I remember what I've done to me during the crazy night. I hold myself, my soul is calm, and I decide I create and I destroy in the daylight, the daylight, the daylight, in the daylight, the daylight, the daylight.
what men may say. When in 5 years none of our people have died, and there's never been a casket rolled through people's temple. When 24 times in this year, and the year's not out, they brought
See, see. Good evening, everyone. Bride and here, the countdown begins.
Good afternoon, everybody. I know the auditorium is not full, but we are 15 minutes behind time. I can't let the rest of the scientific session go helter-skelter because of the delay caused in the morning. May I invite the first speaker, Nitish Chandan. I think it's a very, very important topic. Even 2 years ago, I honestly would have felt, I said, come on, cyber security and healthcare. I remember about 6 or 7 years ago, I was invited to give a talk on security issues in healthcare in Brisbane. This was a hardcore IT company, security, everybody. So I told the organizers, I know nothing about security in IT, I know nothing about security in healthcare, etc. But they said, no, we still want you to come. And then I said, to pardon the unparliamentary language, I said, who the hell is interested in my, whether I'm HIV positive or not, whether my blood sugar is raised or not, who is interested? I think you're overdoing this security business. You can't extrapolate what is credit card security to health security. But in the last 2-3 years, the growth has been so phenomenal that today I'm convinced that I was totally wrong just 4 or 5 years ago, and I think security does play a very major role. I've gone to your article, I think it was very informative. So may I now call Nitish Chandan to, and I'm going to be the most unpopular chairperson. You get exactly 960 seconds. If you can't convey your message in 960 seconds, you're not going to convey it in 20 minutes. So please, in exactly 8 minutes you finish, so that there is 2-3 minutes time for question and answers. Please go ahead.
Thank you so much, sir. First of all, I would like to thank everybody who's here, and Professor Garpati. Actually, I come from Himachal Pradesh, so your talk yesterday I related to very well. So as the founder and we deliver lectures on cyber security, cyber safety to different parts of the world, where also Himachal Pradesh is a part, the same regions that sir has also been. So moving forward, my paper is basically talking about these two things, critical network infrastructure and EHRs. The importance of cybersecurity and healthcare is actually unprecedented, but I'm going to talk about a couple of case studies since the time is not actually what it was. So let me get it here. What do you think is the cost of cybercrime to India? In the last, let's say, 10 years, it's been 15 years today. Also, I would like to say that it has been 15 years today that the Information Technology Act was passed in the country. The first IT legislation of this country was passed on 17th October 2000. And 24,630 crores is the cost of cybercrime to this country in the last 10-15 years. So it is not just banking, it is not credit cards, and it is not personal debt. It includes all the dimensions that we can think of. Moving ahead, estimation of readiness is not possible as of today because there are numerous health centers that are in the digital disconnect. So if we say we are ready or not, I will not go into the details of why the paper has it all, but I would like to highlight this particular, the third point that you can see. Generally, all electronic health records information must be encrypted, decrypted. The last line, with the best available encryption key strength. Now, this is an excerpt from the document on the national standard on EMRs. So, the best encryption policy is not there in this country. There is no standard national encryption policy as such. So if we say it is in 128-bit DES, AES encryptions, nothing of that sort. So we have no standard laid down as to how this data is going to be protected. Okay, now there is a study by a researcher that has revealed such information. Now, defibrillators being controlled over Bluetooth were prone to attack for random shocks. just one thing, thermostats were prone to temperature settings change, and it has caused spoilage of drugs. This has happened. Now we are looking at a generation of cyber murders. How, if you remember an incident that happened in the States, the vice president's pacemaker was on a network, and while he was speaking somewhere, it had to be turned down. The reason for that was there was a potential threat because it was wirelessly controlled, and the processor speed and all could be clocked so that it could also lead to his death. Now this is happening. We are talking about 2015, and it is happening today. The first cyber murder is anywhere around the corner. Okay, misdiagnosis has happened, administration of unwarranted care, all because the networks are not protected. So if you know a little bit about technology, you're using WEP encryptions on your Wi-Fi, it is hackable in less than 30 seconds. If you're using WPAs, it's another 1.5, 2 minutes. If you're using WPA2, TKIP and all, okay, it's a little secure. But Wi-Fi's and networks a little low graded, yes, it's hackable in seconds. And that's where we are with hospitals, because my parents are medical practitioners and have seen hospital networks and how vulnerable they are. Again, my focus has been wherever I've spoken, you know, it's not a very long career that I've had speaking at these places, but one thing that I can tell you guaranteed is that the biggest cybersecurity leak are you people. It is us, because we have passwords like those. Admin, password, 1234. If you are aware about the latest BSNL hack that happened a couple of months ago, the passwords were stored in plain text. I'm going to start from India, and let us take it across nations. Sony was hacked last year. The North Korea, South Korea debate was there, but they were hacked. Why? The reason was the password SONY123 of their main servers. So that is the reason. You can have any encryption policy, you can have 256-bit AES encryptions, but if you have a password that says 12345, there is nobody who can protect you. The only solution to cyber crimes today is awareness and sensitization. Now, UCLA was hacked, 14.5 million accounts were stolen, and I'll tell you, the University of California in Los Angeles, hackers stayed in their networks for 2 months. It was after 2 months that they realized that somebody was in their network and accessing data and copying data. Now, health records are very costly. For a fact, medical information can be worth 10 times as the credit card. Now, I can tell you, if you've heard of scams where people call you and tell you, this is your ATM card number, this is your bank account number, please tell us your OTPs. I'm sure you've heard of this. Now, all of these crimes happen how? How does this data get leaked? It is all because of these reasons. Not just medical hacks. I mean, you can call up Just Dial and ask people to give you data. They will send you for, sell it to you for 10,000 bucks, one record. So one record can even cost you 10,000 rupees. I'm not joking. You can really call Just Dial and ask for data providers. They'll give it to you. It is happening. Implantable medical devices, the growth is tremendous. As we know, Internet of Things is coming up. All of this is coming up. And cybersecurity is again is a concern. But before sensitization of users, there is nothing which is possible. You can have anything, any levels of encryption and security and hashes, but if your passwords, as I told, is that, it's all gone. To conclude, awareness and sensitization is there, okay. Now, what organizations, people, as regular citizens, you also need to do is to carefully categorize and classify data. That is very important, you know. Yes, just a couple of days ago, I was attending a lecture by Lieutenant Vineet Kumar. He's a renowned information security professional. I mean, people from our domain know him. He talked about a very interesting thing. If there's a door there, and you have certain piece of data, what are you going to do? Are you going to lock that door, or are you going to lock that data? That's a very interesting analogy, and I mean there is no basic answer to that. You can lock the door, you can chain it up, you can do anything, but if your data is innocent, okay, data has nothing to do with being hacked. The reason it is meaningful is us. So I think I will leave it to that, and there's one thing that I wanted to conclude with. a couple of quick takeaways. If you're on Facebook and your birth date is publicly available, I think you should know that your PAN cards are publicly available. It is the flaw of, I don't know, policy or what, but just with your date of birth and your last name, somebody can retrieve your PAN card number. And what they will do with your PAN card is not create a bank account in your name or withdraw your money. It has happened, and people have established identities for 5 years, 2 years, 3 years, and later those identities, you have a name in your house somewhere up north in Jammu and Kashmir. You're sitting here, you have a house there, you have a bank account there, everything set up there, and later these identities are sold at crores. I mean, it goes to the terrorists and whatnot, and it is not thousands, lakhs, it is crores. So I will, I think, leave it to that. Thank you so much, sir.
Thank you, Nitish, for strictly adhering to time. If all the speakers do this, we'll have enough time for question and answers through the application. Can I call the next speaker, Anita Kulkarni, to talk on an adaptive system for aggregating patient data? Anita is a software engineer, runs a company, MetaMagics Computing in Pune. Your time starts now, 8 minutes.
Hello. Very good afternoon, everybody. I thank the organization for giving me this chance to talk to you, and I thank all of you. Can we get the slides up?
Okay, the speaker's not here, it's okay. Any of the speakers in this session are here? Please raise your hand. Your name, sir? David Harris. Yes, sir, David. Is his presentation ready? Please come, David. David is from the School of Computer Science, Scotland, UK, and he's going to talk on remote sensing of heart rate and blood oxygenation level.
Okay, well, thank you so much. It's really great to be here. As was mentioned, my name's David Harris-Birtle. I'm from the University of St Andrews in Scotland, in the UK, and I'm here to tell you about remote sensing of heart rate and blood oxygenation level using camera-based technology. Okay, so let's remind you why heart rate and oxygenation level is important. Can we go on to the next slide, please? This clicker isn't working, sorry, so can we move to the next slide? Thank you. Okay, so pulse oximetry is really important to understand heart rate and oxygenation level because these are really key vital signs to see how a patient is responding. So if your heart rate is less than 40 beats a minute or more than 130 beats a minute, that means that a patient is in a bad way. Or if the blood oxygenation level is less than 90%, then again, the patient is in a bad way. And not only do we need to know these measures as a one-off, we also need to know how the patient is responding over time. So are they getting worse or are they getting better? So there is a standard clinical device which is used, which is called a pulse oximeter, which is a clip on the end of your finger, which measures your heart rate and oxygenation level. And the way it works is you have a red LED and an infrared LED, which measures the intensity of light as it goes through the finger. Now, as the heart beats, you have more and less blood going through the blood vessels, which means that actually you get darker and lighter, which means you can actually measure this darker and lighterness through these optical measurements. And the fact that oxy and deoxyhemoglobin, that's oxygenated and deoxygenated blood, are different colors, they have different absorption spectra, you can use a ratiometric measure of the red divided by the infrared to get that information of the oxygenation level. So this is all very well and good, and this is used in pretty much every single hospital all throughout the world. But this relies on the fact that you have a clip on the end of the finger, and that means that you actually can't use this kind of technology in every single situation. So for example, if I have a patient who comes into accident and emergency, and then they wait in the waiting room, we can't be measuring their vital signs until a clinician has gone up to them and put this single clip on the finger. And what would be really great is actually if we have a camera in the environment looking down at all the patients in the room, identifying all their faces, and then extracting those measures just from them being in the environment. And that's what I'm going to be telling you about today. I use the Microsoft Kinect, which is used for gaming. It's used for Xbox controlling if you're trying to swipe a bat or control your racing car in a game. This camera can do that by identifying where your limbs are, so where your hands are, where your head is. And actually I can use this camera technology not just for gaming but for clinical purposes, because it gives us the color image, it gives us the infrared information, and it gives a depth map. And from that depth map it provides information of where the heads and all the joints are. Now, that's really useful for me because actually I can identify, okay, here are all the heads in the room, this is the color information, this is the infrared information, and then I can measure those over time to see how the measures fluctuate to get the heart rate, and use that infrared and color to get the oxygenation level. So the kind of systems that I use a spectrometer setup and the Kinect, and so therefore I can do reflectance-based measurements. And as well as the Kinect, I also use a spectrometer to identify what are the spectral features, and if I'm to make a system in the future, in what way can I optimize it? In what range of colors, what range of wavelengths is my system most accurate? Okay, so how do I actually calculate the heart rate? Well, this is one of the kinds of signals that I can get. And so this shows the heart beating and also some low frequency noise which I can filter out. And if I use my algorithms to calculate the heart rate, I actually get the actual heart rate that I get using a normal pulse oximeter. So actually I'm able to get the same kind of measurements, this time using camera-based systems. So if I want to look at spectroscopy and see, okay, what wavelengths, what colors do I want to use in the future? Well, actually, it turns out that the highest accuracy that I can get in terms of calculating the heartbeat is within this green region, around 550 nanometers in terms of wavelength. And at all other wavelengths, the signal-to-noise ratio is much less, which means I get less accuracy, but it's much higher in the green. So I can use that to improve my system for the future. So actually, when we're using the Kinect, what kind of information can we get out? Well, here I'm able to identify where are all the faces, and then within the faces, I identify regions of interest. So I identify, okay, here are where all the cheeks, this is the forehead, this is the lips, and this is all done automatically, okay? So no human is going to have to say, okay, this is where the cheeks are. It's all done automatically, and it identifies both in the color and in the infrared, and therefore I can measure these statistical measures on these regions over time and calculate the heartbeat and oxygenation level. So now we've come to a point where we can measure these things and automatically extract out all the faces. So now I can send the clinician an information of where are all the faces and what they look like. So this is the kind of user interface that we're showing to the clinicians. The patients' heads are automatically populated, just pictures of them as they come into the scene. Their real-time heart rate is also measured, along with the history of their heart rate, and the same with the oxygen saturation. So now, if we have some measurements of the heart rate and oxygenation level, we can flag up to the clinician, oh, this patient is in trouble, please go and see them. And so they've got the picture of the patient who's in trouble, and the clinician can then look and then see, okay, I'm going to go and identify this patient, all without the need for a clip. This is all being done in the environment. So thank you so much. I look forward to any questions later, and here are my contact details. Thank you.
Thank you. We'll have the questions towards the end. Are you ready? Yes, Anita, can you come back?
Good afternoon once again. So the topic that I'm going to cover is how do we manage data? Yesterday there was a lot of discussion that most of the technology blocks that are required for transforming healthcare with IT are ready. And more or less they are. But one of the challenges we have is the data that we have in healthcare, and especially I'm talking about patient data, because we are talking about improving patient safety, patient outcomes by using healthcare, IT. So the question that I address, and we've been working at it for quite some time. Metamagics is the company that I founded about 5 years back. So the state of patient data is there are thousands of patients, innumerable symptoms, hundreds of tests, and if what we are seeing outside, so many booths and so many enthusiastic implementations, innovative ways where home-bound patients can capture data, vitals and serious data, then you're going to be having a deluge of data. And the problem with all that is the fate of patient data is there's diagnostic data which is more or less electronic. There are case sheets which are I would say 20% of the time they are electronic, 80% of the time they are handwritten, and there are all of that diagnostic data, whether it's CT scans, labs, all of that ends up in the hospital's basement. Some hospitals are enlightened, as we have been listening to the stories from Apollo, and they do a fantastic job of making sure that all data are electronic. But what happens is, when you have data which is stored on your servers or in your basement, and you want to ask a question like this. Yeah. So you want to ask a question as to what was the minimum of creatinine for any specific patient. There's a nephrologist who wants to know what is the level of creatinine. And there is no way you can answer that question by looking through a pile of papers. Whether it's pile of papers or a bundle of electronic documents, the problem remains the same. So when we are talking about data, what we are talking about is we want to make data searchable. We want to make data amenable to aggregation and analysis. And how do we do that? So today, typically, if you look at EHRs, you have the inpatient data is what gets captured. But for chronic illnesses, and we are focused on chronic illnesses and rare disease management, there is a lot of data that patients have before they reach a tertiary or a specialized hospital. Then they get into the hospital, in and out, couple of episodes, and the hospitals have their data. And once the patient is discharged, there is a long chain of follow-up that has to happen. And that, again, leaves that patient data outside. So historical data and OPD data are not included in the system, so you don't get a lifetime view of a patient's data. And that's what we are trying to address as to how do we manage this data. So the process of unification that we have evolved is we accept disparate data, because sometimes people who are suffering from chronic illnesses, their near ones and dear ones try to keep the data in Excel sheets. Then the labs give you data in PDF documents. Then you get hospitals. Hospitals sometimes give you data on CDs, but nobody gives you data in an electronically exchangeable, usable format. So we take all that ad hoc data, we extract the schema out of that data, we consolidate, and what we do also is we do the semantic mapping. In the morning, we've listened to very enlightening presentations about SNOMED. So SNOMED comes in handy because people describe data in multiple ways, and we scrub the data, we scrub the noise with semantic data, and then we load all that data to the native database so that hospitals can continue to use the data. So this is the process of SNOMED mapping, semantic mapping that we have. There's no time to go through this in detail, but I have a little example of how SNOMED helps. This is the data. First time when a patient walks into a liver clinic, this is how the diagnosis gets recorded. And if you give this data to any search engine or you want to retrieve, then each string is distinct, and there's no way you're going to get all the patients in this list as patients suffering from liver disease or liver cirrhosis. So what we have done is we've taken data like this and mapped it to its root, and what you get is a data that is clean, a data that is mapped to the root concept. So the diagnosis remains as it is. We don't change the diagnosis. What we do is we overload that single concept that was recorded, because that has to be recorded. That has the sanctity of medico-legal purpose. And for analysis purpose, we enrich the data by adding the concept IDs and the root concepts. So once you have this data, then it's easy to retrieve and easy to do analysis by patient cohorts. So when I have a system like this, and I showed you a pile of papers, and from which there was a clinician was trying to answer a question, what is the minimum of creatine for a patient? Instead of that, what we give you is this, and we know that the minimum or the maximum or the trend for patients vital creatinine for many, many illnesses, multi-organ complications, creatinine tends to be one of the most vital parameter that doctors are interested in, and we give you that. It's not just about creatinine, about any parameter that is of interest to a clinician, we project it this way. Okay? This is another way you can compare recovery patterns. Now, to be able to compare recovery patterns of two patients, a lot of work. It looks like simple graph, but to come to this graph, you have to do an enormous amount of work in terms of harmonizing the data, aggregating the data, resolving conflicts. Somebody might just call it HGOT, somebody calls it AST, so somebody might call it enzyme levels. So massaging the data through all that noise, and to get to this level of finesse is what the journey from going from papers to paperless is about. It's not just about paperless, it's about what does my data tell me? Does it tell me recovery patterns? Does it tell me, is my data searchable? Is my data going to improve my ability to do diagnosis? It's going to help me improve patient safety? Those are all the concerns that are very burning concerns, and those are what we address. That's all. I think we have very little time, and I hope I have been able to do justice to the topic. Thank you so much.
Is Mr. Gyan Sharma here? Yeah. Thank you. Sharma is from the Department of Health and Family Welfare, Government of Madhya Pradesh. He is going to talk on a very important topic on erratic supply of vaccine and logistics in the public health system and how information technology can help in that. Please go ahead.
Yeah. First of all, good afternoon all, and thanks to organizer for inviting me to participate in this awesome conference. So here you can see the theme of my research paper. It's basically a new application that we have developed for public health system, where supply of immunizations under which we provide vaccination, and that comes from manufacturer to end user, which is located in remote areas, particularly in rural areas. So it's a cold chain system where from top to bottom we have to maintain cold chain, and for this before that we had no system where we can trace real-time information that how much vaccine is required, and against that how much vaccine is available. So UNDP, United Nations Development Program, which I work with, have developed a EVIN application, which stands for Electronic Vaccine Intelligence Network. So I collected some data first before that, what is the need and how it justifies that, how it becomes fit for government system. So this is the objective to assess the information, role of information technology, which can enable for effective stock management of vaccines and logistics also. So you can see in the picture that this is one of the app we have developed, which we will provide to health workers in government system, and they'll put entry through that, and it's a real-time data entry, and one can see that this is the current stock of vaccines which is available. facility. Facility can be sub-center, facility can be PHC, CHC, or district hospital. Yeah, it's about the study design. It's a descriptive and quantitative study. And research area was Ujjain division, which is comprised 7 districts of Ujjain division. And duration was from 1st April to 2015 to July 31st, 2015. Yeah, this is the demographic profile you can see. MP is one of the state which is known as a Bimaru state and which has poor immunization coverage in the country. It's almost 65%. So you can see birth rate is also varying from district to district. And number of focal point, we call it cold chain point also, where vaccine is kept. So it's also varies from geographic location as well as according to population also. Yeah, I'm using this demographic data because it becomes a base when you calculate number of vaccine which is required. So suppose if there is a, 35,075 is number of births, so according that you will have to calculate how much BCG doses is required. Yeah, this is a scientific calculation of vaccines which includes standard wastage rate also. For example, oral polio. Oral polio, government has recommended 10% of wastage. So according that, if there is 5,846 for district, which is, no, suppose if there is no 10,000 number of births, so according that 10% wastage will be allowed, and on the basis of that, if 5 doses of oral polio is to be given, so according then 1 month stock should be this. So similarly, syringes is also part of logistic, which is to be supplied along with the vaccines. Yeah, here comes the findings. Basically, you can see from divisional level to district level and district to lower level, which is at PHC level or CHC level, you can see monthly supply of vaccines. So here, Ujjain district has got only twice supply of hepatitis B, which I took example of hepatitis. So there was no supply of hepatitis in month of May and July. Similarly, other district like Devas, which has got once in a 4 month. So how erratic is supply you can see. And if supply is in such a way, then obviously you cannot supply to down level also. Yeah, another antigen we took is measles, which is very oftenly reported as a stock out. So here you can see the monthly requirement, standard requirement is 10,000 for Ujjain, but against that, how sporadic is supply, which is not matching with the monthly requirement. Similarly, for the other districts also, it's totally imbalanced. Yeah. Here it comes, when I visited 142 focal points, which is all PHC, CHCs where vaccines are kept. So you can see that there are some incidents like excess stock is also there. The stock out also happened there. And inadequate stock was also there. So stock out is almost zero stock situation. So if it happens in the field, so you cannot supply to a worker who is going to conduct immunization session in village particularly. So these all factors leads to poor immunization coverage in that area, and sometimes if mother comes to that health worker, but if there is no vaccine is available, she has to return without vaccination of her or her baby also. So all this overstocking situation as well as excess stock, minimum stock, all these factors also leads to wastage rate also. I would like to mention that one pentavalent vial which is being supplied in government system, it is costing 1,500 rupees per vial. So you can calculate how much is the overall cost for a district. Similarly, government is coming up with the new antigens also. In next year, government, probably next month government is coming up with the inactivated polio vaccine also. And down the line, rotavirus as well as mumps and rubella is also coming up. So government has a big plan to come up with the new vaccines. But if this is the wastage rate, then you can understand what will be the burden on the government system. So these are the certain reasons which are because of these overstocking of these situations. Because vaccine is a biological product, it needs certain temperature which is to be maintained at all level, from manufacturer to at last level also. So if there is no vaccine, temperature is not monitored, then automatically it is to be discarded. If its VVM is not as per guideline, then its VVM will become unusable. So we will have to discard it. Similarly, if FIFO and EFO, it's basically pharmacy people must be knowing, it's a basic norm where which is having first expiry, which needs to be first utilized, and another vaccine which is having late expiry, then which has to be used later on. So these are the factors which leads to wastage of vaccines. Yeah, now come to the point that the tool which we have developed to overcome such issues, we have developed one EVIN application. It's a mobile-based system where one worker, if he needs monthly stock of 10,000 DPT dose, then it should be monitored through that. And it can be, you can see, the person who is working at last facility level can put data entry, and it can be seen by district level, like district immunization officer, divisional program manager, and state level state immunization officer can also check that this is the current stock position at all levels. So automatically dashboard can be generated, and it can be monitored that which are the particular centers which are having poor stock or stock situations. So I'll come to next point. These are the, expected outcomes we believe, because we have piloted this project in UP, Bareilly and Shahjahanpur. So on the basis of that, first we have got the improved stock availability. It means that there should be a minimum stock should be maintained as a buffer. So no stock out situation should be there. Real-time data visibility. I'm sitting here, I can check that this is one of the district and its monthly requirement is this, and against it how much vaccine is available. So this is the, beauty of this app which we are going to provide. Tools and reports. There is no standard mechanism to get reports that how many vaccines are available and how much children are covered. So there should be some standardization according that it provides a uniformity also. A strengthening health system. Yes, certainly. If worker is knowing that this is my monthly stock which is required, and this is to be the guideline which we have to maintain for cold chain management. So these are the, we are strengthening of public health system where workers are trained, getting skilled. And if this model is sustainable, then it can be replicated in other areas of the country also. Yeah, this is from my end. Thank you so much.
We now call the next speaker, Chakrabarti, Amitabh Chakrabarti.
No, sir, Bagmiksha, second speaker. 8 point. She's not here.
Well, I would first like to thank everyone who has made this event the success that it is now. Since I have been here at this event, I have been constantly posed with one question. What is an IP lawyer doing in an event like this? So I have a very simple answer to that. Since we have been discussing information related to medical history of patients and individuals in general, it is a logical consequence that we also discuss the security and the confidentiality issues and standards that come as a corollary to it. First, I would give you a brief introduction about what personal information is as per the laws of India. Personal information is any identifiable information which is retained by any stakeholder, and when I say a stakeholder is any body corporate or which is involved in healthcare plans, provides healthcare supplements, or also includes every primary healthcare provider and other physicians as well. The moment a personal information is pertaining to medical history of any patient, it becomes protected health information. As we can see from here, protected health information could be in any format. It could be verbal, it could be in the physical format, it could be an electronic guided system. But anyways, the moment health information is a sensitive information according to the laws of India. Since I have been here, everybody has been quoting HIPAA guidelines. But unfortunately, I mean, since I have been discussing with all the exhibitors there, no one has quoted the IT rules that are in place. The Indian rules that are in place, the IT rules, specifically deal with the reasonable security practices and procedures that have to be in place while dealing with any health information by a body corporate. Protected health information, while I am a body corporate, if I'm taking information from a patient, I have to first explain to the patient that what are the intended purposes for which I am retaining such information and for which I might be transmitting such information to a healthcare plan provider or a third-party administrator for purposes of insurance claims and for any purposes. What happens in India is, for protected health information to be disclosed without the authorization and informed consent of the patient which is concerned with such information, it has to be only for the purposes of national utilization for any public health activities which the government wants to undertake, for determining what are the malignant diseases that are in place in the country, and for reasons like informing the organ banks and tissue support organizations to ensure that there is no that the medical history of the patient, the organ donor, is rectified. We get scared only when we know what is a consequence. So if I am going to a doctor and I am discussing about my ailments, and suppose I am diagnosed with depression, I won't be all that concerned about my security and confidentiality till the next day. Suppose say Novartis sends me a mail of what all the products that I can be using for depression. This is a breach of confidentiality and patient privacy. So that is the reason why I have been focusing on the part that when a person's health information is taken from him, retained on any server, transmitted to any other body corporate or party, the patient must be aware of the intended purpose and the time period for which such information is being retained and who are the possible recipients of such information. The security and privacy standards in India, like every, I cannot quote the companies that I represent or the healthcare organizations that I work for, but the point is every organization, be it in India or in the US or Australia or UK, they've always focused on one thing. They've always asked me to look into the HIPAA guidelines. Since in India, there are not this, till I actually started looking up on this properly, I did not know that there was an EHR policy which has been ratified by the Ministry of Health and Welfare in August 2013, which also talks about, which also refers to HIPAA guidelines and Snowbed City and all the vocabulary and clinical standards that are in practice. And India is a signatory to a lot of these treaties. Security and privacy standards, the first thing that one has to do where a body corporate is taking the information from a patient while transmitting it to someone else, the body corporate has to first de-identify the information, ensure that the information which is flowing from one party to other is not identifiable in nature. The moment it is identifiable in nature, you are breaching the basic privacy of the person. Privacy talks about who can have access to your information, and security talks about how unauthorized access has to be stopped. Reasonable measures. Everywhere that we look into discussing the security and privacy standards, we always come across this term, reasonable measures. The term reasonable is used in the legal domain as something which is reasonable to a prudent man. A prudent man for any domain is a person, is an expert in that domain. So for anything to be protected, one has to ensure that whatever the standards are, which are the general standards of practice in the area of subject matter, it has to be a reasonable effort. In India, the IT rules state that there are certain standards which are established and are generally accepted. So we can either stick with those standards, or if we create a standard of our own, we have to get it approved by the central government. I'll quickly I'll conclude to this. The solution, here I was discussing about issues till now, but the solutions that can come to our help are first that is we need to have an implementation of electronically stored protected health information on a secure channel. As a medical patient myself and as a lawyer, I can tell that since I'm moving from one city to the other, if I'm switching between hospitals, it becomes very difficult for me to convince Apollo to give me my information and then I can show it to Columbia Asia. So the point is, in a heterogeneous health environment, having a unique health identification number, like the US has an SSN, and so we have all the information on one cloud and server, and it is accessible by everyone across the heterogeneous environment. I would like to, as a lawyer, we are working on policies which will be in place to ensure that there is a system, there is a unique identification number which retains the medical history, my past, present and future medical history related to my parents, anything, because in lifestyle disease it's not the person's individual history which is taken into account, but also the history of his or her family members. The third thing is, okay fine, I'll just quickly explain what these are. These two things I have referred to, this is a patent application which has been filed in the US, which shows how a user who is subscribed to, say, an app, which we can see in all these exhibitors have been talking about, how he can control the level of authorization that he is granting to every user. So where one user is the doctor, the second being a super specialty physician, the third being a healthcare provider, the fourth being a third-party administrator, the client, the user, the patient himself has the ability to control the level of authorization and the level of access that he will be allotting to any of these people. The second granted patent application that I'm talking about is, it just gives a flow of how a software and app will come to the help of a patient for creating an EMR. So I won't be talking about this, it's difficult to explain. Having an EMR and having an app which supports my medical records across heterogeneous environment not only assists me as a patient, but also helps the third-party administrators and insurance companies to look into risk-adjusted payment models. Now the problem is where every time, like in India, not all companies or not all hospitals go for cashless transactions at all times. So it's either cashless or we get reimbursements. So having an EMR system and having a uniform EMR system in India will actually help us create a model where this can be implemented at a larger level. And I would finally like to conclude by saying that since we are already talking about the information which is being retained, which is being collected, which is being transferred to other parties for the benefit of the patients and the convenience of the hospitals, there is a need to look into the security, the privacy and the confidentiality issues and the compliances that one has to make sure so that there is no legal consequences that follow. I will conclude with that. It's okay. Thank you so much.
I now call upon the next speaker, Mr. Divesh Dubey. Before he starts, I have an announcement to make. I understand that his bag has been misplaced and that his bag contains his driving license, college ID, etc., etc. These are very important. If any of you please locate it, please hand it over to the counter here. And I do hope you will get it back. Don't get worried about it.
So, as we know, today's date, I'm talking about today, India's healthcare industry is 110 billion US dollar, and we are expecting to reach 280 billion dollar by 2020. And if you talk about and US healthcare market is around 300 trillion US dollar. it's more than our actually national economy. And they're spending around 90 billion US dollar in health IT. It's near to our healthcare industry. Now we'll start with the EMR, the topic. We can see a global EMR market by region wise. You can see in 2012, the Americas, North America and South America, market is 9.1 billion US dollar, EMR market. And again, EMEA, European and Middle East and Africa, the market is 6.5 billion US dollar. Then Asia and Australia is 3.2 billion dollar. It's increased in 2015, you can say 7.1, Europe, America is 11.2, and Asia and Australia is 4.0. You can see the total EMR market in the world globally, 22.3 billion US dollar. And it's increased 5.5 growth. Is that working? Yeah. So, EMR in India. During the 1980s, there was a competition between few companies that who will develop EMR in AIMS, All India Institute of Medical Sciences. So TCS had won the opportunity to develop EMR in India, and they developed patient care system during the 1990 for AIMS. And that got actually failed due to some bottleneck. There was no coordination between them, and there is no effort. They just put it and they did not use properly, and they did not get revenue actually. So in 1996, they decided to shut it. Then around 5-6 years back in 2008, some of entrepreneur has started to develop EMR. And in between, we got around till now 35 domestic EMR vendor and 120 international vendor. In 5-6 years, and the last 2 years, 2013, Ministry of Health and Family Welfare government, our government actually, has come with some standard, which is actually a recommendation, not a law and a rule or regulation that you have to use that. It's just a recommendation. There is an N number of recommendation, but I come with only a few, which is very important. Even US look into this. So this is UHID, Unique Health Identifier, we say, and for data capture, and HL7, which we all know, clinical data for inter-department documents. So some of the major EMR provider in India and some of the hospitals in India who are using EMR. We can see Amrita Institute, Apollo, Fortis, Manipal, Satyasai Hospital, and some of the IBA Health, German company, and Wipro is Australian company, Siemens we all know, Z and CDEC is our IT companies, Indian company. So what actually drive EMR in Indian market? Now people are young, we all know. They know about healthcare awareness. Every day life is changing and them lifestyle is also changing. Demand of quality, competition between hospital like Fortis versus Apollo and other hospital also. Cheap quality will encourage for international patient. We know some of the cardiac operation in Australia, in US, they charge 20 lakh rupees. If we convert into Indian rupees, here we spend only 3 or 4 lakh. So what is the current status of EMR in India? EMR has the highest penetration in India compared to South African nation and some of Asia's nation. So it's a 13.5% of in the last 5 years, and we are expecting to increase the same rate because of the upcoming hospitals and projects. So what is actually challenges for us for adopt EMR in India? We can say Indian individual challenges. If you talk about the individual challenges, then, okay, individual challenges, then doctor, many of the doctor doesn't know how to use computer, forgot about the EMR, okay. And some of the people like them's age is 60 year, 50 year, they are not interested to use. And if you talk about the psychological challenges, it's a user's interest, if they wanted to use or not. It's up to them. If they are satisfied with the EMR, them's emotions, all that. Organization challenges. As I said, there's a lot of hospitals using EMR in India. Even there is some of hospitals also using, but sometimes they quit. sometimes they use, don't know the reason, and how long they're using actually, and which department they are using. So continuous they are not using. What were the financial challenges? Setup costs, ongoing cost, and one of the most important, investment, whatever investment they are getting that money or not. And then legal challenges. Just like US have a HIPAA, they have a privacy and security. What about privacy and security in India for EMR, for patients' health information? And then technical challenges, training, technical trainings. Conclusion, I believe that there's a lot of major factors which I showed you, and these are the major challenges which actually affecting to adopt EMR in India, which is very slow because of that. I'll recommend one thing, that being doctor, I'm not doctor obviously, if I'm doctor and the software is developer and hospital manager or CEO, need to talk with the doctor. They have to talk with the way doctor think. Ask them which way you want EMR. Sometime, obviously they do not want to type, because the way they write, the way they want to type, and the keyboard is not like that. Right. So these are the references. So if anybody have any question. Huh?
Thank you, Dr. Dubey. We'll wait for the...
Thank you.
We need to keep up to time. May I request Mr. Maman Paul, is he here? Yeah. He's going to talk on a very important subject, adverse drug reaction. As most of you probably know, a paper was published in JAMA, Journal of American Medical Association, 3 years ago, which documented 150,000 deaths every year directly due to adverse drug reactions. So adverse drug reactions causing mortality and morbidity is a significant clinical problem.
Thank you very much, sir. Good afternoon to all the eminent personalities who are on and off the dais. My topic is, I developed a software and it's adverse drug reaction reporting as well as monitoring. I will skip this slide. We all want our babies to be like this. That is cute and bubbly. But when I Googled some of the images for thalidomide tragedy, I could see these images. That is, these were the babies born after the infamous thalidomide tragedy. During the late 1950s, a drug called thalidomide was introduced into the market for alleviating morning sickness of the pregnant women. And the babies delivered by them were having a rare congenital disease called phocomelia. As you can see, it's a reduction in the limb size. So, what is an adverse drug reaction? Adverse drug reactions are, as you can see from these images, are noxious and unintended reactions which occurs at normal doses when given to a patient for the prophylaxis, diagnosis, or for the treatment of a disease. So, in developing countries like India, adverse drug reaction reporting as well as monitoring and also the pharmacovigilance system is in a budding stage. Whereas in developed countries, it is having a proper channel and proper system for that. So, we are basically reporting through paper-based forms, and this faces many challenges. Challenges like communication gap between the healthcare professionals and time consumed for this reporting, or the data storage, how this data can be stored, these paper-based forms, and as well as the retrieval of these data. We can't just check out the piles of papers, and also the analysis of these data. So we face many challenges like this. While I was thinking about these challenges, we are daily reporting adverse drug reactions in our hospital. And I was thinking this problem should be solved somehow. These problems have to be solved somehow. And I came up with an idea that why can't we make a software for that so that it can be reported and communicated as well as data can be retrieved as well as analyzed with the help of a software. And these challenges were the motivation behind this development of the software. And the stage one was a planning phase during which I decided the front end to be Microsoft Visual Studio and the back end to be SQL Server. And I developed, after the development of my software, during the development I faced many challenges like how can we make this user friendly? We have to make this user friendly so that all the nurses and physicians, pharmacists, etc. can use this without having any technical expertise. That is what's more important. So I did this through developing dashboards and shortcuts so that they can easily assess this. And another challenge was that how this data can be communicated. How this can be communicated with a physician. Normally we, in our hospital, I am a student, I am a doctor of pharmacy intern, and when we report, it's to many of my friends, they have difficulty in reporting because they are a bit reluctant to report the ADRs, adverse drug reactions, because how the physicians will respond to that. There are many problems like that while we are reporting this adverse drug reaction. Basically due to the unawareness among the healthcare professionals. So, this communication, how can we solve this communication gap? So I thought of that, and why can't we email the physicians on the spot? That is, while we are reporting the adverse drug reactions itself, it will be automatically mailed to the physician's mail ID or a common mail ID of the hospital. And this was after finalizing all these things, after finalizing the software, my friends as well as the teachers at my college, they evaluated, they lively tested this product, and based on their recommendation, I tweaked some of the parts, some of the user-friendly designs, etc., and finalized the product to its ultimate perfection that I can get. So there are many features apart from the reporting that I mentioned. We have to solve many challenges. Like apart from the adverse drug reaction reporting, there is an advanced search so that the physician or the nurse or any other healthcare professional or a clinical pharmacist for that matter can search through the database. If a patient gets readmitted to the hospital, we can check whether the patient had an adverse drug reaction before that. And we can make necessary arrangements so that that adverse drug reaction doesn't happen another time. And reports can be printed out and also can be made soft copy, can also be kept on the hard drive as we wish it. And as I mentioned earlier, emailing can also be performed automatically. It's mailed to the physician's mail ID. And Naranjo scale is provided so that the causality of that reaction can be also measured by the reporting personnel. There are, hello? Sorry. I have also taken some of the screenshots of my software and I have put it here. This is the login screen. This is the login screen that I developed and through which the healthcare professional enters. This is the adverse drug reaction reporting form through which the healthcare professional can actually enter the data, and it can be saved or edited or whatever you want. And it has also an additional panel for adding a photo so that the reaction can also be visually recorded. These are the reports that I was talking about earlier. These are some of the reports actually. The first one is actually a notification of the adverse drug reaction that will be emailed to the physician. This is actually actual one that is emailed to the physician. And the next one, the second one is the actual adverse drug reaction reporting form that is based on the status quo's form. We can also take reports based on the brand-wise or generic-wise, etc. That's additional option that I have provided. And with all these features, what I am saying is that, in short, the adverse drug reaction reporting and monitoring software is embedded with these features and can be used in any healthcare facilities and can provide a pharmacovigilance that is on par with other developed countries, and we can improve our pharmacovigilance system as well as adverse, that is a part of also adverse drug reaction reporting to a much better extent. My next step towards this is implementing it in as many healthcare facilities as possible. And also, this software with all these features has the potential to become the backbone of national pharmacovigilance, since it requires minimal infrastructure and there is no money wasted on much of the infrastructures, as well as it can be used in rural areas too and in any healthcare facilities. So what I'm saying is that this has the maximum potential to be the backbone of national pharmacovigilance program. And I am saying that as an Indian, I believe that I develop India. And with that, I am giving a great salute to our President APJ Abdul Kalam, whose birthday was on, former President APJ Abdul Kalam, whose birthday was on 15th October. And thank you, and Jai Hind.
Thank you. I now call upon the last speaker for this session. She is from Iran, Lida, who's going to talk to us on home spirometry. We do have a few minutes for question and answers. May I once again request you to please use the software so that all the questions are displayed on the screen. Yes, Ms. Lida.
Good afternoon, everyone. I'm Dr. Fadaizadeh. I'm from Iran. And I have a presentation which is entitled Home Spirometry, Assessment of Patients' Compliance and Satisfaction and its Impact on Early Diagnosis of Pulmonary Symptoms in Post-Transplant lung transplant patients. Since it's a telemedicine conference, I think I should skip this part, but as you know, we usually use telemedicine for consulting, monitoring, caring, and performing different procedures. And we use different means of telecommunication for this purpose. But one thing that I want to talk about this afternoon is that monitoring patients, mostly patients with chronic diseases and life-threatening situations, is very important. And we as doctors, we are very concerned about this, the follow-up of our patients. Mostly lung transplant patients, which are very susceptible to different infections and many different complications, are very important in this regard. So an early detection of disease is very important also. That's why we tried monitoring these patients via this telecommunication system and actually lowering the rate of transferring them to the hospital just for checking up and while they don't really have any problems. As you know, remote spirometry is an approach, and that it contributes to timely monitoring of patients, and it's a very efficient tool for measuring the lung function of the patients, especially patients with, who have undergone lung transplantation. And any difference from their previous reports is very important for us, and joining that with the symptoms of the patients is very important because it may show that they are developing either rejection or infection. What we evaluated in this study was that we tried to assess the issue of adherence and their compliance with performing these spirometries, and they're actually sending their clinical symptoms that they had. And what we did was that this is a cohort study, and it was performed on patients who had undergone transplantation for, it was their first 6 months after transplantation, and they could participate in the study, and they were given these spirometer devices, and we asked them to send us they were asked to measure their FEV1 every morning, and they were asked to send us along with the clinical symptoms that if they had, like for example, if they had sputum, if the color of the sputum had changed, if they had cough, wheezing, or dyspnea. And this study was conducted over 6 months, and the first 3 months we asked them to send it daily, but during the second 3 months they were asked to send it on a weekly basis. And we asked the patients to tell us about their satisfaction with the method of following up compared to the follow-up that we used to do by referring to the hospital every week or every month according to the guidelines that we usually use. Actually, we had 15 patients who participated in the study because, as I said, they had to have 6 months from their operation, and their average compliance was 78%, which is, compared to the other studies that we had, it's a very high level. And the level of as we studied the level of compliance, we saw that the level of compliance started to decline over a few months. But again, after we asked them to send it every week on a weekly basis, the compliance again started increasing. And this is the percentage of patient adherence to performing these spirometry tests. And the satisfaction of the patients, studying the satisfaction showed that the sense of increased support from the medical staff was rated highest. That was 92.9%, and the least was using the spirometer. And the changes changes of FEV1 over time was not very statistically significant, and fortunately our patients remained stable during the study period. And this is the graph of the FEV1 changes. And in conclusion, what we concluded from this study was that there's a relatively good adherence and satisfaction considering using spirometry for the patients and asking them to send their symptoms via an SMS that is previously given to the patient, and they were asked to fill in and give it to us on a weekly or daily basis. And the highest satisfaction is to have the support of the medical staff all the time and being able to communicate with them whenever and wherever they wanted. But their least satisfaction was with using the spirometer device, and that was because they were concerned with the sterility of the device that they were using, and they thought they were not using it well or correctly, and they thought maybe it is not as accurate as the ones they used to use while they were referring to the hospitals. But one other thing that was very important was that using these mobile phones was very satisfactory for the patients. They could use it anywhere and everywhere they wanted, and they expressed fully satisfaction. That is 85.7%, which is considered a good amount. And a main purpose of telemedicine is to avoid unnecessary referring of patients to the hospital. And one of the patients that really needs to be taken away from the hospital and they have to have the least referral is the patients with lung transplantation or any other transplantation, because these are susceptible to infection due to the immunosuppressive drugs that they are using. And so also, these patients are very sensitive to infection in the community because of using these drugs, and so they need to be chronically and during a long period of time, they have to be followed up. So using these spirometries and telespirometry and using the mobile phone can help us to shorten the time of patient evaluation and also actually avoid unnecessary patient referral to the hospital. And thank you for your attention.
Thank you. Do we have any questions or will? There are already drug reactions. How is your? Yeah. Can you answer this question, please, on adverse drug reaction? The author of this paper. Marman Paul.
Actually, the thing is that we do not have a national database. It's actually WHO collaborated VigiFlow. We are using right now as software and is not used in many of the, it is not available in many of the hospitals right now. Only a few hospitals are having.
Please answer the question. The question very clearly says your software on adverse drug reaction is not the first software in this country. How is your software, what is the differentiator, how is your software different from other existing softwares which also lead to, which elaborate in great detail about adverse drug reaction? That's the question.
Okay, the software, as I mentioned, has many features that I already explained. That are the features that is that is being highlighted by me. That is, we can take reports and other things from that software, and it doesn't need much of infrastructure. It only needs a single computer to use that. That is, it can be used in any rural healthcare facility where there is a lack of proper infrastructure with high bandwidth of internet or anything. We can use the software there in much effective way.
Okay. Okay, thank you. I think the second question is very important and practical. Please give her a mic.
Well, for patents in India, it is not possible to patent an app, a software in India. Software when connected with hardware is possible. There is a possibility, there is a slight chance that you can get that patented. We have to keep in our mind that India is a social welfare country, sorry. So we have to ensure that not everything which is in the domain of technology is enjoys monopolistic rights. So as of now, there is no law to patent an app in India, a software in India, but the moment it's tied with a hardware which is innovative and which has extremely novel features tied to it, it is only possible to patent it then.
Can I ask a stupid question? Is the patent for an app national or international? Is it a national patent or a global patent? Anywhere in the world I'm asking, not in India.
I'll tell you. Every intellectual property right is territorial in nature.
Sorry, say it again.
Every intellectual property right is territorial in nature. Unless in
is what?
Territorial.
Territorial, okay.
I mean, it is bound within the country that you are subscribing in.
Okay.
So if I want a patent to be valid in India and across the globe, then I have to go through something which is known as a Patent Cooperation Treaty, which we are a signatory to. Or what we can do is we can go and file individual applications in every country that I want it to be protected. Same is for every other IP right.
For Aditya, Please answer the third question. What is the risk-adjusted payment model?
A risk-adjusted payment model is, okay, fine. What happens is, I'll have to refer to the US healthcare system when I'm explaining this. What actually happens is, if I am subscribed to a healthcare plan, they have apps. Most of the companies there which provide healthcare solutions also have softwares which enables the patient, I mean the client, to utilize the app to make appointments. And there is a, I mean I'll be disclosing, okay fine, I can explain it to you in a better manner. There is an option that either I go for an appointment, just a consultation, or if I'm in a very bad shape, then I have to go for ER. So what happens in this process is, if I am rectifying, if I'm identifying the patient at the very initial stage of his or her ailment, then what happens is the insurance, the healthcare providers, they do not end up paying for when the patient is actually going into the ER. So it is a model which helps the healthcare providers to identify the patient at the initial stage of their ailments, so as not to incur heavy expenses while the claim adjustment process.
I really don't know what the fourth question is. Maybe the person who typed in that question could elaborate. I don't know what you are referring to. What quality controls have you used? To which stock are you referring to?
Okay, so this is for me, I think. So what quality controls have I used? So thank you for the question. So when I use my system, I compare it against clinically used pulse oximeters. So actually I've tested it on against 3 different pulse oximeters, and I'm trialing the system in an NHS hospital, so that in the UK we have this national healthcare system. And so there's one hospital that I'm using for trialing the system in NHS Fife. And so actually, the way I can get different oxygenation levels is I'm going into a respiratory ward where there's patients with lower oxygenation levels. Normal healthy people have nice high oxygenation levels, but that means that I can't test the system unless I go in to see in wards. So that's why I'm testing it in there. Hopefully that answered the question. Thank you.
Okay, thank you. I presume the last question refers to the data on vaccines.
Correct, sir.
Could the presenter on vaccines respond to this?
Yeah, thank you for the question. It will work like a transaction. Suppose one amount is credited and another one account is debited. So suppose if one district person is distributing vaccine to block, so it will be also recorded, as well as block will also record as a receipt. So 2 ways we can monitor that, and that data will be monitored at each level. I'm sure that I have answered his question. Thank you.
If there anyone likes to make any observations from the floor for 2 minutes, anybody would like to make any comments? Not necessarily a question, but any comments or observations? If not, I'll just make 2-3 comments before we proceed with the formal distribution of mementos. You would have noticed that we call this session Spectrum of HCIT Innovation, and this truly is a spectrum. We have had presentations varying and showing us the deployment of HCIT, adverse drug reactions, how to improve the chain in vaccine storage, which is extremely vital and important. We have had a lawyer talking to us about intellectual property and various other things. Personally, I feel, of course, I know the climate is changing. Unfortunately, in the 20th century, when I became a medical doctor, the words trust, faith, honor, these words have totally been removed from the dictionary today. Today, when a doctor encounters a patient, even in India, the first thing he thinks of is this guy going to sue me or not? Yes, he may sue me, so why should I take a chance? Let's get a CT scan done. Let's get a diabetologist's opinion. Let's get an endocrinologist's opinion. We have started practicing defensive medicine. We are just following and aping the West. To people like me, it is very sad that a patient no longer trusts a doctor no longer trusts a patient. This is, of course, a problem with the entire society. I don't think we can do anything specifically. Now, adverse drug reaction is not, I'm very happy a young person like you is full of bubbling with enthusiasm and energy. We'll certainly do our very best to encourage you. But in the real world, adverse drug reaction from a clinician's point of view, from a practicing doctor's point of view, is extremely complicated. It depends right from your genomic profile. It depends on your liver function tests, on your renal function tests, on the ability of various enzymes to metabolize your drugs, drug-drug interaction. You know, there are at least 150 different variables which will influence a drug reaction, and it will be extreme. My only suggestion to you is, please, and this is one thing which I have noticed over the last 6 years this conference has been running, whatever progress HCIT has made, I fully acknowledge that to a large extent it is because of the industry, it is because of software specialists like you, application developers like you, hardware developers. The medical community probably has not contributed too much. But having said that, I am afraid, I worry, I dread the day which is already appearing when many of you work in isolation. Please do not develop a software on adverse drug reaction without working closely with a clinician, not with a pharmacist, not with a pharmacology department, but with a practicing neurologist, rheumatologist, an internist, a surgeon, etc. Please get their inputs before you develop any application, any software. Your software must be of practical use to us. Technology in search of an application will not have long life. I should come to you and tell you, look, these are the problems I have. I want a software like this. This software should address this, this, and this item. I really find this lacking, and I find most of the people, including doctors, we work in isolation, you work in isolation. I think there must be a much, much better, closer harmony, and we should not work in isolation. EMR, of course, this morning we had 2 papers, and you have again told us the importance of EMR. I think we covered most of it, patient data, etc. I still have 2-3 minutes time, and if anybody wants to make a comment, yes, please. Please introduce yourself. Give him the mic. I mean, Sridharan from American Megatrends doesn't require an introduction, but still.
So there was this question on patent, and I thought I would answer that question. So American Megatrends, we have more than 300 plus patents across the globe. In India, we have applied several patents. So as she rightly said, if you want to have a patent done in India, you need to have a hardware. And you need to have a very unique value proposition with your hardware. Then you can have an SDK or an application going with it. And especially when you are getting into the medical field and when you are building devices, make sure it passes all the electrical safety requirements, biomedical requirements, because if you are going to create a wearable, it is going to touch the screen. So when it is touching the skin or when it is working with the samples, it should not cause any kind of itching or any kind of reactions. So that is another important aspect, all the electrical safety and ensuring all the, so if it is a wearable, you need to make sure that there are no reactions. And if you want to have your patent taken globally, you need to apply something called as a US GPO kind of a thing. So first you get the patent in India. Patent in India usually takes anywhere between 2 to 3 years. Sometimes it takes more time than that. Then you can go for the international patent. So just having an app or a software, and if you're trying to get a patent in India, it is not possible. However, in United States, you can have patents for the solutions, where you can have patents for applications and indigenous software design, which you can get it in the United States. But in India, you need to always have it with the hardware. Thank you.
Yes, sir. This and one more comment, if any.
Yeah, I'm Gaurasundar from CDAC Pune. I have a kind of advice to all the, I saw the presentations and they are fantastic, and I'm very happy that you guys are all working on these cutting edge things. But my advice is that, especially in terms of the one that you're doing about pulse oximetry and the one that you're doing about ADR, we as a developer have to understand that there are already a huge plethora of applications in hospital and for clinician. We are just overloading them with too many applications for too many things. We need to start developing software and components in such a way that is pluggable within a larger environment. We rather than developing another application which covers one more area of one more aspect of healthcare, I would expect that or rather I would suggest that you develop a component which is pluggable easily into an existing HIS or an existing EMR system. Then it will go a long way, because then the learning curves come down. It can be utilized by another developer into a larger thing. So that is one way that I would think, and that is what we have been working at CDAC. Most of the development that we are doing now is in the middleware. We are creating more and more SDKs. We are creating more and more libraries which can be integrated into larger application rather than one more application doing one thing different. So that's it.
If there is no other comment, before I go to a very pleasant function, Frank, please come. We have tried to be as objective as possible. We have taken one visiting card from each of the, two is it? Two. We have taken 2 visiting cards from each of the stalls and put 30 cards here. Those 2 cards were chosen absolutely at random, blindfolded. We have put 30 cards here, and before, I don't like to become personal, but I can't resist the temptation. I have been attending neurosurgical conferences from 1975 onwards in India, outside India, and I must say it is extremely unusual to find at 3 o'clock on the afternoon of the second day of the conference, when the conference is going to close down in another 1.5 hours, to find the entire hall room packed. I must say this is in medical conferences. I think this speaks volume. I was secretary of the Neurological Society of India for 6 challenge to have as the last session, but even then it wouldn't work. I'm absolutely thrilled to see this hall totally full. I don't see any difference between yesterday morning and today. So once again, I think you're a great audience. You are put up through all this, and thank you once again, not from the bottom of my heart, not from the bottom of my heart, because I believe that the heart is just a pump which pumps blood, but from my brain, because I think this is not an emotional knee-jerk reaction, but a cold, calculated, objective, scientific statement. So thank you once again. You have been a wonderful audience. Now, I'm now requesting Frank to close his eyes. Close your eyes.
Just say something. Yeah, something. There is one solution. That is when there is an Icelandic volcano outbreak, that everybody is stuck in a place of a conference till the very last moment, which happened to us.
So please choose one card, and before you choose the card, this is a Kindle white, paper white, given as a very small token of our affection to all of you for being here, but on the condition that the person whose visiting card is here is physically here to collect it. Otherwise, we'll go on collecting card after card after card till we find one person who is physically here. Yes, sir. You are excluded if you have put your card. Then they'll say rigging and I am responsible. And the winner is, just like Miss Universe or Miss World, we will wait for 30 seconds for the suspense. Normally you would start from 3-2, but here there's no 3-2. It is from Somerset House, Strand, London. Mobile number, telephone number. Okay, I'll give the name. Mr. Galib Khan, Director, Written Medicine. Are you here? Mr. Galib Khan from England. Okay, next. Can I put my card? Pixel Health, COO, E-commerce and wellness Asia Pacific, Mr. Verma. No. My God. Probability, you're all experts. You develop an app which gives you the probability. Akshaya Technology Services, Healthcare Technology and Business Analytics. Mr. Ramkumar? No. The first three are not here, I'm sorry. I would like to welcome Mrs. Preeta Reddy, Vice Chairperson, Apollo Hospital, and Mrs. Sangeeta Reddy. Please do come, madam. Okay, this is the fourth card. I hope at least this person is here. AJ Hospital and Research Center, Mangalore, Dr. Prashant. My God, nobody is here. I'm just saying whether I can put my card inside. 4 people, all 4 are not here. Pixel Health, hey, this is not fair. No, okay. 2 cards are the same person. No, Amish Verma. No, it's the same person.
Shall I collect the
No.
cards here? Shall I collect the cards here?
Yeah. Which cards? Let's wait and see. Manjula, Dr. Manjula, GJM Hospital. Okay. Yeah. AJ Hospital, Dr. Amita. There are so many people here, but yet not as a. Okay, I think you start collecting the cards. Start collecting cards from everybody here. Ranjit Chatterjee. No. Okay, please give us your cards. Dr. Chetan. Oh yes, stop it, Srinivas. Please prove your identity. Tell me what is written on this card. How do I know you are the right person? So tell me everything which I should find on the card. Please tell me, let me double check.
I studied in IIT Kharagpur, so it's a IIT Kharagpur card. It's an
yes.
old card with
Yes.
my number striked out with the.
What is your number, please?
There are 2 numbers there.
Yes, tell me. Tell me, what is the number?
966-376-1327 is my second number.
Okay.
And the first number is 8900479012.
Okay, you are the right Chetan. Okay, good. Dr. Chetan is a very unusual emerging species, and I'm absolutely fascinated by him and his like. He's an MBBS who did a 3-year course in IIT Kharagpur. He has a master's degree in medical science and technology, a full-time 3-year course in engineering done by an MBBS graduate. And I think this is the future. I think it's very appropriate that he got this prize, because this is the future of healthcare management, where a doctor who's a full-fledged engineer runs a healthcare system. And I'm very happy that you have got this. You get it.
Thank you very much. My pleasure.
Mrs. Preeta, just before you came in, I made an announcement, which in your presence I would like to repeat. I said I have attended hundreds of conferences from 1975, medical neurosurgical conferences. I have never ever found on the second day in the last session with 1 hour of the conference to go, an attendance which is exactly the same as it was yesterday morning. I think this is absolutely unique. I mean, no conference do we have the same attendance as yesterday morning.
I think the magic is in the audience.
No, that's what it's a fantastic audience.
Yeah, I noticed that. I think it's the audience who've been so fantastic. We need to give them a big round.
including your pacemaker and defibrillator, how you could change the program so that your heart stops. Come.
Miss Bagmishika.
She is an intellectual property specialist and advocate who spoke to us on legal aspects
Mr.
of
Gyan Sharma.
patent applications, etc.
Mr. Devesh Dubey.
Next.
Mr. David Harris.
Come, David. He's from Scotland.
Mr. Mammon Paul. And Ms. Lida. Ms. Lida? Yeah. We have her.
I would also request Dr. Pitta Reddy to please hand this over to Srikanth, who did a fabulous job in screening so many presentations and putting this particular session together. Srikanth? The original full articles of all these people have been gone through, reviewed, and we're going to bring it out as a publication, as an ISBN publication.
We have Ms. Lida here, sir. She was the speaker.
She's from Iran. She gave a beautiful presentation on post-lung transplant spirometric monitoring at home. 20 people with lung transplant done who were monitored with spirometry at home in Iran. She's an anesthetist.
Thank you, ma'am. Thank you, sir. Ladies and gentlemen, we will have 2 parallel sessions now. The workshop on social media planning for hospitals, which is mainly directed to doctors, hospital top management administrators, is taking place in the main hotel, in the first floor boardroom, which is beside hall number 3. So we request the interested people to please gather in the boardroom in another 10 minutes. The next session in this hall is on innovation in healthcare and an open forum with startup companies. This session will be moderated by Mr. Madhu Aravind, the CEO of Searchlight Health. The panelists are Mr. Mohan Kumar, the Executive Director of NPP India, and Ms. Lisa Prasad, the Managing Director of Global Innovations at Henry Ford Health Systems, United States of America. May I request Mr. Madhu Aravind, Mr. Mohan Kumar and Ms. Lisa Prasad on the stage, please.
can we reach the network?
Hello. Okay, I think we'll get started. Basically, this is a session that's going to be focused on few of around 14 of the startup companies who are going to be presenting what they're doing. So this session is going to be broken into two segments. One is there's a set of panelists sitting here who are kind of representing various aspects of what people do in a healthcare ecosystem. There is a viewpoint from an entrepreneur perspective, that is Tushar. There is an investor, Mohan, who is an investor partner with Norris Partners. And there's Lisa, who is heading global innovation for Henry Ford. So their viewpoints are going to be from different perspectives, from being an entrepreneur to being an investor. And the way it's going to work is they're going to actually speak for a few minutes to give context to what they do and how it fits into the bigger picture. And after that, there's essentially the startup folks are going to be presenting for 5 minutes on what their product is, the value prop, and so on and so forth. Before we get started, let me just spend just a couple of minutes to provide an overall context. So overall, during the last couple of days, during this conference, you would have heard that there are a lot of opportunities that is there in terms of gaps in supply demand. There are lots of viewpoints like the current products that are out there. Consumers are not very happy. There are people who find it difficult to figure out what the right hospital to go to, or the right doctor to go to. There are people who are not happy with the insurance products that are out there. There are doctors who say that the EMR that they have doesn't work for them. You know, they are trying to circumvent that problem. So there are a lot of aspects that are out there which is kind of depicting the pain points that consumers are facing. That is, consumer being an end patient or a user like you and me, or doctors, hospitals, and so on and so forth. Now, the key thing that I see is that I sincerely believe that while these problems are going to be solved, these problems are not going to be solved by the current incumbent companies. And what I mean by that is, typically a company that specifically, let's say an example into software, that is very much geared towards optimizing workflows, you know, internal stuff, efficiency, and so on and so forth. As an example, what yesterday one of the docs said, he hates using an EMR, and they're trying to make that process better by making it voice enabled and so on and so forth. Is an example of that, where such kind of changes are what typical enterprise software companies look for, and they do not yield a 10x improvement to the end user. On the other hand, startups that are outside don't care about that. They try to figure out various different ways outside of workflow, how to leverage the data out there, how to use latest machine learning technologies, and they're going to actually try to figure out how to actually create that 10x value prop to the doctor or to the patient so that they actually use the system, right? So that essentially is going to be a different way of looking at it, and sincerely believe that the current guys might lose the plot on that. And so it's a fantastic opportunity for the startups out there. So as and when the guys are going to be presenting, you'll see the kind of viewpoints in that. So before they get started, let me actually give the mic to Tushar, who can introduce himself on the context, what he does, and so on and so forth.
Thank you, Mohan. My name is Tushar Vashisht. I run a company called Healthify Me. It's in the preventive wellness space, and we've been doing it for almost 3 years. We've secured 2 rounds of funding, are helping 2 lakh Indians get healthier and fitter and avoid lifestyle conditions like metabolic syndrome and diabetes and hypertension. And we're growing about 20 to 30% month on month. We work with Apollo's Delhi division. We work with Medanta and Manipal and some of the other healthcare systems as well. We work with corporates and directly with consumers too. I think, one, it'll be interesting to talk, to structure my quick context making in 3 sections. I'd love to talk about, one, how is the fundraise strategy evolving globally and in India? Second is, how as an entrepreneur my journey has evolved in the last 3 years, and third is sort of what's coming next that I think is relevant for all startups. And since you've given me 3 minutes, I'll try to wrap all these amazing themes in just 3 minutes and not waste people's time. So I think, first of all, let me begin by saying that it's an interesting topic for the conference, transforming healthcare with IT. I can totally imagine that about a century ago, there would have been a similar conference where people would have said transforming healthcare with electricity, when electricity was first introduced, right? And I think a few decades later, electricity was completely mainstream, and we don't talk about how do we revolutionize healthcare with electricity today, because it's just taken for granted as an integrated, embedded form of healthcare delivery. And I think information technology is doing that to healthcare today, except it's not going to take us a few decades to be integrated with, just like it took with electricity. I think it'll be a matter of a couple of years. And the offtake with information technology and the integration between IT and healthcare is moving at a rapid exponential level right now. So with that stage being set, let me talk about fundraising first. This last year, this 2015 year till date, globally there's been almost $2 billion of investment that has gone strictly for startups in healthcare IT as you would call it, globally. That is 3 times what was invested in 2013. What is further interesting is that 10% of the 2 billion, which is 200 million, has been invested strictly in India, which is pretty amazing. I mean, I think a 10% of anything global for India in that scale is pretty outstanding. I think that beats all benchmarks. I mean, we don't represent 10% of the world economy. We do not represent 10% of infrastructure investment, but we do today represent 10% of global investments in healthcare. I think that is fascinating and interesting because I think healthcare investments is kind of moving from the fringe to the center. I'm sure my eminent co-panelists here would talk a lot more about it, but I think in the last couple of years we saw a lot of spends on taxis, on food deliveries, and on various other interesting space. But I think healthcare is kind of finding the focus of in the investor community, and will continue to find it more so globally and much more so in India. And as an entrepreneur, I'm obviously extremely excited about that because we started in 2012, and I think when we went to VC saying we want to do something in the health tech space, it was always a tough sell. But we're finding that two fundraise rounds later, and the second one, the bigger one we raised earlier this year, was a much easier conversation. And I expect to my other budding entrepreneurs also have a far easier conversation in 2016. Now let me talk to you about my journey. We started in 2012 when people were still on Blackberries and were kind of adopting the curve. Today you've got a 200 million captive audience which have smartphone, right? And another 400 million which have feature phones. So information technology is the reality of consumer. So in my opinion, the next biggest innovation that is going to come through is not about how we can revolutionize current healthcare practices with information technology, but how we can empower and enable the consumer with better healthcare access on something that is ubiquitous, like their mobile phone. And I think from an entrepreneur's perspective, that is something that we have been doing. So we started in 2012, guys, just like many of you, with an idea that we can use the smartphone to prevent conditions which are linked to lifestyle by helping people change to a better lifestyle. We built the world's first Indian calorie counter with tens of thousands of Indian foods and databases that can help you track all your micronutrients. Then earlier last year, we evolved that into a full-on remote coach where we introduced nutritionists, fitness trainers, and yoga instructors that would look at this data and then give contextual feedback. Now, with the advent of greater power in the smartphone, like the access of sensors like GPS, pedometers, smart cameras that can access data, and my job of tracking data has become a lot easier. And I expect that trend to continue. So today, I don't need to have a wearable or a pedometer tied to my arm if I want to track steps, right? I don't need to have a separate sensor for heart rate. I mean, many things are becoming more and more available in the smartphone. And at Healthify Me at least, so the third thing was, where is it in the future, right? So in my opinion, future is being able to look at data from the customers, taking that very seamlessly with the power of the smartphone, analyzing that and giving them really good contextual feedback and analysis remotely. So with our help, for example, today Apollo's customers and Medanta and Manipal's customers do not have to go physically to the site. They are connected 24/7 with their physicians, with a team of nutritionist trainers, and I think that is the way ahead. And from an operationally perspective, since we have raised 2 rounds of fundings and we have grown a team to about an 80-member team spread in 3 different cities today in India, I think I can talk about the pains, the struggles, and I can probably empathize more with the entrepreneurs that are going to be out there So excited to do that as well.
Sounds good. Thanks, Tushar. Mohan, if you can.
Just very sorry to set the context, guys. Before this thing, I was involved with Nandan Nilekani for 2 years, building the Aadhaar project for the country. And I'm an investment banker prior to that by profession in New York and San Francisco. Graduated from University of Pennsylvania. Yeah.
Thanks, Tushar. Mohan.
Okay, I'll briefly touch upon, we are an investor, Northwest Venture Partners. We have invested roughly about 80 million in healthcare in India. So we are a $1 billion fund. And we have two focus areas, technology and health. We do services also. We invested in, for example, in ThyroCare, which is a B2C diagnostic chain. We have about 6-7 investment in healthcare. Let me tell you what we look for, right? Because that's probably what is most interesting to all of you. It'll be surprising to you. The first thing we look for, it's not just in healthcare, across any space, is the passion of the entrepreneur, right? It's very difficult to judge, okay? That's where most people get it wrong. How passionate is the entrepreneur with respect to the idea, okay? Is he committed? Is he committed fully, knowledgeable about the space? What kind of energy level you have? That, like, we give more than 50%, okay? And we do in multiple settings. We meet the founders like 3-4 times, office, dinner, lunch. We even just casually ask them to go for a walk and talk, right? So that's an art. I don't think anybody has got it. If somebody can solve the problem scientifically, it'll be a great benefit to the venture world, okay? So 50% or more weightage goes to that, okay? And, by the way, that's where we get it wrong, okay? Everything else we get right, but that's where we go wrong most of the time, okay? The second thing you look for is, you look at the problem to be solved, right? So I'll be more specific here. In healthcare in India, we look for entrepreneurs who solve healthcare problems relative to India, people in India. So it has to be something affordable healthcare in medtech, or a new applying technology to solve the shortage of doctors. We believe, for example, doctors in India, you can't solve the problem of shortage, okay? Because it takes 7 to 10 years to get a good trained doctor. And no way you're going to solve the problem in the next 10, 15 years, even if you double or triple the medical college, right? So the only way to do that is enhance the productivity of doctor, whatever way it may be, okay? Using technology, telemedicine, give them more tools, make them available 24/7, reduce the number of time or automate the surgery. So that's of great importance to us, because we believe if we can solve the problem, you can build a great company, okay? So affordable healthcare, doctors' productivity, okay? And around that, there'll be multiple themes, okay? This is what excites us. We look for solving a large problem relevant to the market, okay? And finally, we don't go into the market side at early stage, okay? If you have a good idea, we'll work with you, we'll help you, okay? We spend at least 2-3 years out of our time, okay, working with you to refine the problem, okay? What you start with and what you end with may be completely different, okay? And we'll help you to solve a problem which is large, okay? Because once you take venture capital or private equity, right, you are actually tied up for next 10 years, okay? And if you want to get an exit, you have to solve a large enough problem, okay? And that's not, we don't expect that to answer that question when you come and present to us in the first year, but we will help you along the process to find a problem large enough to solve, okay? I would say there's 3 simple rules, okay? I don't think there's any magic there. And you know what, the track record of us, we get maybe 10 to 20% times right, okay? 80% we are wrong, okay? So whatever I say, it's 80% wrong, okay? 20% correct, okay?
Lisa, I'm assuming your presentation is ready, right?
Thank you. Thank you. First, I want to thank Ms. Reddy and the Apollo Group for inviting the Henry Ford Health System to attend this conference. It's truly a delight to be here. My name is Lisa Prasad, and I'm the Managing Director for Global Innovation for the Henry Ford Health System located in Detroit, Michigan. I'm really excited to be here today because India, as we've seen and we've heard, is such a hotbed of tech innovation, particularly in the healthcare field. And we as in the Henry Ford Health System, are very interested in identifying ways to co-develop some of these technologies and push them into the US market. Let me briefly tell you who we are and what we do. Henry Ford Health System was founded 100 years ago by Henry Ford as an integrated healthcare system. Innovation is in our DNA. When Henry Ford was first thinking about creating the health system, he actually brought in engineers and designers from the auto factories to create a very patient-centric experience, something that we've all been talking about, but in fact, some of this was done 100 years ago, and innovations that we take for granted today, such as the movable hospital bed and the movable bedside tray in hospitals, were actually developed by Henry Ford at the Henry Ford Hospital. Today, we are a 5-hospital, 100-clinic system, and some of these clinics are something like 100,000 square feet, so I think in the Indian context, they would be considered hospitals, but because they're not inpatient facilities per se, we refer to them as clinics. But we have 25,000 employees, we have 1,500 employed physicians, and we have over 3 million patient touches every year. We are a $5 billion corporation, and we have widespread scope and services and also scale. We also have a fully owned insurance company called the Health Alliance Plan. So essentially, if there's something happening in healthcare, particularly in the US, it's happening at the Henry Ford Health System, and it's happening under our P&L. Over the past decade, we've seen some major disruptive forces, and that's not unique to Henry Ford, and that's certainly not unique to the US. You've seen them as well. We have the Affordable Care Act, of course, which is unique to our environment, but we're also seeing lower reimbursements, higher cost, aging, chronically ill patients, and we realized about 4 or 5 years ago that we needed to start thinking about hospitals differently, and we created what is called the Henry Ford Innovations Program. And really this was to deal with our intellectual property, but also to teach our physicians and staff how to become more innovative in their day-to-day work. There are 3 pillars to our program, and I'm really going to go through this very quickly because it's the last one that the entrepreneurs in the room will be interested in. We have the Innovation Institute, we have the Global Innovation Program, and we have technology management and system partnering. The Innovation Institute is one where training and development occurs for not only our physicians and nurses, but also for our frontline staff, and this is where we hope we're teaching people to become more innovative and create new ideas. The Technology Management Program is a technology transfer program on steroids, as we like to call it. This is really where we take the intellectual property that comes out of the hospital and put it through the commercialization process, from inception to development to validation and then to commercialization, either through licensing or through spin-off companies. But really what's unique about Henry Ford is that we also seek solutions from external companies and mostly startups. We like to partner with them to co-develop products and push them into the marketplace. What the company brings is its technology, its talent, and its seed capital, things that all of you have been talking about. And what Henry Ford Health System brings is the wide array of clinical validation skills that we have internally. We do product testing, we have rich patient data, particularly real-time data and feedback, user impact, not just on patients, but also from nurses and doctors. We have the payment model because today, if there is no payment model that backs up the technology, chances are very slim that the technology will actually be implemented, no matter how good it is. And we bring the health system brand. So it's very interesting because earlier Dr. Ganapathy was saying that when you do your inventions, make sure you work arm in arm with the people on the front line, the doctors, and that's exactly what this model is intended to do. So there are lots of co-development benefits from getting involved with the Henry Ford Health System, particularly at the very early stage. And what I'd like to also say is that I think we get involved with innovation at a much earlier stage than the gentleman who you see on stage here with me. So as we go through and talk about the 14 great companies and the ideas that are going to be presented, hopefully you'll hear a variety of perspectives from all phases of the innovation process. Thank you very much. And I think hopefully that was only 5 minutes.
Thanks, Lisa. I think now we'll get to the next part. So if I can get that list, or thank you. Yeah. So I think if you can give me the list, probably we can just get started. Okay, so the first company is 360 Health Vector. Please come forward. Okay, so person is not there. Okay, so the next one, Diabeto Care. Is there? Okay, sorry, 360 Health Vector.
Good afternoon, everyone. We are Health Vectors. My name is Jagsir. Allow me to introduce ShopTech. A healthy, vibrant guy used to do health checkups on all of his birthdays. Very sadly, we lost him at 32 due to cardiovascular complications. Just gave his family and friends 10 minutes before he left us. He's not alone. If we look back, there are 38 million people who die due to non-communicable chronic diseases every year, among which 6 million are Indians. That's more than half of Bangalore's population. And economic loss is huge. Why is this happening? So there are 3 main reasons that we found. First of all, everyone, when they're healthy, they have lack of time and awareness that they can actually prevent something from happening to them. Second is, there's no holistic view on data while giving advice to the patient. And third is, again, errors and mistakes are no new news. All we know is ignorance is not bliss when it comes to personal health. And give you a fact, 1 in 3 babies born today will become diabetic, right? And why is this happening? We are still stuck in that detect and contain paradigm that when something happens to me, I'll take care of it. When actually you can predict and prevent it. So we are a personal health analytics company which helps you predict and prevent chronic diseases before they occur. So how do we do it? It's a simple process. You register and do a health checkup. And we collect your clinical health data and personal health data. What do we do with that data is run it through rigorous validation and get good data out of it. Pass it through our analytics engine, which benchmarks your present health, looks at your past health, and also projects your future health based on evidence-based science. And then collecting all 3 pieces of it, it prepares an automated solution for the doctors and nutritionists and physiotherapists, which then are validated by them and passed on to the subject or the patient in terms of a PDF report or a printed hard copy. We also have a web solution and a user app for the end user. We have apps for the doctors to validate the data. We also have apps for technicians to input correct data. Let me give you a success story. Meet Nikhilesh. He was able to reduce his risk just in 6 months by using the solution. We are helping companies bringing down their population health risk. We are working with some elite people, among which are corporates and hospitals, and trying to help the individuals at last. Team behind is extremely passionate. We have engineers and doctors behind this, guiding us all through the way. We have set a goal for ourselves. By 2018, we got to touch 10 million lives. And if you are a hospital or a corporate trying to help your employees, please go to myhealthvectors.com and schedule a demo today. Thank you.
Okay, so before someone asks anything, so what is the business model though? In the sense
So business model is two right now. One is we work with corporates, where we conduct a health checkup of their employees and help employees manage their personal health, and they also help employers bring down, manage the wellness of the company. Second model is where hospitals, the health checkups that they do already, we enrich the end delivery by providing more information to the end user.
And you provide the service via them to the end user. Via the hospital, you provide this service.
Via the hospital, we provide it. Actually, it's the hospital providing this. We work at the back end and support hospitals.
Got it. Okay. Any questions?
So I'm unclear. Who actually pays for your service? Who pays for this?
Corporates for the employee health check, and then hospitals for the. So they just add on top of it, and actually it's the user paying the hospital, and it's coming to us.
And at this stage, is there any metric that you can say in terms of success, not in terms of scale, but in terms of health index or anything, you know?
Yeah, so we have actually done this study on corporate for 2 years and found out there was significant change in the population that we were working with when it comes to the cholesterol levels and also sleep improve of that population. We actually had a case study in the presentation.
Again, bouncing off of what you just said, you know, one of the issues as an entrepreneur we face is the buyer versus the payer problem.
Yeah.
It impacts usage significantly. So we did experiments in corporates, like you did, but corporate space, and we saw very little offtake by the employees because then they weren't sort of as involved with the process because, you know, they weren't paying for it. So we just did a national launch with Cognizant actually just yesterday, day before yesterday in Chennai. But the model change here was that we got the employees to start paying, and then they start taking it more seriously. So, and we've seen a much greater impact already.
We are also seeing that.
Where are you sort of seeing the balance emerge on that? And linked to that is, how many total number of customers do you currently have in terms of end users?
End users, right now we have worked with 2,000 people, but we have a very strong pipeline which we are continuously converting. We are open to every model. If the employers say that they give us access to the employees, and employees make the decision to pay and go for it. So we work in all models. Our only goal is to provide it to the end user.
Okay, sounds good. Thank you.
Thank you.
The next one is Diabeto Care.
Diabetes means a lifetime.
There's just a 3-minute video, and after that I'll be able to speak.
Diabetes means a lifetime of daily and disciplined choices for health. The fact is, there can be no common treatment or prevention plan because every person's body and lifestyle is different. So how do you decide what is best for you? How do you get constant and comprehensive diabetes support? Discover Diabeto Care and experience the new era of personalized diabetes management. Our nationwide centers not only offer face-to-face consults with healthcare experts, but also help you stay connected to care through advanced technology tools. Let's explain how. When you walk into a Diabeto Care center, a diabetes specialist nurse compiles your medical history. The nurse also records your blood pressure, height, and weight, and performs specialist investigations related to diabetes. At Diabeto Care, your eyes are regularly checked for diabetes-related complications. And your feet are examined and investigated to assess changes due to diabetes. You then consult with a nutritionist for an in-depth diet and BMI assessment. And when you're ready for the doctor, your lab reports and related observations are ready on our DXNet software. Your diabetologist then prepares a personalized care plan best suited for your needs. Diabeto Care believes in putting control back in your hands and have an expert education program delivered by the UK-trained diabetes educators tailored to your specific needs. As we have revolutionized diabetes care with our unique remote monitoring service using technology innovations and trained practitioners, we ensure that there is a constant, customized connection between our patients and care teams. Transmitting the data to DXNet, a paper-free, hassle-free e-medical archive. DXNet allows you to access health information easily and efficiently 24/7 and allows our healthcare and support teams to monitor your health effectively 24/7. Any changes in the preset health levels trigger automatic alerts to you, your kin and your personal decarer. It's a way for you to live an active and independent life. With Diabetacare, you can control your diabetes, not the other way around. Diabetacare, your 24/7 diabetes manager. Diabetes means...
We know the impact of diabetes. Everyone have been talking about preventive health, the lifestyle conditions and other things. So what is required today is a behavioral modification. Monitoring, behavioral modification, motivation, and management is what is required for diabetes, and that's what Diabetacare is looking at. We are looking at monitoring the patients regularly. The glucometer, which is provided to our patients, has a SIM card which gets, where our call center of nurses and diabetes educators gets alerts every time the person tests, and then if there is a hypo or a hyper, the person gets a call. If it is a hypo, the kin gets an alert, and also the diabetes manager here gets an alert. And also there is other surrounding things, or where we motivate people, motivate them on actually changing their behaviors. There is a lot of programs for the patients who are enrolled into our program, which includes behavioral counseling, which includes a lot of fun games, teaching recipes, calling them the online recipe teaching. There are awards that we have planned for the people who have come up with the best recipe for diabetes, the peer education programs. So it's completely a comprehensive diabetes management, as we say, a 24/7 diabetes care program. So it's think diabetes, think Diabetacare is our slogan.
This, I'm guessing the actual care delivery is a brick and mortar model, right? So
yes, actual care delivery is a brick and mortar.
And then the supplements are there for the virtual monitoring and
yes,
all that pieces, right? Can you share something in terms of like where you guys are today, so that there is some context for questions?
We are at about 14 locations across India, majorly in the south. Bangalore has about 7 locations. Delhi has 2. We have in Cochin, we have in Hyderabad.
So are you seeing any of these behavior modifications actually happening?
Yes. So there has been a lot of traction in terms of when people even do not check for their diabetes. So we call them back and say that, why haven't you checked? It's been about 15 days you haven't checked. So what are you doing about it? Do you want to speak to your doctor here? So there is a lot of, there have been minuses also. People have blocked our numbers. So I'm not saying that everything is fine with us, but majority of them have been accepting, have been seeing that. See, one of the tracker is the HbA1c that we are looking at. And we have enough studies that we have been doing. We started off a recent study with type 1 diabetes also with kids, and we have seen a lot of clinical results that we could see. Commercially, it is yet to kind of look at how we can start making money, but clinically we are there.
Tushar, anything you want to add to that?
Just still not clear what's the scale and impact. So if you can talk to us about what's the percentages changes that an average patient goes through, whether it's HbA1c or whether it's blood glucose levels or whatever it is. And the second is just the scale, like how many people are you catering to, and what's your growth plans?
So right now, if you're looking at the people in the plans, we are at about 600 people who have taken our plan, like it's a 24/7 access to the diabetes educators, nurses and doctors for the whole year. And there are other plans, quarterly plans and day plan kind of a thing, where we do only the titration part of it for about 15 days if there is a if he's advised insulin newly. So that's for the connected care. In terms of the patient footfall itself across all the brick and mortar centers, we have crossed almost about 25,000.
I had one question, like what percentage of your patients follow through? Like what's the dropout rate or adherence rate so far?
We're at a renewal rates of about 70%. 30% is a dropout.
Seems very good. But then in terms of compliance, like there are two things, right? One is...
No, compliance is not, compliance I would say the reverse of it. Compliance is at 30% kind of a thing, but they're interested and they're paying up to, keep the plans on.
Okay, sounds good. Lisa?
No, yearly. Annual plans.
It's a great idea you guys have, and one that seems to me is very easy for others to adopt or modify. So how is it that you're ensuring that you'll stay ahead of the competition? What are you truly great at as your team?
Staying ahead is what, at this point of time, I agree, the entry barrier is pretty low. What we are looking at is the kind of services that is being provided. We are not looking at the technological advantage part of it, because a glucometer with a SIM card is a no-brainer. So we are looking at the kind of interventions that we are doing and the kind of clinical protocols in behavioral modifications that we are following, that which can wherein we can achieve the results actually.
Okay, sounds good. Thank you. Okay, the next one is Doctor Circle. Doctor Circle is anyone from there here? Skip it. Okay, so we'll go to the next one. Daily rounds.
Good afternoon. So this happened in last year, November 2014, in a small government hospital in the outskirts of Chennai. So there, Dr. Shruti, she diagnosed a patient, a child, 3-year-old girl child with swine flu. Everyone was kind of surprised, because not many cases of swine flu was actually diagnosed in that locality. So their question was that how could she diagnose? Even the senior doctor was kind of confused. Nevertheless, they went for blood investigations, and it turned out that the child indeed had swine flu. So she was properly treated and followed up. So what really happened was this. Dr. Shruti actually shared as a review in our app store. So she happened to go through our Daily Rounds app, a case of swine flu, which was actually shared by an Indonesian doctor. And she could immediately relate it to that patient. So have you ever thought about this, how doctors learn? I'm Dr. Deepu Sabin, I'm co-founder of Daily Rounds. I'm an internal medicine physician, or at least I used to be. So as doctors, we have 3 methods of learning, just to make it simple. So one is textbooks, obviously. We use our textbooks. And second is no-brainer, again, clinical practice. And there is a third method, which are called clinical cases. So these clinical cases are real-life patient stories we use to keep learning and stay updated. And this is very similar to the management case studies or marketing case studies you might be familiar with. But there is one problem here. 98% of these cases we create, they die as old PowerPoint files. They are never published or shared. So this is Team Daily Rounds. We are a team of doctors and developers. We decided to do something about it, and that is Daily Rounds. So Daily Rounds is a clinical case sharing app. You have a stream of cases. Physicians and surgeons, they can share cases. They can actually solve the cases in a gamified manner. You can challenge yourself, you can challenge your colleagues. You can get your own score, and you can keep track of your progress. And by this November, we are actually adding a curated list of 126 journal updates also. Now, as of today, every single day, 400 new doctors join our app platform. We have 160,000 doctors, making us the largest doctor network in India. We have more than 70,000 clinical cases and very solid social media presence. And most importantly, we are the most highly rated app in the App Store globally. In the mobile health apps, we are rated 4.6. Now it's 4.7 actually. The entire app is free for physicians. Our business model depends on access to doctors. So our knowledge solutions, what we call our knowledge solutions, one is the pharma analytic and market research solution. With that solution, industry can actually say how doctors in JP Nagar treat migraine and how does it actually compare with, say, neurologists in Delhi. Second is our e-detailing solution. With our powerful e-detailing and backup solution, backend solutions, a physician can actually request a antihypertensive combination directly via the app. So almost a year back, more than a year back, we just had 1,000 doctors. And in the October of 2014, we have the first publisher, which is actually Harvard School of Medicine. Now AIMS, CMC, Vellore, and almost many of the top institutions actually publish via our app. In Jan, we have more now number of downloads. We cross in more number of downloads than the market leader of, which is M3. In May, some of the A-list investors in India actually invested in us. And for the next 1 year, we have very ambitious plans. We are actually launching 12 new specialties. We are growing globally, specifically in Malaysia, US, and Indian subcontinent. And we are actually working with more than 5 industry-leading partners. And obviously, keep doing what we do best, which is actually helping doctors become better doctors. And we have just recently opened up our publishing platform, so I welcome all the institutions and the partners here to publish through our platform. Thank you.
Okay, can you just explain, like, what do you mean by helping doctors become better doctors? Actually, give us just an example so that I just understand.
Sure, definitely. Let's take the dengue outbreak WHO guideline, right? So IMA recently released an update, and there was this 2012 update. Now, if you are a physician, the typical case scenario is that you either go to a library, or you should be having a $200 subscription to a journal to get access to this content, right? So versus, in our scenario, at that time we had around 1 lakh doctors. These 1 lakh doctors got this update as a notification in their mobile phone. So it is actually 2 tabs, and you have the latest dengue notification, and it's very relevant because, an epidemic is happening. So that is why I think it's actually helping a doctor become better doctors. And you can expect all the doctors to go to a library.
And what is your source of information? Like, what is the thing that you're...
So our source has three sources mainly. Most important source is actually the peer user-submitted content. A lot of doctors, you can actually check the app. So we made it, if you sign up as a medical student, it's open on an open app. So a lot of doctors actually share their own cases. Second thing, we have industry partners like, as I said, AIMS, Department of Endocrinology is actually doing their case on the app. And third, obviously, we do create some amount of content. So these are the three sources.
Mohan, what do you think of the monetizability of these kind of models, actually?
You know what, I think you're trying to monetize using the pharma companies.
We are monetizing to an extent now. We started monetizing, actually.
But as you know, like Indian pharma or global pharma you're talking about. Okay.
So we started with the medical devices industry, actually. Two of the India's largest device industry we are partnered with for radiologists, actually.
What would they want? Like,
So they want to know what kind of MRIs doctors use, in which locality, what protocols they use, and they would like to get leads. It's simple.
Got it. So you take their info when the doctors sign up with you.
Yeah, we have the network, so they get the access.
No, I had a question here, right? Is this being peer review done by other people before it goes out?
So the peer review is actually done by an in-house editorial team at this time, but for the specialties, right? When you are opening up radiology, we are not doing a peer review, so it becomes a in-app peer review. So you can actually upvote and kind of share it.
How many cases do you have? You said
we have 75,000. 75,000.
75,000 cases.
Yeah.
And what does a case mean? Like,
all right. So case can be. It is very simple. Maybe cases have bigger. It could be a patient's story, like fever, chest pain, and X-ray. What is the diagnosis? How do you treat? How do you follow?
Sounds good. Anything else? Thank you.
Thank you.
Okay. The next one is MedPack Systems.
Hi, good afternoon. Sorry, I have to raise the mic. I'm Shastradhar from MedPack Systems. We are a PACS and teleradiology and telemedicine company. So PACS is where actually once the images are received on the server, they can be viewed on using a local, on the browser. In the hospital, you can use it. You can use a browser and you can view the images. You can view even an iPad. You don't need to install any software. We have the same PAC software, we have taken it onto the cloud, and around 120 centers are uploading from India, Australia, UK, and Africa. We also have a telemedicine. We are trying to do a remote ultrasound, integrated with our PACs. So basically, without the radiologist being present at the remote location, we are trying to get the ultrasound also into our PACs. So what is the sweet point? We actually have our own 3D radiology workstation using the cloud. We are able to do it for the teleradiology using the cloud. So we have developed our own 3D teleradiology client, and we also, for the Indian bandwidth conditions, we have a flash-based JPEG 2000 compression, because these images are pretty bulky. So you can just stream it on our bandwidth, and even with the low bandwidth, centers are able to upload to our cloud from remote locations. And we also have a HTML DICOM viewer, which for the iPads and Android, because Flash is not supported on the iPad. The packs which we sell to the hospitals, we are also, it's integrated to our software in the hard disk monitoring also we do. Because in the packs, if you lose data, right, you're killed dead. Because the whole reason for packs is to make sure your data is not lost. We around have, also told, we already have 120 clients. We are working with some large, we have 4 enterprise installations, including one in Australia and other in India. Most of our other 120 clients are from rural areas in India and Africa, and diagnostic chains. So this is just our management team. Looking forward, we are looking at our first telemedicine customer also. So we have just started the telemedicine and we are on the trials. And we are seriously looking at the remote ultrasound, because as of now, we have, in the remote areas, without the radiologist, they are able to get things done. Only for ultrasound, they need a radiologist, and we are just trying to solve that problem. It's a little bit painful, but what we do is we plan to get a very low resolution video, and at the remote end, the doctor is going to click, and then we stream the high resolution images onto our packs. And because packs, he can actually check like a store and we are trying to get into Africa and Southeast Asia. So these are our screenshots. Quickly, so this is the web-based one. This is a flash-based. So you just open Google Chrome and you can just start using it. You don't need to install anything. It's a full-fledged DICOM viewer with scout lines, everything. This is the wall 3D rendering, but for this you need to install our application. So this is just the protocols you can do. This is the reconstruction. This is the telemedicine we're talking about, and this is the ultrasound we're talking about. That's about it.
Okay, so when you actually go to a hospital, right, what is the thing that you think, whether in terms of model or a product, differentiates yourself from?
So basically, we have 2 products. One is enterprise, where we actually push in the whole, we just go and install a server with our software, and from all the radiology, they just push it in.
No, but what how do you differentiate yourself from, as you know, there are, at the cursory level, of course, there are a lot of PACS players, but you should be having something that differentiates yourself from them.
Let me put it this way. The Benz also does the same thing, and even Maruti 800 does the same, right? So we are mostly like the Indian guys, right?
So what are you, the Maruti 800 or the Mercedes?
So we do the same thing. But we don't, we are a startup. So we know our weaknesses and we know our strengths. We are technologically strong. So what we do is, the biggest challenge IT has is installation of software. Let's assume the EMRs or the teleradiology, right? Let's say I have a hospital where there are 100 computers. Imagine installing a PAC software in 100 of the PCs. Yeah. It's a nightmare. Convince, or just imagine a doctor, right? He goes home and he just switches on his Mac. Ours works on Macs, Linux, everything. So it doesn't matter. It just needs to be some browser in it. So he just goes in, he just logs in, or he just goes to net cafe. We don't know, right? So he just goes there and he just pops in. So our biggest advantage, what we differentiate is no installation required for packs. So with full-fledged
client side, that's
yeah,
for the
client
doctor.
side, yeah. There's no, you can just like plug in and go. For the 3D it's required because I need access to the GPU. Okay. So a graphic card.
Okay. Mohan, like for the enterprise software companies, right? What do you see as like, is there a market that's evolving in India, or it's still like fragmented and small like before?
What we see in India is quite fragmented. There are a lot of small companies trying to sell enterprise. Only last 2 years I'm seeing companies which are developing solutions based on cloud, which can, basically what it enables is the doctor and the patient and the second opinion, etc. need not be in the same place, right? So I think it's still, I would say early stages. It's very early, not even 2%. So I think the growth is still to come. A lot of projections I see India like $1 billion to $1.5 billion healthcare technology, which is HIS, EMR, cloud packs, remote monitoring. I would say today is less than 100 million. Yeah. Big hospitals like Apollo, they adopted, but it's not the other ones. Still billing system, HI is a billing system. So that's a challenge you'll face is while we go ahead and try to sell, the selling cycle will be longer, okay?
Yeah, actually most of our teleradiology clients, they're slowly converting themselves into PLACS clients. They just start the cloud. Once they get used to it, right? Many of them have become like the enterprise system.
Yeah, one thing I'm seeing is the rental model is being adopted, so bring the price down very low, right?
Yes.
Start 5,000 rupees a month, work with a broadband provider, bundle it, okay? Provide the basic feature, and as adoption happens, you add more and more modules. So I think you have to start low and then build your way up. That may work better.
Okay, thank you.
Thank you.
Okay, the next one is Augmenta Health.
Thank you for this opportunity. In the next 5 minutes, I'm a pure clinician. I love to deal with my patients. I'm a psychiatrist by profession. I now call myself as a medical health entrepreneur because I've learned some hard ways and tough ways, and this is a journey which I would like to put across. Startup and innovation, and I think I would like to first of all make a point here. Is healthcare business very different from the other businesses? Think over. My answer is, it depends how we see. Because if a healthcare company makes a lot of profits, how do we assume the profit to be? Is it because they make more money? Is it because they're giving good efficiency? It's very difficult to tell. We know healthcare is evaluated not just by about bottom lines and top lines and those. There are a lot of proxies. Is the toilet clean? Is the nursing staff taking care? Is the the lift operator doing good job? Are they courteous enough? Is the wheelchair available next? So there are a lot of proxies which decides how healthcare is delivered. I'm talking about delivery of healthcare. At the end of the day, anything is at a delivery level. So positioning, how do we position as healthcare? With a brand or with trust? I think it has to be together. There is some kind of a balance we need to bring in. As I already mentioned to you, I'm one of the founders, and the other one is Dr. Shamita, who's sitting there, who's also a healthcare professional. So I'm a psychiatrist and she is a public health professional. What made us start up something in the mental health sphere? The answer is very simple. We used to give simple solutions, like have a common ID, let's use Excel sheet, some simple things people used to reject. We used to find it difficult. The next thing was, we thought it's high time that we face the challenges by ourselves, take the lead. And one of the thoughts is to leave behind a trail. When we are no more there and we are only in the photos, could we leave behind a trail is a simple question. And I think we really want to do that. And I think I'm proud of what we are going about now and the way we look forward. Healthcare is definitely going to move around in some direction. We know which direction, nobody knows, but we hope it's going up. What is Augmenta Health going to do? The budding Augmenta Health is going to take care. Even though we started in 2011, maybe we were sleeping or maybe we are thinking too much. We didn't do anything for about 2 years. We just started and kept it. With all hard-earned money of our family members, we could pull in about 42 lakhs, which is about a 2 BHK house, which everybody would buy. We thought, okay, let's invest, as if we are very rich. We still rent a rented house, but we thought it's high time that we put in. The reason was very simple. I'll let you know. The vision we have is very simple: creating healthy communities by designing healthier minds and enhancing well-being. Because I was astonished to see, I was there for last 2 days, hardly mental health was hardly even mentioned. But we all know mental health is sheer important. So what are we wanting to do as a mission? We want to promote mental health and well-being, both. The treatment, illness, well-being, everything, and give very good quality care at affordable costs. More importantly, we are wanting to create a safety net. Create a net where people can go back. In India, we know we don't go to psychiatrists. We go to aunts, uncles, relatives, and friends. But we are losing the culture today because of various reasons. Can we create more sensible safety nets? And why did we focus mental health? The answer is very simple. 1 in 4 adults have some psychological issue which needs help to be addressed. 10% of the disease burden is because of mental health. $16 trillion is the amount of money which is going to be lost because of mental health issues in the next 20 years. Don't even ask me how many zeros come there. I don't even know that. The real reason is very simple. We thought it is our expertise. Let's focus on our expertise. Let's not try to jump into too many things. That's the simple reason. We created 3 divisions, 3 steps, and 3 successes I would like to share in the next 30 seconds. We have a clinical division called Couch, which takes care of outpatient facilities. Only 1 center is there in Bangalore. One Day Guru is the teaching and training, which takes care of professional help. We empower other medical professionals learning more about mental health. PH is the public health initiative. We ensure that money which is spent is calculated. The reason is very simple. We have limited money. And out of the 42 lakhs, the best part of it is we have stored it into a land which is about taken out 2/3 of it. The rest of the money is what we are juggling around and try to create innovation. But we don't go behind. All of it we use is into online, taking care, database, save everything and all the stuff. And we want to create a culture of helping people dealing with these things. The 3 simple successes are very easy. We have just recently filed our income tax filing and those things. We have already touched the positives. Before tax, we have already been able to reach profits. We hope it will scale up even more further because without any marketing, we are able to do it. If we start doing rest of the stuff, I'm sure we are going to go. A lot of people in the industry and outside start looking and ask, how come you are able to run the show? I think we are able to raise eyebrows, which means probably we are doing really wrong things or really good things. We assume we are doing the good things. We are very, very proud to be one of the finalists in one of the awards which they had taken over. We are in the final 3 of the outreach program. We are India's first online suicide gatekeeper training program. And it's a suicide prevention program which was developed by us. No IT software engineers, Sharmita and me, midnight, sitting down, coding WordPress codes and those things. We did it with a cost of about iPhone 6 Plus. If you had missed the Flipkart, you will pay costly, but otherwise, that's the cost we spent. About 65,000. It's on and running. It will run forever with the same cost. You don't need to pay anything. It can be highly customized and scalable to the next level. That's where we are. And well begin is half done. I think that's not enough for us. One thing I would make a point clear here is we are very sure that someone is paying. Every action someone is paying. It's a patient, it's the doctor, it's the funders, it's the investors, somebody. So I think we need to be really accountable for the money which is transacted in healthcare. That's something which we are always looking at very seriously. And we only want to focus on mental health. We really do not want to go into anything else because we have enough jobs to be done there. So we have expansion models in terms of mental health literacy, clubbing, hub spike model of consulting we want to develop. But we definitely want to focus on complete healthcare in mental health. Promotion, prevention, treatment and rehabilitation, drug de-addiction. These are things which we are definitely looking at. Intention, connection And execution and adaptation always requires teams and funds. I, as an individual, cannot do anything. I'm always looking forward for good liaising with working with people. Instead of pitching this, when people told you should pitch, I say I don't pitch. Let's talk. Let's join together and have a great journey. Welcome aboard. If anybody thinks you have an idea in similar areas, let's work together. Let's leave behind world a great place. Thank you very much.
Yeah. Yes, sir. This one, what's the business model right now? Like,
we have 3 ways of revenue generation. One of the revenue generation is by running the outpatient service, which is only one currently. It's a full-fledged outpatient service, which takes care of the psychiatry, counseling, therapies, and other things. The second way of generating money is by delivering a lot of training programs, specifically targeting a lot of other colleagues and doctors. We run, as the HELPy, which we spoke about, suicide care, we run a free program for the doctors who can register and learn about mental health. It's called as I Love Brains, where we share about passionate cases, videos and those things which talks about it. And we also generate revenue through it, significant amount of this thing, because we are liaising with a lot of training institutes and those. That's the third. The third thing is the public health initiative which we have done, which is free for the end user. They don't need to pay. Anybody can access through it online and go to the website and register and become a suicide gatekeeper. You can prevent suicides. What we are looking at is when we customize, we look to tie up strategically with NGOs and other people who like to work on, we might see at delivering them the baseline material, infrastructure which is required and training, which is very difficult to get. That's what we are looking at, sir.
Lisa, one question, like in the US or anywhere else in the world, do these kind of mental health solutions, do they kind of work outside of traditional hospitals and care providers and so on and so forth?
Yeah. So let me just say that there is a tremendous amount of economic loss related to mental health every year, and nobody knows how much. And the problem is that if you can't measure it, then nobody really sees it as a loss, but there's a real cost involved in implementing a program, so people focus on the cost of the program instead. In the US in particular, there is a much more increased focus on wellness, and mental health is certainly a part of that. And outside of the, I think that there is an opportunity for programs like this to be marketed to hospitals themselves. And I think that they could be very much seen in conjunction with diabetes treatment, because we, in particular at Henry Ford, see a lot of depression and a lot of, again, lost productivity associated with chronically ill people. So there is an opportunity, I think, but again, you have to kind of figure out the cost model, who will pay, how will the payer be identified, whether insurance will cover it or not, all of those things.
Okay, thank you.
Thank you very much.
Okay, the next one is Cardiac Design Labs.
Good afternoon. Okay. So I'll just set a quick context here, and then we'll explain the product we're developing. Okay. So this is a slide on the data on India. So very specifically, this would also map to the growing economies. We have about 64 million cardiac patients in this country. 90% of these actually are going to small hospitals. There's a small number which actually goes to the regular big hospitals which provide the diagnosis and the treatment. And this is primarily because of the landscape and where these hospitals are recorded. So India today actually only treats acute. This is because the resting ECG machines, which are predominantly used in most of these hospitals, actually only look at data for about 10 seconds. And if the condition is acute, it's going to pick up and you do the next level of treatment. So you're actually waiting for most of these patients to actually come to that stage of acute, and then treatment is provided. So when in a city hospital, when an affordable patient walks in, he has access to doctors, cardiologists, and they have access to devices which can actually diagnose the patient a little early. They have these holders, event monitors, and then you have the treadmill test, which is used to treat, analyze ischemic patients, which is the coronary artery disease. So what are we talking about is in cardiac design labs, try to create a scenario where these small hospitals are able to diagnose these patients frontline, be able to filter these patients more effectively. Very simply because we have about 4,000 cardiologists in this country to 64 million cardiac patients. Anybody's guess as to how many patients actually reach to a cardiologist. You need to get the right patients to these cardiologists so that their time is used effectively. And the next level doctors, which are there across, are able to actually do the first level filtering. So this makes an effective system for actually management of early detection and disease treatment. So how did we go about this? So when we actually looked at the large hospitals here, these Holters and treadmill tests and event monitors, these are all fairly expensive equipment, apart from the resting ECG. And there was a protocol in which they were used, and they were developed at a different point in time. We said if you have to bring that kind of diagnosis down to a smaller level, we will need slightly different kind of devices. First, you don't have technical know-how in these small hospitals. You do not have trained technicians who are sitting there. Second, the cardiologists are not there. Third, very importantly, they cannot pay the big money. So you will have to do it in a much more affordable cost. So what we ended up doing, we developed a comprehensive ECG analysis system. How did this happen? We actually looked at, so we worked with doctors along the way, cardiologists. We developed these algorithms in such a way that these rings run real time on small mobile devices. It can be a phone or a tablet and a certain hardware that is worn by the patient, which is actually fundamentally the ECG pickup. So why is these things complicated? Very simple. The resting ECG is called resting because you have to be absolutely at rest. Taking an ECG from a resting patient is fairly simple. You have good, clean data from the heart, good for analysis. Once the patient moves, it gets complicated, which is called the ambulatory ECG. You have noise, you have other kind of problems that come into the ECG. All these require correction. These corrections are done at software, involve complicated signal processing. Then the next level. Even if you have got a certain segment of ECG, now, how do you present this to the cardiologist? You cannot take all of this ECG to him. He does not have that kind of time. So you need to do some kind of filtering that happens and says, get to the conditions and say, these are the ECGs you should look at. So we built a full clinical engine into the software, which can actually do the analysis and tell you where to look at. So we were able to do resting ECG, we were able to do full ambulatory ECG analysis and the stress test analysis, which is the ST segment, particularly to the ECG, which helps you analyze the coronary artery disease. We were able to do all of this real time, and now the cardiologist is not there. Even if a patient is monitored in a small hospital because he or she walked in with some symptoms, you need the final review to happen through a cardiologist and reporting being done. So we added effective telemetry into this. Very simple. We were able to bring it through to simple apps that the cardiologist will use. So at the end of the day, when they're actually going home, they can actually look through maybe 10 or 15 patients that have been monitored at different small hospitals in peripheries, and they're able to identify an active patient. So there's two-level filterings have happened before he actually finally took it. So this is the system. It has a body-worn device and a tablet or a mobile that goes with it. Both those are at patient side. Then we have the cloud server and some remote apps which complete the workflow. So right now, I'll just show you how simple the system is because I'm actually wearing it. So this is the device. And my monitoring is happening on this simple mobile phone. I am doing Holter on the go real time. I'm able to give all the features that a complicated GE or a Philips Holter is able to give you on this simple device. And it has a full workflow with the remote apps that can actually complete a complete diagnosis remotely. We are the first company across the globe to actually give you this comprehensive diagnosis. This is 12-lead diagnosis. I'm just wearing the full, all the 10 electrodes that form the 12 leads to give you this diagnosis. So what is happening? What are the key propositions that are coming? We're moving this primary cardiac advanced diagnosis from large hospitals into smaller hospitals. There's a pretty large number. It'll have a big impact where it goes. We are doing this, we have actually test bedded this with doctors, they're able to use it. We are doing this without call centers, full-blown call centers, because the traditional event monitors in the market actually generate a lot of ECGs that go online. Somebody has to filter them before a cardiologist looks at it. We're doing all this on software. So primarily, this will be a very good scalable model, if at all the minimal level of call centers that can be built in. So we'll be able to take on much larger client base with reach to diagnostic centers or small and medium hospitals.
Since we are running short of time, can you get to the summary part of it?
So that's about it. So that's a comparative chart that tells you on the right is the large hospital, on the left is the small hospitals, the three large diseases that we have mapped. You see the kind of names that I've shown there. They are the different manufacturers of Holters, event monitors, and resting ECGs. You see on the left column on top, small and medium hospitals have nothing today. They just have the resting ECG machines for acute CAD. They don't do any of this. With our system, you will be able to start looking at that as a market.
Mohan, just one question. Do you, from what you see, do you envision a scenario where there could be a big medtech company that can be built from India? Like, because the big guys are coming down, the small guys are going up, all those is happening right now.
I don't know with kind of mission. What I can say is medtech combined with services, okay, probably will be a
so actually,
larger market
that's the
than a
other
purely
part which I
medtech.
didn't come to. We are doing a pay-per-use model. We would actually deploy the device, we'll load a virtual wallet with prepaid model, and deduct per diagnosis that's happening.
Now, what he meant is also the clinical service also, right?
Yeah, the actual, because somebody needs to guarantee, yes, if I'm a patient,
yeah,
I am critical care, I need to make sure that it's available, right?
Yeah.
Okay, so some doctor services can guarantee me, if and when there is a problem, I am guaranteed within the first golden period somebody comes and helps me out. Tying it up emergency services, maybe a larger revenue model. You know,
Yeah,
look, it's,
so
I think it's
now
the
we are
right direction, unless we go down deeper into the problem and say, how you tie the medical devices with the services, with the doctors, patients, how does the money flow, right? And that's when you get a large business.
So right now what we're doing is trying to talk to some of the larger hospitals before going down, or we try to plug into the existing ecosystem of the referrals that they already have, and we connect those doctors in. So the system actually fits into the existing manual system that they have today.
Sure. Okay. Thank you.
Thank you.
Okay. The next one is Acaster Technologies. And since we are really running short of time, it would really help if we can wrap it up in 3 minutes.
Sure. Can I have...
Good afternoon to everyone. I am Mrs. Deepthi Verma, the Marketing Director of this organization, Acaster Technologies Private Limited. So it's a social enterprise, and our vision is very social. Our vision is to solve the basic problems of the society all across the world in the healthcare by doing the groundwork in the technological innovations. So our journey has started with the burning problem of which is the need of the society, that is 78% of the population in India are not getting quality diagnostic services. And the reasons are very simple. We didn't have a proper technology which can sustain Indian environment, Indian conditions. What are the Indian conditions? There is a power problem, there is a transportation problem, electricity issue, and above all the affordability. Accessibility and awareness is the one major factor, but more than this, affordability is the major factor. So we know from the beginning that the solution is very clear, that we need a technology which is made for India, which is as per the Indian conditions only, which can sustain the remotest locations, rural locations, different climates of our Indian geography. So it is Mr. Amit Bhatnagar, who is an IIT engineer. He has taken this initiative and has revolutionized the novel technology for the diagnostic services. So he has brought a very beautiful solution for our country that is called mobile lab. So it's an entire laboratory in a suitcase, it's a lab in a box with the power backup. What we have done, we have miniaturized the whole laboratory into a suitcase. We have a semi-auto analyzer into this, the centrifuge, incubator, micropipettes, all the components which are required to run a laboratory. And on the top of it, it has a backup because of the battery and solar panel. So with the solar panel, it can run continuously for 24 hours. So it is a we have all the things in one suitcase. The technician, lab technician can take these machines anywhere and can go anywhere in the field and can do the testing right over there and give the reports on the spot. So what we have done, we have also added a software solution to it. So you can see the laptop is connected to it. So we have a Bluetooth connectivity as well as the USB software, USB port. So all the information from the analyzer goes to the laptop and the patient information is available on the cloud. So even patient can access his report, and the organizations who are using this technology in the field, who have deployed these machines all across the rural areas, they can see the real-time data from their head offices. So this is the list of tests. These are around 36 blood tests, which involves glucose, hemoglobin, lipid profile, liver function test, kidney function test, and hematology. So this is the kind of report format which comes. It gets auto-generated in the software. You will have your logo and the list of the patient with the data, with his reports. So these are the features which we have just mentioned. It's very rugged, portable, and it can sustain all the rugged temperature. It can work from 0 degree to 50 degrees centigrade, which means it can work in Leh Ladakh region as well as in Jaisalmer, Rajasthan region without any stringent working condition. It doesn't require any air conditioning. It doesn't require warm-up time, cooling time. Nothing is required. So technician can do the testing anywhere. So this is the satellite control. So now when we are working in the field, so the quality becomes very important parameter because the technicians are working in the field and there is nobody on the top of him to supervise him. So what we have done, we have added a mechanism called satellite control. Through satellite control, we can assure quality, we can assure financial control, we can assure real-time data transfer. Even without internet connection, we can have a minimum basic information that has he done the quality control today or not. The basic quality control is the protocol which any laboratory has to follow every day. So we can have that data every day without even internet connection through on our phone systems or on our internet system, even on our mobile phones.
Can you go to your last summary, please?
Sure. So we have a patent for this technology. We are funded by Technical Development Board. This technology has been also recommended by Ministry of Science and Technology. Even the Ministry of Health and Family Welfare has approved this under the guidelines of free diagnostic schemes. And it has been awarded as one of the best innovation by President of India, Shri Pranab Mukherjee. These are the certifications, USFDA, ISO, CE, you can see. So at the acoustic technology, we believe in the holistic approach. One is the disruptive technology which we have already built. Now we believe in skilled manpower because wherever we send this machine, we need a manpower. So we are coming up with training centers. We are trying up into skill development ministry and we are bringing the unemployed youth. So what we will do, we'll make the unemployed youth into a empowerment. We'll empower them with this machine and then the banks can finance them and they can use it, they can start their own labs. And then here on this platform, we need a strong network because we cannot reach each and every place. So we need a strong network in terms of we want to tie up with the corporate CSR, under the CSR activities, the governments, NGOs, foundations, telemedicine services. We can reach all remote locations. Sure, sir. Okay. So this is our objective which we have already shared. So this is the running cost is very low. This is one of the beauty of our machine because we are doing it at the doorstep. The running cost is very low. The glucose you can see 90 paisa and hemoglobin 18 paisa like this. And then this mobile app can be utilized at all these places which are written here under telemedicine, at the remote health centers, the mobile clinics like this. So this is our latest innovation. On the mobile app, we can do only 36 tests and at the same time, we need a vehicle to carry it to the remote area. So we have come up with the bike innovation. So it is a complete laboratory. On the bike, the technician go itself at the doorstep and can do the testing right over there. And it has a portable, foldable tent, table, chairs, all the facilities is there. Now it is also come with ECG, microscope, and the blood pressure, temperature, all these tests are included in this, other than 36 blood tests.
Okay, I think, we're running short of time, so I think that should cover it, right?
So these are key clients?
Yeah.
That is all. Thank you.
Okay, thanks. Okay, that's okay. Thank you. I think since we are up to another 4 more to go, we'll call the next one. Yeah. Kid nurture. Really, 3 minutes, please.
Hi, I'm Anurag. I'm the founder of Kid Nurture. Kid Nurture is a software platform for pediatric caregivers such as parents, pediatricians, and developmental pediatricians. The most important keys in child growth and development assessment is timely detection and early intervention. And somehow those areas are which are suffering a lot because there are some obvious problems like parents don't know exactly what are red signals they need to observe and raise during their well child or vaccination visits. Normal pediatricians are supposed to do some level of monitoring during well child visits, but somehow they are not able to do due to lack of helping tools in time. And at the same time, developmental pediatricians use very complex tools to assess, which already consume a lot of time. And due to that, most of the pediatricians rely on clinical judgment, and that's what a study says in United States, that around 70% children who had some kind of behavioral disturbances or developmental delays, they went under the radar. They were not identified by normal clinical judgment. So Kid Nurture is a one-stop solution to address this problem. It provides automated pediatric tools to all caregivers across different nurture segments. So once you create a child profile here, you get a complete nurture profile across different nurture segments from growth, development, immunization, nutrition, or physical examination point of view. Each caregiver gets a different set of tools as per his or her role in child care. If it's a parent, they can record normal milestone, growth-related data, and system will show them any red flag so that they can raise that problem during next visit to pediatrician right in time, and based on that, any early intervention can be introduced. This is how parental login looks like. As you can see, different areas with the collection of tools applicable to parent as well as certain tips and related information is provided to them. A normal pediatrician get tools appropriate to his or her practice. That is normal developmental assessment or normal growth charts for WHO or Indian Academy of Pediatrics, those kind of charts, and other physical examination. This is a normal pediatrician kind of login I can show you. And similarly for developmental pediatrician, we have automated many copyrighted complex tools which require a lot of time for generation of reports, like a checklist for autism or ADHD and other developmental assessment things. So as you can see, these are India-specific tools like Trivandrum screening scales as well as developmental assessment scale for Indian infants. So these are, So these are like certain complex reports which require mental age or developmental quotient calculation, etc., which is being done by the software automatically. So from market perspective, there are around 300 million children in India, 30 million added every year. So there's a huge market opportunity, 70,000 pediatricians and other therapists which make our other market segment. Revenue, we are charging medical professionals for annual subscription, and we plan to add this module to other HIMS-based solutions because that is the module which is missing from any EMR solution right now. From parents, we want to monetize that community when it grows big. Right now, it's free sign-up for parents to record the data, to book appointments, to share their information online with doctors, and at the same time, doctors can share the information online as well. In terms of achievement, we developed this product with detailed research and feedback from from taking that feedback from the experts worldwide, from leading Indian institutes also. So they have given the permission to use their copyrighted tools, etc., in our system. Some paying users are not on board now because we made it live just last month for the pediatricians, and we are now also building the API-based module to integrate it with the other HIMS solutions. Currently, the product is as per...
Yeah, if you can just wrap it up though.
Yeah, sure. So right now we are seeking help from funding perspective as well as mentorship and network. So our goal and mission is to make Kid Nurture the platform of choice for pediatric caregiving in the future. Thanks a lot.
Thank you. Just one very quick question. So the model is really reaching out to pediatricians to use this stuff, right?
Yes, parents and pediatricians both.
Both, okay.
So pediatricians are going to pay for annual subscription, and parents would be monitored later.
Okay. Sounds good. Okay,
Yeah,
since we're running short of time.
I had one question. Do you reach out to the parents through an app directly to the children, or you go through the hospitals, or?
No, we are reaching to parents directly from different marketing aspects, like from digital marketing as well as.
Okay, so you put it on your app store to download.
Yeah,
okay.
it can be both ways also, from hospital side also.
Okay, thank you. The next one is Smart RX. Really, 3 minutes, please.
Yeah, good evening, all of you. We are SmartRx. I am Madhivanan here. We are a mobile health platform delivering care management and telehealth. We started off as a patient engagement tool, and now we are well entrenched in care management and trending towards telehealth and remote health. So what we do is simple. We try and solve these three problems. Patients and users who have issues in terms of accessing healthcare or consultation, or it could be simple home-based medical needs, right? We try and solve their problem, thereby saving time and also making it cost-effective for them. Number two, we try and improve care delivery. How do we do it? We play the role of a care manager for them, which is probably not existent in the present healthcare model as we see. Because the doctor, of course, prescribes and gives the instructions in terms of what the patient needs to do, but whether these are followed by the patient is something which is not known until the patient comes back to the doctor and tells what he has been doing and what has been the progress. The third one would be better engagement and outcomes, right? So this is something which is not necessarily as a patient that one needs to be doing. Even when a patient is fit and he is wanting to improve his health parameters and outcomes, he can adopt the platform and the tool, and thereby making himself a more healthy person and being more productive to the society and to the family. How do we go about delivering these three values, right, that we touched upon? So improved access. So we have a set of features and tools by way of which we enable and facilitate access for healthcare consultation, and it could also be through way of e-consults. And e-consult is something completely a mobile-based solution. The user or the patient can get a preliminary opinion and or a second opinion kind of a thing through the mobile itself, and the doctor on the other hand also is going to be available on the mobile app. And once the appointment is fixed, the payment, everything happens on the mobile itself. There is no need for a web version or a web solution on this, right? And you can also order tests, diagnostic sets, and home care medical needs can be ordered online. Personalized care plan. So we talked about care management. So what happens in the post-discharge or in the chronic care situation is that the doctor would probably write out a discharge summary and tell these are the things that he needs to be doing in the rehab and in the post-operative situation until he comes up for the next follow-up visit, right? And then it is up to the patient to follow it, and how much of it is following it is left to the patient itself. But in our case, what we do is, by a mobile interface, we make the content available for his disease-specific condition, right? It could be a total knee replacement, or it could be convulsions for the child, or it could be gestational diabetes, right? So all this information specific to that condition is made available to the patient or to the parent or to the attendee of the patient, and it is available at their fingertips, and it is always there on the mobile. Besides this, what this does also, it can also be highly useful for non-smartphone users, because these care plans by itself will prompt and trigger push notifications. On day 3 of discharge, what the patient is supposed to be doing. If he is supposed to be measuring the blood sugar levels, that will be sent out as a push notification, and he will do that, and he will be able to record that on his mobile as well and bring it to the doctor for the follow-up consultation.
You can summarize.
Yeah, okay. So the third aspect is better monitoring. So you have all your third-party reports as well as your healthcare provider reports can be collated in one place against your name, and it's available right on your mobile, and you can carry it wherever you go, and you get consulted in wherever city you are. So just a bit of information about our company. We are a startup incorporated 3 years back, based in Bangalore, and we are innovator in the mobile technology platform. And we have 1 million users, and out of which 20,000 patients are paying for our care management service, and we are growing at a rate of around 20 to 30% every month. We have a product which is built for the US market, which is called the Care Bridge, which acts as a care manager. This is how the mobile framework of ours looks. The first one is the home screen, the second one is the e-consult, the third one is the care plan templates, the fourth one is the personalized health records. So the current model is we partner with hospitals to roll out this service under their banner. So it's for the patients, it's typically seen as being run by the hospital itself. Going forward, we would be partnering with other channels and also going direct. So the typical monetization is upwards of 200 plus if it is just care plans, and if it is going to be packaged with other features like e-consults, lab reports and all that, it could go up to as high as around 800 rupees.
Yeah, if you can just finish.
So this is the last one, and I think we have a team of core team of 5 people. Anil is the founder CEO. I am the COO, and we have the engineering head. And we are funded by 3 entities: Startup Health of US, and IIM Ahmedabad, and Venture East Hyderabad. Thank you. I'll be able to take
just one very quick question. In the model that you mentioned, even when you're tying up with the hospital, are you providing the services behind the scenes, or is
so we typically end up running, even though we provide an admin dashboard and create an account to the hospital, asking them to run the service by themselves. Typically, we end up running the service for the hospital from the back end. Yeah.
Thank you.
Yeah, thanks.
Okay, the next, only 2 more to go. So last one, second last one is Mediocre.
No problem. Life, learning, and living before disease, decay, and death. We've been hearing a lot, so I think it's my task is made actually easy, because the keynote speech yesterday by Dr. Rob Jesse started off by saying that individuals need to handle their health, and also Tushar made it very easy for me, talking about preventive health, and Mohan talked about bringing efficiencies in the medical eco or the healthcare ecosystem. That is what we actually do. The 3 things that Mediocre, the modern healthcare platform, does. One, it basically connects the individual with the entire healthcare ecosystem in a unified process. I think the key word here is process management. At the time of being connected, it delivers intelligent contextual content for each one of these stakeholders to make intelligent decisions. And as a consequence of it, the 3 things we have heard, a plethora of technologies, a plethora of devices being talked about. So the one thing that is missing, and not just in healthcare but in most industries, is integration between health, medical, and information technology. And those are the 3 things that we end up doing on the Mediocre platform. In terms of, I'm really not going to spend time talking about any of our mission or vision, but essentially, I think the one key thing that we keep talking about, we talk about health, and then we talk about medicine, and we talk about hospitals, and we talk about doctors. The primary focus of Mediocre is first and foremost to get an individual to understand that health is a personal management process. And that should be something which is from the time that a person is born till the time that a person dies, that he or she is able to manage their lives more responsibly with respect to health. In terms, and again, product architecture, one of the key things that we've talked about, and this is something that concerns everyone, there is a great amount of discussion about security. So we built in identity and access management. This is perhaps for the first time that it's going to come up anywhere in the world. Process management. Essentially, we talked about, there is a lot of discussion that's gone on about how content and knowledge can be reposited. And we intend to purpose it using metadata in terms of being able to manage it at the time of transaction. And essentially, one very important thing that I would like to sign off with is the fact that, you know, we keep talking about big data, and we also keep talking about business intelligence. But what's absolutely key, especially in healthcare, is cognitive intelligence, which is this experiential intelligence, which essentially gets developed when you're able to work on an electronic health record, which becomes the only true guide, which is basically data that's generated from birth until death. Now, I know the questions that can come up is, how does this happen? That what we tried to do, we are a company that started in January 2012, and we started development in April, I'm sorry, I lost that. We started 2015. I'm sorry, I lost track of time. January 2015, we started development in April 2015. And what we have done is we have tried to prove our concept by going to a village, which is Satanuru in Mandya district of Karnataka. We adopted the village. We are creating 10,000 electronic health records of the inhabitants of the village. And in the process, we are training more than about 5,000 volunteers who are also creating their own health record as a means of developing in training the villagers. What we want to prove here is that when you have your health record, and then as a consequence of it, we also launched a cycling event to generate funds. So we just didn't want this to be a tokenism. We want to be able to raise funds, and whatever we come up with in terms of, we already know that waterborne diseases are the key. There is tuberculosis and there is HIV/AIDS. So essentially, we want to be able to generate those funds, be able to bring about a substantial measurement with respect to reducing non-communicable diseases, being able to show how a healthy lifestyle can improve. Why are we doing this? Because the more affluent, the urban, the educated ones are very arrogant to understand the concept of owning health as a personal concept. And by being able to show this from a place that is possibly impossible, you know, make it happen in the society and make the urban, the affluent, the educated, be able to take health responsibly. And if somebody can basically upload on Facebook the daily events of their lives, I'm very certain that if health is really important and it depends, your life depends on it, you will be able to upload your data with respect to managing and maintaining it over a period of time. So our company is not just an electronic health record company. It basically is the base data on which content, knowledge, and metadata can reposit and enable a process to interact intelligently across the ecosystem of healthcare. Thank you.
Yeah, sure, thanks. Tushar, basically, keeping the business model issues aside, what advice do you think you can give for folks who try to use technology to improve adherence, compliance, and so on and so forth, right? Because that's essentially kind of what you guys are trying to do too.
I think the hardest part is getting the users to give and track data. I think that is extremely hard. So most of us, who make behavioral decisions, most of the times are aware of the consequences that are there at a tertiary level, right? But they may not be using that data to make active, conscious decisions right then and there. So to be able to enable that, I think one of the things that helped us certainly is getting users to track what they are doing from a lifestyle perspective and then giving feedback. But user inputs is extremely hard a problem to solve. So, whether it was the person who was getting, diabetes people track their glucose level, I think you heard compliance issues. It was, the parents' problem as well. Getting users to track is very hard. So the only way to enhance that is by giving extraordinary value to the user for anything that they track. So at least in our company, if a user gives us data, a data point, it's as important as paying us. So, so whether the user is giving 1 rupee or 1 data point, we consider it as valuable, right? So we give back a lot of value by insights, information, advice, connections, context, etc. So I think increasing the value to input ratio is something that helps businesses and helps consumer behavior too. Yeah.
Okay. Thank you. Okay, the last one is BizInfo.
Good afternoon. My name is Vishwas. We are providing an app-based clinic management solution, and we are challenging the concepts of the cloud itself. Basically, the reason why we are moving to the cloud is because of the cost of the hardware and the maintenance of the IT infrastructure. What if I tell you that I can provide an entire application on a small tablet? I can make the tablet itself as a server and provide the clinic management software on the tablet, and through which, your clients, basically your client as a doctor, as a patient, or as an admin or reception can access this server. So that's a concept that we're using, that we are running the application software on the tablet and giving the facility of access of this application by the patients, doctors, and the reception admin. So what does this software do? It does the scheduling, prescriptions, billing, record keeping, and yeah. So the concept here is very simple. There is a tablet on which the clinic management software is running. 247 Doctor Care is the name of the software, and which is accessed by the doctors, patients, and admin. So what patient does is whenever he wants to book an appointment at any point of the time, he just opens his app. He has to download an app. So he books an appointment. It can be done through SMS or an app or through web also. And he has so many other features. He can see the history of his appointments. He can see the history of the progress that he has made, etc. Doctors can view their appointments for the day or any specific day. The doctor can reschedule their appointments and inform the patients about the rescheduling of the appointments so that patients can rebook on a different date. Then they can configure the working hours. If they are working from 2 to 5 with a time slot of about 5 minutes for every patient, they can break the time and make that time available to the patient. And that is published on the server, which can be seen by the patients, and based on when the doctor is available, patients can book appointments. And he can set availability, and then there are in-app applications. Then admin can do a lot of functions. He can register the patients, they can create the billings, he can manage the drug inventory, billing, admin scheduling, and inventory management. So all these applications are available on a simple tablet, which can be accessed as an app by those 3 clients. So this is a typical picture of by a patient booking an appointment with the doctor. You can see the screen there. And you can book the appointments through SMS or through web. These are some of the screenshots of the web. A doctor can give the e-prescriptions. They can do the e-billing. The reception or admin can do the e-billing. And this is our roadmap. Right now, we are in the phase 1. We introduced this product about a couple of months back. And there are some pilots happening. There are no customers in India, but there are 2 or 3 pilots happening in Singapore and Malaysia. In the second phase, we want to give a comprehensive clinic inventory management and medical device integration. In the third phase, we want to integrate an EMR and also to a feedback system with the patients. Thank you.
Okay, thank you. Okay, so I think that concludes the set of startups that we're presenting. So I think thanks a lot for Tushar, Mohan, and Lisa for helping us out with this. And I think, Arvind, I hand it over to you for the concluding piece.
Madhu, thank you very much as a token of our gratitude to the panelists for taking your time. And, we really enjoyed your presence here, enjoyed having you here. A small token of our gratitude, a memento to each of them, please. Madhu. And Madhu, thank you very much for hosting the session. And as our token of gratitude, can I request the CIO of Columbia Asia, Ashok, to hand over memento to you. Thank you. Ladies and gentlemen, thank you. Thank you very much. We've enjoyed bringing the 6th edition of the Transforming Healthcare with IT to you. We've enjoyed the hospitality of the city of Bengaluru, and I must say you've been a fantastic audience. Thank you very much. A big hand to all of you, please. Thank you to my organizing team. Without you, I'm sure nothing in the stage would have moved. Thank you very much. Please do send your feedback to us at the scientific committee sc@transformhealth-it.org. We'd like to hear your views. The 7th edition of the Transforming Healthcare with IT will be presented to you in the wonderful city of Hyderabad at the High Tech Convention Center. We'll announce the date shortly. Mark your calendars. We look forward to seeing you at Hyderabad next year. Thank you very much.